representing the team from Bulawayo. And this debate, we are actually supporting gamete donation. So as an introduction, I want to define gamete donation as a form of third-part reproduction where baby is born from all sides of sperm from a source other than the couple. There is no genetical relationship between the offspring and one of the couple or both. In a situation whereby you are using actual embryo donation, there will be no genetic relationship to parents. So sperm insemination has been there a long time. I checked the history, they actually say 1881, people were doing sperm insemination. But the first documented case of oocyte donation in assisted reproduction was reported in Southern California in 1984. It was a very, very clever technique. If you have a chance, you can actually read that on sexual reproduction menopause. In America, the Society of Assisted Reproduction estimates that more than 18,000 donor cycles are done.
Can you hear Jeff?
I think some technical challenges there. Let me actually call him.
Yeah, so sorry about that. I think someone muted me, but I'm back. We have explained that the teams are mainly one for gamete donation and the other one for adoption. No, it's freezing. What's happening? Okay, we're going through the slide where we define gamete donation as a third-party production where the baby is born from oocyte or sperm from a source other than the couple. And then the genetic relationship between the offspring and one of the couple is absent. And then I've also spoken about the first case being in 1984. That's the first recorded case being in 1984. And that in America, about 18,000 donor cycles are done, resulting in between 9 and 10,000 babies. And I've also spoken about the types of donors. That's the anonymous donor. This is a donor where the identity of the donor is not known, is only known by the clinic and maybe the agents. And the recipient is only given a limited amount of information about during the selection process. And then non-donors, this is where a recipient will bring a relative or a friend who they have selected to donate for them. And in this group, there's this special group called intergenerational donors. This is whereby donors, a recipient will bring a close family member, even a child or a parent. And in this survey in 1992 in America, they found that it was quite a very common, it was a common practice. In oocyte donation programs, it was occurring in almost 40% of the times. And in sperm donation programs, about 26% of the times. including child-to-parent donation and parent-to-child donation. Non-donors are a very, very controversial subject in gamete donation. Clinics usually formulate.
So it's okay.
In clinics, usually have to formulate policies that will actually allow control of this. In our clinic, we don't allow child-to-parent or parent donation. What is donated? The oocyte can be donated. Here, in this case, what happens is that the ideal donor is pre-screened for genetic disorders, mainly from taking history, and infective disorders. Then the oocytes are obtained from the donor after a controlled ovarian stimulation. So the donor actually goes through a stimulation process, just like a woman who's going for IVF. And then the oocytes that are retrieved from the donor are fertilized using partner sperm, that is in heterosexual relationships, and donor sperm in same-sex relationships and single ladies. During the process of stimulating and preparing the donor, the recipient undergoes preparation of the endometrium using estrogen and progesterone, and then will then go through an embryo transfer. The resulting baby obviously will not have any genetic relationship with the mother. Then in sperm donation, this is usually indicated where there's severe male factor infertility. Donor sperm is collected using masturbation, and then the sperm is washed, and then an IUI can be done. That is if the recipient has a patent tubes and so on and so forth. And then if the IUI is not appropriate, then IVF can be done. Embryo donation. This is whereby an embryo which has been prepared using donor sperm and donor oocytes are transferred to a recipient. And in this case, obviously, there's no genetic relationship with either the recipient, with any of the recipient parents. So in terms of indications, obviously, there are some ladies that have premature, supposed to be premature ovarian failure, and postmenopausal women, cancer ladies, where you end up removing the ovaries and leave the uterus, and the recurrent IVF failure, and same-sex couples, carrier of genetic disorders, severe male factors. So these are the usual indications for gamete donation. And the last one, which I've highlighted, is elective gamete donation. This is whereby clinics have sort of set up age limits to say, if a woman is above the age of 42, we're not going to waste time and try and stimulate that woman, because we know the reserve is low and the risk and the rate of failure of that process is quite high. In our clinic, we don't usually do that. We go through a counseling and offer the patient the choice, decide whether they want to go through IVF, even if the age is not right. We give them the evidence and they make them decide. I have had a patient who was 45, and I told her that it was not going to succeed, but at the fourth attempt, she actually conceived with her own eggs. So what are the benefits of gamete donation? To the recipient, it allows a potential parent not capable of producing any gametes of her own to be a parent. The baby that is born from a gamete donation is genes from one of the parents, and it allows a woman to experience pregnancy. My educated colleagues, Bismarck and Gerald, will tell you about adoption. So in gamete donation, you actually see the pregnancy. The family will see the pregnancy. The society will see the pregnancy. And during the antenatal period, the woman is able to prepare for the coming baby and alter her lifestyle during those 9 months and antenatal visits. She'll be able to say, okay, there's a baby which is coming, and then prepare herself. And then pregnancy also allows the baby and the mother to bond. And most importantly, childbirth. If you're going to do a Caesar, which is going to go through labor, the bonding is increased. So those are the advantages of using gametes, donated gametes here. What are the drawbacks? The mother might feel that the genes are not hers. And certainly in sperm donation, this has been found to be a problem, that men don't bond quite well with these children. And then in unknown or anonymous donors, she might not be able to determine the ethnic background of the donor. And then there's still a high risk of IVF cycle failure and the cost of the treatment. However, the pros outweigh the cons, especially with egg donor use. What about the children conceived from donor gametes? There's an excellent article on fertility sterility of 2015 September. They did survey scores on these children at 3 years, 7 years, and 10 years, and found that the scores for these children were within normal range for normally when compared to normally conceived babies on emotional symptoms, conduct problems, hyperactivities, inattention, quality of peer relationships, and pro-social behavior. They further on assessed the mother-to-child relationship at 3 years and found that they were also comparable to normally conceived babies in warmth of the relationship, the amount of time and enjoyment in joint activities, and the mother's ability to recognize and respond to child's needs or the level of mother-to-child conflict. So in these babies, even in my experience, we found that the way they relate, somehow, I don't know what happens. The baby usually resembles one of the parents. If you're using donor eggs, you find that most of these babies have been surprised. They look like the father. And the bond between the mother and the child is usually very, very good. Then in terms of use of unknown donors, there are contentious issues, one of them being disclosure versus non-disclosure. So these babies, eventually when they grow, the people who are into ethics propose that they ask themselves, who am I? And they propose that not disclosing actually causes harm. And the question is disclosure really ethically necessary? Is there a real right to know? In America, the ethics committee actually recommends that you have to disclose, and the disclosure rates in America are as high as 78%. In the UK, from 2005, there is now a provision to give information, and that information starts at 16 years. At 16 years, the child can actually access the information on physical characteristics of the donor. And then full disclosure at 18 years. That is, at 18 years, the child can actually go and get information about the name of the donor, the last known address of the donor. In our clinic, we've got very, very strong consent forms and agreement forms, both for the recipient and for our donors, that were against disclosure. And our agreements actually say that for you to get that information, you have to go through a court process. What about other issues? Issue of advanced age recipients. There are more and more women who want to have babies. Some would have maybe missed the opportunity whilst they're pursuing careers. And some maybe at the time when they wanted to have children, the technology was not there. The oldest known case of a recipient is about 65 years. I'm sure they'll be older. The advantage for these special recipients is that by using donor eggs, you avoid the chromosomal disorders that are associated with old age. But there is some evidence that the baby is born from these elderly patients have got high rates of prematurity, IUGR, stillbirths, and paternal age-related congenital anomalies. The long-term effects are not clear. And then the question then arises, should there be an upper limit to say, if you're older than 65 or if you're older than 50, you cannot receive donor X? Such limit doesn't exist, and in most cases, it's a clinic-to-clinic policy. In Zimbabwe, we try to have some sort of council-coordinated committee that looked at use of donor gametes. And then when the topic of age restriction came, there was no agreement. So we still don't have an upper age limit. And such a limit probably will be biased and judgmental. You can donate the whole oocyte, but you can also donate part of the oocyte. This is just, might as well, it's just a parting shot. This case has actually was reported in the UK, where a lady had a problem with the mitochondria, and then a DNA nucleus put into a healthy mitochondria, resulting in a healthy baby. So it's a 3-parent baby. That's the article. So in conclusion, what are we saying? We're saying gamete donation might be a form of adoption in a way, but it has some added advantages. The process is scientific. The process is efficient. You hear when my educated colleagues talk about adoption. This goes to on and on. With gamete donation, when you come and see us, we screen you, we screen the donor, and then within 2 months, we have done the process. And the child that is born is genetic material of one of the parents. Pregnancy, childbirth, and breastfeeding allows for a better bond. And pregnancy might actually help that baby to be integrated into the family and society. Thank you.
Thank you, Dr. Moyo. That was a good presentation. Now we are going to introduce the team B, who is going to give us information on the other side of intervention, which is adoption. So Dr. Mateveke and Dr. Madzire, please take the floor.
Thank you very much, Chair. Let me just prepare, share my slides. Thank you very much, Dr. Moyo, for your presentation. You confirm you can see my slide, Chair?
Yes, I can see it.
We can see your slides. Please proceed.
Okay. Good morning, ladies and gentlemen. So on behalf of the Harare team, we are moving the motion that adoption is better than gamete donation. So we have called this third-party reproduction and comparing versus adoption. So I'll just stop sharing briefly. I think when I admitted a person, it doesn't allow me to continue. So Vincent, can you make sure I quickly admit your voice to be showing on my screen, or you can stop me being a host for now. Well, okay, so just as a background, we just want to share what is adoption. We all know that is the act of it's a legal act of taking another child and bringing it up as your own, or the fact of you being adopted. So if what a de facto adoption, that's when the baby is related to the prospective adopter parents. So you might be living with your brother's child, whom you then decide to make legal use, and then you actually process the papers. So there's already a relationship. We can have a de facto adoption where there's completely no relationship at all. The non-de facto adoption. And then foster care, there are no legal obligations. We do this commonly in our cultures. You can stay with your aunt's child or your uncle's child, but when it comes to them having to pay their fees, they go back to their parents for fees. Whereas in adoption, you take complete care of everything. The child becomes yours. You are responsible. They got the right to your estate. So adoption is governed by Children's Act, Chapter 5, and it has so many sections. Whenever I see a law with so many sections, it means there's got so many processes. So 57 to 85, these are almost like the sections which govern the various steps in the process. And then there are some implementing bodies. The law is implemented through the Child Welfare Council, through the Children's Court, and through the Department of Child Welfare and Protective Services. I'll just give you some snippets of the Act. So this Act, firstly, it does mention that the Children's Court has to be established to administer this adoption process, and then the court shall adopt a probation officer to act as a guardian, and then so an order may be made authorizing an applicant who is the spouse or the parent of a minor to adopt such a minor. So this is just talking about a situation whereby is when one is in a relationship with somebody with another child or with a child already, then you can get an order to adopt that child because the other parent or the real parent is in agreement. Can you please accept these people? I think they are blocking my view. The message on the screen. I think it's Vincent. Okay, so okay, let me just accept. Sorry about that. Okay, so this, now talking about restrictions to adoption. It cannot be allowed or automatically be allowed in people under the age of 25 years. And then there must be an age gap of at least 21 years between the person who's adopting and the minor they are adopting. Meaning if you are 50 years of age, you cannot adopt somebody who's 35 years. You need at least a 21 age. Of course, this brings to this job, which can also see where some women say marriage is just a fancy word for adopting an overgrown male child who cannot be handled by his parents. So I think the ladies will need to know that no, there must be at least a 21-year age gap between you and the husband for you to adopt your husband. So with my screen, once I admit people who want to go into the meeting, it won't move. So I will have to stop sharing. So I'll just stop sharing briefly and restart again. Okay, so going ahead again, looking at some of the restrictions to adoption. A male cannot adopt a female. A single male cannot adopt a minor female, but a single female can adopt a male child. And then adoption cannot be allowed if the person who's being adopted is not resident in Zimbabwe, or the person adopting is not in Zimbabwe. And then the minor being adopted has to be medically examined, and a copy of the examination must be made available to the court. And then adoption cannot be made if the applicant is not a citizen of Zimbabwe. But again, as you know, there is an exception to every rule. So the minister can actually bypass these restrictions. So what's the process of adopting a minor? So you need to go through the Ministry of Public Service and Social Welfare and get the necessary forms, which are then completed with all your details, your income, your accommodation. So really they vet you and see whether there are no known tendencies, history of abuse and so on. So they really evaluate the intentions, so as to speak. And then when that has happened, then one is placed on an adoption waiting list. And then whenever there's a child who needs adoption, then this can be availed, and then you make a final choice. And then after successful adoption, then it means you can be issued with new registration documents. So this again happens even when you're staying with a child or maybe a relative's child. When you adopt them, you can actually go and change their registration details, and they now they will reflect you now as the new parent. And again, what I think I needed to emphasize is you can actually adopt a child, or the so-called illegitimate child. Suppose a husband has got a child outside the union, and then if the husband can convince the wife that they can actually adopt that child, provided that the other parent is in agreement, then the law will allow that adoption process to go on. So I have mentioned third-party reproduction. Our team has preferred to use gamete donation. So this is a process involving someone other than the individual or couple that plans to raise a child in the process of reproduction. So like our learned colleagues have already told us about donated eggs, sperms, and embryos, and there's also the gestational care arrangements, the so-called surrogacy. We are then now also moving this motion and saying adoption is a part of third-party reproduction. And then we do admit that there are definitely many equivalents. We know the main goal, or also one of the top priorities for many people, is to have a child and to have the experience of parenthood. So this is an equivalent between adoption and gamete donation. And both of them, they share the complex process in making decisions, more so in cultures like ours, which are very restrictive. People would want to know the totem of the child they're adopting and so forth. So it's very complex. And then the process also are emotionally draining. So this is equivalent whether you're doing gamete, embryo transfer, embryo donation, and so forth, and adoption. And then the issues of disclosure, like what Dr. Moyo has already said, it's also quite a big issue because at some point the children might want to know who their parent is, or they get to know that they're adopted. Do you tell them that you adopted you? And of course, it depends at what age. As a baby, they might not know that they're adopted, but if you adopt them, let's say at the age of 10, 15, then they already know that now they have been adopted. I did look, our law does not specifically, they don't give an age limit for who can be adopted. The only thing they mentioned that there has to be a gap of 21 years. So I assumed a 71-year-old can adopt a 50-year-old, and it means the law would allow such a thing. And then another equivalence that matching can be done in both processes. You can look for phenotypical features which you would want if you want somebody who's black hair or certain height, so that there is some resemblance. And I think likewise, like what Dr. Moyo was saying, that there seems to be already some default matching which happens by when the children are born. They tend to look like the other party was not genetically genetically connected. And then in moving our motion, why we think adoption is better, we are saying adoption is taking an already born child. Our learned colleagues have really told us of very complex processes, but for us, mere mortals, simple people, we are saying why not just get the child who's already born. Pregnancy is a complex process which is really selecting out an offspring. So you don't have to worry about prenatal genetic diagnosis and so forth. You just look for the child who's born. And also a child who are parentless and a couple of persons who are childless, usually due to unfortunate circumstances, are given this automatic opportunity to have a child without having to go go through a lot of costs. And then adoption does allow those who have got no chance of falling pregnant, either due to pre-medical conditions, to experience childhood. So this could be actually people who have had recurrent failed IVFs, or those who don't even have the reproductive organs, like in Mullerian agenesis. You can have a male with azoospermia, and then the female partner has other serious problems. So they can be very complex scenarios where it might be way easier just to go ahead and just get a child, and even forgo the agony of looking for a surrogate, which is very difficult. So the only experience which is not gained in adoption is childbirth and nursing. But we know nursing, we can actually get the mother to suck the baby if they're going to adopt a young baby. But sometimes if they're adopting an older child, then that's not possible. And then when people adopt this way, you have the joy and the anxieties of watching children grow. They go through all the experience of children being naughty, children failing, and those, and they are going to enjoy all those processes. And then children identify with and often love their source of support. So children are just like animals. Those of you who look after dogs, they will love you because you're taking care of them. So I think we think that even when somebody adopts a child, they will still be able to bond and be so intimate because of the love they will be showing that child. And then one of the biggest effect, I would call this the fulcrum of our motion, is our success rate is almost 100%. When we want to compare it to the IVF process, which our colleagues are proposing is better. Sorry, so I think we'll stop the argument at this point now. Just allow the chair to go ahead.
Yes, thank you, Dr. Madziwire. An interesting talk indeed. Now we are going to introduce the other side of the debate, debate rebuter. And Dr. Rambani Pasi representing Team A, or Dr. Moya, I'm not really sure who's going to take this. Please, you can take the floor.
Thank you very much. My name is Dr. Rambana Pasi. I'm based at UPH in Bulawayo. I'm part of the Team A. So we're going to be talking about the other side of adoption. So Dr. Madziwire has done very well in terms of supporting adoption. I'm going to give some of the points against adoption. Hello, can you now see my screen?
Yes,
hello.
It's quite clear. Yes, we can see your screen. It's clear. Please proceed.
Oh, okay. Thank you. Thank you. All right. So I'm going to be talking about the other side of adoption. Let's talk about the timelines. Like Dr. Madziwire has already highlighted, the process of adoption is quite tedious. It's quite long. There are a lot of steps that are involved. He highlighted that there are a number of sections that in the Constitution that govern the process of adoption, and you have to move from one office to another. A lot of bodies are involved, and that process takes a lot of time. The situation is made worse if there are if there's international adoption, where you want to adopt a baby from another country, and there could be differences in legal frameworks and all. Like I've already said, the paperwork takes time. The legal processes, as we know, they also take a long time compared to gamete donation, which you can do and complete in about 2 months. The process of assessing the potential parents, because you don't want to throw a baby into an unsafe environment. So you really have to take time to assess the potential parents to see if they can ensure a safe environment for this adopted child to grow in. That process takes, you're not going to do it overnight. It takes a lot of time. I've got a patient who has been trying to adopt for the past 2.5 or so years. She still hasn't managed. If there's a lot of traveling involved, for example, in cases of international adoption, there are a lot of costs that are involved in it. It might actually cost more than a donor IVF cycle. There is no chance of genetic relationship between the parents and the adopted child. This is in comparison with gamete donation, like what Dr. Moyo has already highlighted, that in some cases, at least one of the parents may have a genetic relationship with the child. In adoption, that is not possible. The fact that there's no bonding because of pregnancy and breastfeeding, that has already been highlighted. Adoption process is not 100%. It doesn't always succeed. The adoption process can fail at one of the many stages that are involved, and the baby may have to be returned to their foster home. It occurs in about 1 to 2%. And the older the child is, the higher the chance that that adoption may actually fail. If you're talking of infants less than a year, then disruption can be 1%. But if you're adopting someone over 5 years old, the chances of failure, they go up to more than 26%. And the main reason why these older children are a problem is because of in cases where there's institutional upbringing, because it predisposes them to some psychological disorders. But also some characteristics of the adopting parents and the agent that is involved, the agents that are involved may also play a role in adoption disruption. So if a child is, if the process doesn't go through, the child might actually feel that they've been rejected, and this may have devastating psychological effects on the child. Okay, that slide is showing us some of the reasons for adoption disruption. There are many of them as shown in that slide, ranging from the parents unable to deal with the child behavior, difficult attachment, verbal abuse, neglect, and so on, and so forth. You may also have some psychological problems following adoption. This is more like what happens in postpartum depression, where you have the adopting parents sinking into a depression. It tends to occur about a month after the adoption. It can be as high as 63%, but it's not usually recorded. There are a number of causes why these adopting parents may sink into a depression. For example, they might find that what they thought the process would be like may not turn out to be like that. The expectations may not be met by the child, and if instant bonding is not realized, that's supposed to be realized, and if love at first sight fails, so the patients, the adopting parent may actually experience some psychological psychological problems. And then there could be apprehension. You know, the adopting parents are maybe worried that, is this really a good idea? Will this sort of love and attraction last a lifetime? People may be worried about that. Okay, I might be happy to adopt now. I may be happy with the child that I've adopted now. Will I feel the same after 20 years? Is there a chance that those birth parents who are giving away their child may wish to reverse the process, the legal implications of that might cause people to be worried? The process of adoption is not always inclusive. Like Dr. Mazvire has already highlighted, there are a number of groups of people that may be excluded from adoption. He talked about, for example, if you're in a gay relationship, or if you're a single man, you may not be allowed to adopt a girl child. So those people in those categories are automatically excluded and denied a chance of being a parent if they are looking for a girl child. And then he also talked about those younger people who want to adopt. Yeah, you're only allowed to adopt if you're above the age of 25. What if I'm 23 and I now want to start a family? It's automatically excluded. And that age gap that he mentioned between the parent who wants to adopt and the child to be adopted for about 21 years. All right. And then usually the birth parents, the parents that are giving away a baby for adoption, who feel very good that they have given this this child an opportunity to be raised in an environment that gives them a better chance in life. That's the usual arrangement. But in some cases, the birth parents who are giving away the children may actually have feelings of guilt that they have neglected or abandoned their child. So there are these feelings of guilt, there are feelings of grief or denial, and that might actually cause mental illness in the birth parents. There could be problems with adjusting and identity confusion in the child who is being adopted. You know, this change in environment may be stressful. It may be very difficult for the adopted children, and to learn to get used to a new environment, it's quite a challenge for the children that are being adopted, and that might cause psychological problems as well. And if let's say the adopting family already has other children, maybe they have a genetic relationship with the adopting family. So these children that are being adopted may not feel like they are equals to the other children. They may feel like they are not family enough. So this makes them feel insecure, and it might lead to depression in the children being adopted. The issue of identity crisis, particularly around the adolescents, it might cause confusion in the adopted children, especially if the children were adopted when they are slightly older, 10 going upwards. They might have problems then. Now, if you Dr. Mazvire talked about the fact that you are getting a child already born, which may be good, But the problem is you don't know, you may not completely know what this baby went through, what this child went through to get to the age of 15. You are not aware of how the antenatal care was. Are there any identifiable factors that were neglected during pregnancy? Things like smoking, alcohol, drug abuse. You may not know that the baby was exposed to some of these things in utero. Even when they are born, psychological trauma, you may not know that this baby has been traumatized. And then you are adopting this baby who later develop psychological and mental problems because of past events that you may not be aware of. Let's look at the attitudes of our African society on adoption. In Africa, in an African society, a woman proves herself to be a woman by motherhood. The same applies to a man. You prove to be a man by fatherhood. So if you are known to have adopted, it might affect the way society looks at you. In some societies, children are a form of wealth. So if you're unable to, if people look at you and they think you're not able to have a child, then it becomes a problem. They look at you as someone who is poor. Accepting a child without due process is met with skepticism and may not be able to solve the problems that women face. And then, sorry, there's a typo there. So traditional practices and beliefs might lead to the child not being welcomed by the extended family. So that's about all that I've prepared. So in conclusion, adoption is a valuable option in finding homes for children in very difficult situation. But let's not forget the ill effects of adoption. But where everything has failed, adoption remains an option. I thank you.
Thank you, Dr. Rambanepasi. I'm almost sold out. So I think Dr. Matebeke has to do has a tough task ahead of him. Dr. Matebeke, if you can take the floor.
Okay, thank you, Dr. Mchanga. Dr. Madzire, if you can share the screen for me. Dr. Rambanepasi, you might have to unshare the screen for this to happen. Hello, Dr. Madzire. So yeah, while he's sharing our screen, I'll just say I think very interesting discussions happening today, and I think Dr. Rambanepasi, you've really done very well in trying to push the motion for gamete donation. But I will try to just also bring to the fore the fact that adoption as an option for making sure that couples have children would probably be better in our scenario. I'll start by commenting on intergenerational donors. I would say there is quite a whole lot of ethical dilemmas associated with the practice, particularly if you are looking at change in family dynamics, so to speak. You might agree that yes, let's help our sister to have a child, and let me assist by giving her my eggs. But you find that family dynamics can actually change, and what is the impact of this practice going to pose for the born child out of this practice? So there's really a serious ethical dilemma associated with such kind of practices. I would also say that if you are looking at the issues of using donated eggs, embryos, and the like, for it to actually eventually produce a baby, the level of stress and anxiety associated with the actual process of having to prepare this couple. I think Dr. Moyo did give us a synopsis into the processes of IVF, intrauterine insemination, and the like. The preparation and the amount of interventions when it comes to trying to get this process to work is associated with a lot of anxieties, associated with a lot of challenges when it comes to potential complications. We worry about side effects that essentially include, for instance, ovarian hyperstimulation as a result of trying to have these eggs in these women, and the medications are also quite very, 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 very costly. You also find that there is no age limit to adoption. Dr. Madzivire did highlight a little about a 71-year-old woman having to adopt a 50-year-old man. There is really no age limit, but you find with IVF processes, particularly when clinics are focusing on success rates, for instance, because I think as we speak, most clinics are so fixed on their success rates in order to sell out what they do that they sometimes put these age limits to make sure that they screen sort of away those people who are much older and whose chances of possibly succeeding after the process. Hence, it's sort of like becomes a little bit discriminatory, but adoption does not tend to do that. We have talked about the expense, right from the cost of the follow-up and the cost of the whole process of having to use these gametes and the processes of IVF. I think everyone here agrees that an average person walking in the street may probably not be able to afford IVF, particularly within our setting. Most medical insurance companies do not cover IVF processes. In the first world, I'm sure they have tried. You will find that maybe in the UK, NHS may be able to cover maybe 1 or 2 cycles only. But in the rest of the world, most of these insurance companies are not offering any form of cover for patients wishing to have children to undergo these processes. Adoption, you don't need any medical insurance. We just have to follow the due processes laid out by Dr. Madzivire before. And yes, there's essentially no need for you to be paying out a lot of monies. I think Dr. Rambanapasi did point out potentially that adoption, particularly if you are going to be adopting somebody not from your own country, the traveling and the like. But look, we are now in the 21st century. And I think we're having an online CME right now, and most of these things may actually be done online as you go through the processes, and probably you might just travel once or twice. I don't think it can ever compare to the cost of having 1 cycle of IVF. We have encountered lots of patients because you find without adequate counseling, most patients who are coming or going through these processes believe that if I am going to go for IVF, then I'm going to have a child. But we all know the success rates of IVF the world over. And we have seen patients hopscotching between IVF centers after a failure because of the stress involved. And, you know, the feeling of having probably failed, because if you find a couple coming for IVF, they would have failed to achieve a baby naturally, and it's probably their last hope. And when it fails, it causes a lot of psychological stress within the patients or within the couples themselves. And yeah, children born to a complex sort of like family set, I think Dr. Manzire did allude to this potential dilemma well before. And when you are also looking at the issue of aged parents, I think Dr. Moyo, you talked about the oldest being 65 years old, having to carry a child after IVF through embryo, embryo donations. I remember my own uncle at some point who had a child later in his later years, and they were trying to visit their child at boarding school, and he was being introduced as this is my grandfather, so to speak, because the child was a little not comfortable in actually telling their peers that, look, this is actually my father, just because of the complexity. So you can imagine getting a grandmother to have a child at 65 years old. The relationship definitely is not the same as, you know, in the normal setup. And like we said before, it's quite very tedious and also very expensive. And yeah, the issue of what you call it, the success rate. So I would say within our setting, we do believe that yes, IVF does significantly help. Using donated eggs and gametes does significantly aid in achieving setting up a family for a couple, in them having a child. But I think donation, or sorry, adoption seems to be probably far much easier in setting, far much easier in trying to achieve this. I think I would rest my case at this point.
Thank you, Dr. Mateke. For a moment there, I thought you were sold out for donation, but you did indeed took the debate head on, the challenge head on. What we are going to do now is we are going to allow Dr. Mhlanga Felix to present next. Dr. Mhlanga, please, you can take the floor. Then I will open the platform for questions.
Thank you, Mr. Chair, and welcome everybody. A very good morning to you. I'm trying to share my screen. What I thought we would do in the next 20 minutes, I hope you are able to see the screen. So I'm going to talk about approaches for treating endometriosis in subfertility. This is really going to be a brief summary, because in the 20 minutes that I have, it will not be possible to go through comprehensively all of the issues involved. The issue about why we're discussing this is such a common disease now, and you know, in up to 15% of the reproductive aged. And when you look at people asymptomatic, it actually can go as high as 50%. If you look at it the other way, in women with endometriosis, 30 to 50% of them may have endometriosis. So our challenge in Zimbabwe is we don't collect our data in a very systematic way with the view of publishing it. These are two dissertations that were done by colleagues who are probably on this call. The memory noted 15.7% cases of endometriosis when she followed up about 106 participants who were having chronic pelvic pain and diagnostic laparoscopy. In Dr. Machakaire's series, there was hardly anybody with endometriosis in his cohort, but I think it's a function of time and the kind of equipment that is becoming available. So I won't go into the details of endometriosis, just to say I'm used to the American Society of Reproductive Medicine's classification. There are several other classifications that look at how do you characterize endometriosis? Because when you have discussions like these, it's important to be talking the same language. So because the literature is awash with the ASRM classification, that's what I will use for the purpose of this discussion today. So you see the different forms of endometriosis. You can get it as superficial, like you can see here. You can get it as beginning to get really severe. You can get endometriomas, which you can probably just make out on this picture here. So these are the various facets that we will need to say briefly, how should these be managed? And I'll give you case examples. So does endometriosis itself cause subfertility? The answer is, to a great extent, yes, and the mechanisms are different. When you get this inflammatory response, you get a lot of prostaglandins, metalloproteinases, macrophages. The sum total of this is to affect the implantation or the folliculogenesis, resulting in poor fertilization or poor implantation. So that's the bottom line on why we need to really look at endometriosis as a possible contributor to subfertility and therefore intervene to correct things. For example, in this paper by Toya, I've just left them there so that people can take time to read about them. They took macrophages, I mean, they took granulocytes, fluid from the granulocytes, and looked at whether they developed correctly and compared them in terms of from those with severe endometriosis, from those with mild endometriosis. And there's actually evidence that it interferes with the replication of the cells. So that's how this evidence is derived. And I urge you to find some time to go through these papers. So with advanced endometriosis, it's probably understandable that when you get endometriosis, you're going to distort the pelvic anatomy, you're going to impair the system that picks up the oocyte. And again, those factors that I described in the previous slide come to play in terms of the inflammatory response and how it impacts folliculogenesis. So in my mind, it is very clear that you need to intervene where there's endometriosis, but we need to look at what is the best practice level of intervening. So the bottom line is, who should get fertility-related surgery? Is it everybody? Is it someone with mild disease? And what does the evidence say? So I will have some literature quoted at the end, but we clearly don't have time to go through each individual paper. But what the evidence suggests is those who are symptomatic and those who have not had primary surgical treatment, if they are symptomatic, or those with symptoms with findings suggestive of endometriosis should actually be treated. And the bottom line is the primary surgical treatment is associated with the best treatment outcome for both the pain and the chances of fertility. So if you are not comfortable doing the primary surgery, it's probably not good for you to attempt excising the endometriosis. It's probably best for you to send this patient to centers that have expertise to be doing this. But what is clear is primary resection or ablation of endometriosis is associated with higher outcomes compared to diagnostic laparoscopy only. And this is one of the papers that speaks to it. I would also urge you to go and read it in your own time. This is an update on the original review paper that was done comparing 382 surgeries, looking at those who had just diagnostic laparoscopy versus those who had actually the treatment offered in terms of the excision of mild disease, either by ablation or by excising them. So in this paper, it actually had an odds ratio of 1.9 for almost twice the improved outcomes in those who had surgical treatment compared to those who just had diagnostic laparoscopy. So when you compare the mechanisms of causing disease that I told you, which is the inflammatory response, it probably makes sense to understand that when you excise this disease, you reverse that process and you're unlikely to get that interference with fertility. So it does make sense in people with mild disease to excise the disease. So I'll give an example of what can happen, because this happened to me when I got, in October 2017, a 28-year-old who had a fiance, was 34. She had chronic pelvic pain for a very long time when she was studying in South Africa. And when she came to me, it was in the context of this pain having worsened in the previous 4 months. And she had a scan that had said she probably had a 4.8 by 3 centimeter ovarian cyst. In the discussion, you could sense that this was somebody who was very switched on in terms of, I'm not getting younger and I'm getting these pains. Maybe they might interfere with my potential to have babies in future. So, she was really edgy and saying, before I settle down, can you convince me that I might be able to have babies, because I really want to be able to have babies. So we then had to do a diagnostic laparoscopy on the backdrop of, I think she had things that she was not comfortable to share, but she suspected that this pain could have caused some problem in her settings. So you can see that when we did the diagnostic laparoscopy, there was no cyst. Probably it had hemorrhage, I don't know. But we noted that she had bits of superficial endometriosis, because with the time we wanted to get a histological diagnosis. So we actually shaved it off and submitted it for histology, so that we could get clear confirmation. But in anybody's book, if you look at this is an endometriotic lesion. We don't have any doubt about that. We actually then proceeded to do dye studies, because she was concerned that she was not getting pregnant, without going into the details of her reproductive activities. So at the end, we actually did a lap and dye study for this particular patient, following the taking of this biopsy and removing the macroscopic additions that we could see and we thought were related to the endometriosis. So we shaved a lot of the visible additions. You probably see them better on the left side, because here we'd removed a couple of them already. When we had this discussion, you see as the video progresses that there is a bit of a fibroid on the other side, and we had to go and have a discussion with her to say, you know what, you've got yeah, that's the small fibroid. You've got a fibroid, you had a few adhesions, but they were not that excessive. You have to use this in making your own decision on what you want to do moving forward. So this was shared honestly. I'll just speed up this because I don't think we've got a lot of time. So I wanted to show you the end where we did dye, and you could see that it's spilling on the left side, but none on the right. So we finished off and had this discussion with her to say, my findings were there was a bit of endometriosis mainly on the right side, few adhesions that weren't much, but we just removed them because we had the opportunity to do so. And we noted a fibroid, and there was no diastole on the right, but on the left. So what happened was, I think they used this information, and I remember speaking to Dr. Hukuime, who was joking that they must have resumed sexual activity on the ward, because when she got back to me, she was now 6 weeks pregnant, and her LMP was just 3 weeks post-surgery. So you can clearly see how some of the counseling we do influences people to act. She got married, she went full out to plan a baby, and she was lucky that she conceived. This is another example, but I probably would not go well, and it's courtesy of Dr. Dragana, who did a diagnostic laparoscopy and saw endometriosis. It's just showing a different way of treating endometriosis using ablation. So I'll skip this. So how about with, what should we do with women who have got endometriosis and they're actually endometriomas? These are actually common, and I say this because there's a lot of scanning that goes on in our settings, and it's quite accurate, and most people who are good at it can diagnose an endometrioma. So you probably see a couple more endometriomas. But the guideline is, it's suggested that you should proceed with assisted reproduction if you have got somebody with an endometrioma, except if you've got the endometrioma that you think might interfere with oocyte retrieval. And the reason is to do with, when you treat the endometriomas, sometimes either in error or poor technique, or the surgery itself, you can decrease significantly the ovarian reserve. And you also could cause a lot of adhesions that interfere with ability to conceive. So that's why most people would suggest that if you find an endometrioma and the other ovary is normal, it's probably best to just go straight for assisted reproductive techniques, especially in those above 35. So I'll show you again, Dr. Dragana kindly agreed to share with me her argon laser treatment of an endometrioma. The bottom line is you must address the area that appears the weakest. You must avoid damaging the ovarian cortex. So when you are dissecting, you must go into the correct plane and be sure that you don't unnecessarily handle tissue or mishandle tissue, and you do not remove cortical tissue-bearing regions. So the trick to it is to get into the correct plane and be able to dissect it nicely so that only the wall of the endometrioma comes off, but the cortex bearing the follicles is spared. Okay. So there was a consensus meeting about in 2011, I think, with lots of panelists from multiple 5 continents, and they reviewed the evidence that was available in terms of managing the endometriomas and came up with 69 consensus management points for endometriosis. One of them was to say laparotomy is probably not the best if you are looking at, if you are convinced that this is an endometrioma, because when you operate with minimal access, you're a bit more precise than you would be with at laparotomy, and the potential to damage tissue is higher at laparotomy. So they even went further to say if you've got difficulties that you encounter as regarding the surgical procedure, you might choose to just drain the endometrioma, prescribe gonadotrophin-releasing hormone for at least 3 months, and reoperate 3 to 6 months later. This will also afford you an opportunity to actually then schedule this surgery with appropriately experienced personnel. So if you've got severe endometriosis, I realize we're coming to the end of my time. That's stage 3 or stage 4. You really should not go for repeat surgery as a strategy for improving reproductive outcome, because that has been proven not to work. The only indication for retreating people with severe endometriosis is to control mainly their pain symptoms, not fertility. Right. And when you do this kind of surgery, you might decide that you should use appropriate anti-adhesion barriers. The reason why it probably doesn't make sense to keep doing repeat surgeries is, regardless of the aggressive lysis of adhesions, it is possible and likely that these will reform, the tubal blockage will resurface, and you know, you will not have solved anything in terms of reproduction, but there is value in terms of pain. So here's the final case presentation that I have. It's about a very close friend of mine, was 27 years old, had chronic dysmenorrhea for years. Yeah. It worsened over the 3 months prior to her coming to see me. And she knew that she had cysts from the various wake-ups that she had. And because of friends, she had told me that, you know what, the last thing that I want is surgery. But at the point that she came, she was saying, I'm now in too much pain. You are free to do whatever you want to do. So we did a diagnostic laparoscopy, and this is what we found. The liver was quite normal. This is the left side. This is a hydrosalpinx, and this is the sigmoid colon. Unfortunately, in 2013, I was not recording the videos. We're taking still pictures, so you'll not be able to see the video. This is a huge ovarian cyst, and you can see that between the ovary and the uterus, there's hardly any plane there. In other words, this is what we would call a frozen pelvis. So what we did was we abandoned we took a biopsy, drained the hydrosalpinx, drained the cyst, and told her that you needed to go and see somebody who is more experienced than I was. So one of the things that you notice, for me, this clearly looked like endometriosis, but you see here that there was no evidence of endometriosis on the biopsy, and it can happen from time to time. So because I wanted to refer her to one of my friends in South Africa that I knew had specific expertise in endometriosis, I wrote one of the most painful letters that I have ever written to a medical aid, asking them to fund the transfer to South Africa and for that surgery to happen there. And you can see that I was writing and admitting that there's currently no capability in terms of the local surgeons, and I was being honest. But what it did was it linked me up with people that were later to help me in my life in terms of developing expertise. So when she went there, they reviewed the pictures, they decided to do a colonostomy. And I think if I share these slides with you, you'll then see that they ended up doing a salpingectomy, they drained the endometrioma, and they excised the really heavily affected portion of the rectum. So when she came back, we had a long discussion, and she agreed to go for IVF. And you know, I then sent her for ICSI, which was attempted twice by Dr. Moyo, who is on the panel. The second time that we saw this, I can tell you, we really celebrated. You can see an intrauterine gestation there. And subsequently, she delivered a male infant at 37 weeks. Whenever it's the birthday, we keep getting flowers from this person who's become our very close friend. So let me conclude by saying, I hope I have shed some light on how the decision tree is influenced by evidence in treating women with endometriosis. It is to a great extent determined by how severe the disease is. And I would put it to the group that it's time that we should aim for concentrating all our cases in in one place and have a few people with interest develop that expertise by inviting people who can help us. I hope that before that time, you won't come across all of these uterus that is severely plastered to the posterior rectum, and all sorts of these nasty disease that we call endometriosis. I thank you very much.
Thank you, Dr. Mhlanga. Amazing cases. I'm going to open the floor to the rest of the people. You are now free to ask any questions, starting from the first debate to also to the last presentation by Dr. Mhlanga. So when you want to ask, please unmute and then ask your question. Thank you.
Okay, Mr. Chair, I guess I should share now, right?
Yes, Dr. Mhlanga, please unshare. Dr. Mhlanga, my question is to you. You referred this patient to South Africa. And my question now is, are we now able to deal with such conditions locally? I know Dr. Dragana has done amazing work. Are we now able to do such cases locally? I know you've done also amazing work. Can you now handle the case?
The short answer is no, not to this degree of complexity. We had planned in 2019 to have some of these colleagues come over because it's easier to be taught in your own country than to go and practice surgery in a different country. It's almost not possible to be registered for you to do these highly complicated cases in a foreign land. So when we were a bit advanced in inviting, the first person that I had approached was Abri, and he had agreed to come. But then COVID struck and it has been with us for almost 18 months. So as soon as it settles, we will have some people coming over and training us a bit more. Thank you.
Thank you, Dr. Mhlanga. Anyone with a question? So I'm going to conclude the meeting and allow people to go for tea, then come back for the second part of the Congress.
Okay, good morning. So please just make sure that you register your details before you leave the meeting. You can use the link in the chat box, or you can just send your details, do that for you.
Somebody's just requested for a chat. Are we able to do that before we leave?
Vincent, are you able to share to just screen share the program so that all the participants are aware what is coming after? And the time to return for the next program.
That's why it
Okay, so I'll share the screen.
Yes, please share the screen.
But if it, unless you have just
Sorry, Doc, can you please come again?
Vincent, we could just share the program in the meantime.
3F. 3F.
And if you could zoom in a little bit.
You get for everyone. Most doctors is
Can we mute people, please? The admin.
All right.
Probably because we are running slightly behind our program, we will resume at exactly 10 past to just allow people maybe to take a cup of coffee. Then at 10 past, we'll resume the program. The chair for the next meeting, Dr. Ziki, will take over at 10 past to introduce our next two guests. Thank you.
Dr. Werenga.
Yes.
Yeah, whilst people are having tea, this format of presentation where we do debate, we want to encourage it for even the other sections, because we think that we'll be able to cover different sides of a topic, even not related to fertility. There are topics where there's a lot of debates. For example, we having VBAC or scissor for every breach, things like that. I think we want to see this even in other departments.
It's all right. It's all right. I think that's a point taken, Dr. Moya. Thank you so much.
Yeah, and having said that, I think we want the debate.
I think the change will allow people to vote. Probably will allow people to vote for this debate before lunchtime.
Yeah, people vote on the chat box. Yeah, we want that debate.
Mr. Chair must give it to us because he's claiming victory prematurely.
We want the debate.
We will ask members to cast their vote on the chapter platform, please. Yeah. Cast your vote on the chat platform. We want to know who won and we'll announce probably at the end. So Vincent, you can send out a message to say people may cast their votes. Let's see who won.
Yeah, and then in future, if we're having our registrars, we can sponsor a little prize for the winning group. But for this one, we'll tell them what kind of whiskey we want.
On the daily top 10. So the question that I want to ask is, do men cry? Yeah? Do men cry? Let's talk about matters of the heart. Do you cry when baby says kuti shabarana, kuti and shakuda? Like baby Torota and shakuda. Do you cry or
But
Good afternoon, good morning, everyone.
Morning, Dr.
Sure you can. Fine, thank you. Thank you for your beautiful presentations that we just saw this morning. If we could move over to the next section of our meeting. So our next presentation is going to be from Dr. Grant Mrevanema. Dr. Grant is a final year MEd student. He's a final year registrar, and he will be talking to us on, sorry, I'm Dr. Ziki, and I'll be chairing this session on benign gynecology. And as I was saying, Dr. Grant Mrevanema will be our next presenter, and he will talk to us on the review of myoma treatment options. Dr. Mrevanema, if you are ready, you may start. You'll forgive us, they let me just get in touch with Dr. Mrevanema.
Is the admin able to stop sharing their screen so that I can share mine?
That's okay, Dr. Mrevanema. Let me, okay. Yeah, that has been sorted.
All right. Thank you, Dr. Ziki. Good morning to you and good morning to everybody who was part of this scientific meeting today. I have been asked to briefly review the management options available for leiomyomas. This is by no means an exhaustive presentation. It's in 20 minutes on such a big topic. I'll just share a very brief background rationale and then move on to the treatment options available. So by means of introduction, we know that the estimated prevalence of fibroids is stated to be between 20 to 80% in different populations. Different sources quote different prevalences, mainly because we quote prevalences for patients who present with symptoms, but otherwise it radiology or postmortem, there are so many incidental findings of leiomyomas. So the actual prevalence in populations is probably much higher than what is stated in the literature. And they tend to be more common in the Black race than in the Caucasian race. We encounter fibroids or leiomyomas in our daily practice because of patients who present with abnormal uterine bleeding, either as heavy menstrual bleeding, former menorrhagia, intermenstrual bleeding, which is former metrorrhagia, or a mixture of both heavy menstrual bleeding and intermenstrual bleeding. Patients also present frequently because of subfertility and miscarriages. Unfortunately, we actually don't have the actual figures of the burden of these problems in our setting, but anecdotally looking at books from our outpatients departments, we would know that these are quite frequent problems. Sometimes patients present also because of pressure symptoms, which could be urinary or GIT, and then pelvic pain, which could be dysmenorrhea, dyspareunia, or non-cyclic pelvic pain, And then, of course, we can have acute presentations, such as patients who have torsion of pedunculated fibroids, and patients in pregnancy who get acute red degeneration. These are just some pictures of what I have encountered in my career so far. Some of the photographs borrowed from the procedures that I've done with Dr. Mhlanga and Dr. Ukuiwe, and some of them are from our work at PARI. So this is just a patient who had a fibroid uterus. We had presented for subfertility, and you can see we did the myomectomy and removed these many fibroids. I think there were about 31 fibroids in total. This one is a patient who presented with in approximately 28, I think it was a 30 to 32 week sized uterus. We went on to do a myomectomy at PARI, and we excised all these fibroids, the majority of which were actually pedunculated. This picture here is of a patient who we took for a cesarean section because of failure to progress in labor. And at cesarean section, we actually noted that she had this huge fibroid here in the lower segment that was obstructing. I took this picture from the posterior, but this was really an anterior fibroid. And then this last picture here, this is a patient who presented with what was thought to be an acute abdomen in early pregnancy. The ultrasound scan had suggested that this patient had of an ovarian cyst, possibly a dermoid cyst. But when we took in the patient, we just noted that this patient was bleeding from acute red degeneration of a fibroid in early pregnancy. So they are extremely quite common, and we encounter them quite often in our clinical practice. So there's been an evolution of treatment over the years based on clinical presentation, patient's fertility desires, and class or type of fibroids. The age and fertility intentions of a woman and their preferences in relation to the various treatments is central in decision making. And women desiring future fertility seek uterine and fertility conserving treatments more often. And cultural and psychosocial factors. Cultural and psychosocial factors strongly influence decision making. The FIGO classification is useful for determining the type of surgical treatment. So this is the FIGO classification of fibroids that we use that classified fibroids from type 0 up to type 8, depending on where they are located. Where type 0 are predominantly pedunculated intracavitary fibroids. Type 1 and type 2 fibroids are subserosal fibroids, but type 1 are greater than 50% intramural. And then on the other extreme end, type 7 are the subserosal pedunculated fibroids, and type 6 fibroids are submucosal fibroids, less than 50% intramural, and with it's a whole spectrum. So just a brief overview of the treatment options available, and then I'll go and discuss and briefly appraise some of them. Being listed there does actually not mean that they work. Expectant management is one option. Medical management with non-steroidal anti-inflammatory drugs mainly for pain management, and then the antifibrinolytic tranexamic acid. Combined oral contraceptives, progestogens, androgens in the levonorgestrel intrauterine system, our selective progesterone receptor modulators, and so that's mainly ulipristal acetate and the gonadotrophin releasing hormone analogs, which could be agonists or antagonists. And then surgical treatment options that are available are minimal access surgery, either laparoscopy or hysteroscopy, which could be myomectomy or hysterectomy, and then open procedures as well, endometrial ablation, myolysis, and radiology, interventional radiology, that's uterine artery embolization and magnetic resonance imaging guided focused ultrasound. I am not going to talk about the last two, that's the uterine artery embolization and the magnetic resonance imaging guided focused ultrasound, because the next presenter is going to present the interventional radiology modalities. So the non-steroidal anti-inflammatory drugs and the antifibrinolytics, there is no convincing evidence that non-steroidal anti-inflammatory drugs significantly reduce heavy menstrual bleeding. Several studies exist that actually don't show any beneficial effect in terms of heavy menstrual bleeding. However, they are useful for the treatment of pain associated with degeneration and also for chronic pelvic pain associated with fibroids and dysmenorrhea. Tranexamic acid, which is an antifibrinolytic, inhibits tissue plasminogen activator. It has not been specifically evaluated for the treatment of heavy menstrual bleeding related to leiomyomas. However, several subgroup analysis of some studies have provided evidence of effectiveness, and some studies have shown blood loss reduction that could be as much as 50% in women with clinically diagnosed fibroids. So based on this evidence alone, if we to choose between non-steroidal anti-inflammatory drugs and tranexamic acid for management of heavy menstrual bleeding, we should probably go with tranexamic acid over non-steroidal anti-inflammatory drugs, unless the patients also have pain that we concurrently want to manage, in which case we can actually use both. However, in some studies, there has been a higher risk of fibroid necrosis and infarction that was noted with the use of tranexamic acid, there with quite a significant odds ratio of 3.6. Combined oral contraceptive pills, levonorgestrel intrauterine system, progestogens, and androgens. So in a systematic review and meta-analysis by Moroni et al. There, combined oral contraceptives were demonstrated to actually result in a 17% reduction in the risk of myoma growth in current users of combined oral contraceptives. And I think the evidence has really thrown away what used to be thought that combined oral contraceptives could actually result in growth of the fibroids. So they don't. Not so good quality studies demonstrate up to 50% reduction of menstrual blood loss with combined oral contraceptives in women with clinically diagnosed fibroids. However, what we note with those studies is that most of them are actually observational studies, and they have quite significant heterogeneity in diverse populations. So the evidence is not as strong as we would want it to be. Then in terms of the levonorgestrel intrauterine system, it has also been noted to significantly reduce blood loss and improve hematological parameters in those women who have menstrual bleeding secondary to myomas. However, especially with intracavitary fibroids and submucosal fibroids, expulsion rates of the intrauterine system are quite higher, and anatomic distortions may preclude their use. And in our setting, availability also seems to be an issue as well. Progestogens, oral progestogens, injectable progestogens do not shrink fibroids, and there is no evidence to support the use of our depomedroxyprogesterone acetate for treatment of fibroid-related symptoms. So we probably should not use these progestogens like our norethistron, migestrol, and so on for the management of heavy menstrual bleeding. Danazol and gestrinone reduce myoma size and blood loss during treatment, but their role in treatment has not been solidly established, and the androgenic effects of danazol are now unacceptable. So it's mainly obsolete. Gestinon is more acceptable, or it's got a better side effect profile than danazol. The selective progesterone receptor modulators, ulipristal acetate, which is the commonly trialed selective progesterone receptor modulator, induces apoptosis in myoma cells and inhibits cell proliferation. Several studies, the PEARL studies, were carried out to evaluate the effectiveness of ulipristal acetate in medically managing patients with fibroids. So in the PEARL-1 study, which was published in the New England Journal of Medicine in 2012, 5 and 10 milligrams of ulipristal acetate were compared to placebo over a 13-week period. And significant reductions in the menstrual blood flow were actually noted, which were over 90% for both 5 milligrams and 10 milligrams of ulipristal acetate after 13 weeks. And cessation of blood flow occurred within 10 days in 75% of patients receiving ulipristal acetate. So, and the median change in fibroid volume was 41% in both trial groups versus 18% in the placebo group, and that was statistically significant. And these changes were maintained for at least 6 months after discontinuation of the ulipristal acetate. However, there has been a concern of progesterone receptor modulator associated endometrial changes, which essentially just reflect desynchronous growth between glands and stroma. However, reassuringly, they have not been linked to endometrial hyperplasia and cancer. And these changes have also been noted to revert to normal within 3 to 6 months of discontinuation of the ulipristal acetate therapy. Significant concerns have been raised over liver disease, over hepatic impairment with the use of ulipristal acetate, and now so significant underlying liver disease is now listed as a contraindication to the use of ulipristal acetate. Then in terms of the gonadotrophin releasing hormone analogs, we have the agonists and we have the antagonists. And some of the agonists that have been trialed for the treatment of fibroids include leuprolide, either as 3.75 milligrams monthly injections or 11.25 milligrams 3 monthly intramuscular injections. Zoladex is 3.6 monthly subcut depot implants or 10.8 milligrams 3 monthly subcut depot implants. Others like triptorelin and nafarelin, which is available as a nasal spray regimen, have also been used as sort of off-label treatments for this, though they are not yet FDA approved. And all these treatments have also been noted to be quite effective in reducing the menstrual blood flow associated with fibroids, and they also significantly shrink the leiomyoma volume. The mechanism of action is basically that they target the growth effects of estrogen and progesterone, and the gonadotrophin releasing hormone agonists unfortunately tend to start by causing a flare in the gonadotropins and cause sort of unacceptable menopausal vasomotor side effects. And also a 6-month period of use of gonadotrophin releasing hormone agonists can result in 6% loss of trabecular bone, which is quite significant, and which also may not be completely recovered after discontinuation. So therefore, use for longer than 6 months actually requires back therapy of an estrogen combined with a progestin. The PEL-2 trial, also published in the New England Journal of Medicine, was a non-inferiority, double-blind, 13-week comparison of ulipristal acetate with a monthly injection of 3.75 milligrams of leuprolide acetate, and uterine bleeding was controlled in patients who were receiving all the arms of the treatments. That's 5 milligrams of ulipristal acetate, 10 milligrams of ulipristal acetate, and 89 and those receiving 3.75 milligrams of leuprolide. And so these differences were actually not statistically significant, showing that they are all effective. However, ulipristal acetate was better tolerated, and in terms of controlling the time to control of the bleeding, ulipristal acetate was noted to be more rapid. Leuprolide was noted to show more uterine volume reduction clinically, though ultrasound scan assessment then showed no statistically significant difference. And over the years, there have been extension trials of these PEL trials, including the PEL-3 trial, which concluded that repeated 3-month ulipristal acetate courses effectively control bleeding and shrink fibroids in patients with symptomatic fibroids. However, we note that for us, the selective progesterone receptor modulators and the gonadotrophin-releasing hormone agonists are not commonly used, and where they are used, they are usually used to prepare patients for surgical management. The gonadotrophin-releasing hormone antagonists, elagolix and relugolix, which are non-peptide forms, are suitable for oral use. The gonadotrophin-releasing hormone agonists are not suitable for oral use. That's why they have to come as intramuscular injections, subcuts, depot preparations, or nasal sprays, but the antagonists can actually be used orally, and they avoid the initial flare of gonadotrophins that is associated with the agonists. They also significantly reduce menstrual bleeding and myoma volume, is noted in randomized controlled trials that were concluded a few years back. However, hot flashes and other vasomotor symptoms are also quite a significant side effect. These can sort of be alleviated or attenuated by the use of aid-back therapy, which includes an estrogen and a progestin combination. So in Zimbabwe, as far as we're concerned, so far the mainstay of treatment for leiomyomas has been surgery. I think if we just review our outpatients department and theater books quickly, even though we actually don't have peer-reviewed publications, we would note that abnormal uterine bleeding secondary to fibroid uterus is possibly the most frequent indication for hysterectomy in Zimbabwe. And we would also note that myomectomies are also done quite frequently for patients with subfertility and patients also with abnormal uterine bleeding. And open procedures have been more frequent than minimally invasive surgery, though we hope that it will change in the future, and minimal access surgery will become the mainstay of surgical treatment for leiomyomas. Indications for surgery include severe pressure symptoms, unresponsiveness to other therapies, that is in our settings, not ours. So patients who have failed medical treatment, patients who have failed uterine artery embolization, or enlarged pedunculated subserosal or submucosal fibroids. Hysteroscopic surgery, so small subcutaneous submucous fibroids are implicated in heavy menstrual bleeding and intermenstrual bleeding, and they can be removed hysteroscopically. Usually it's the type 0 and type 1 myomas, which are less than 3 to 5 centimeters in diameter, And the step W criteria, which looks at the size, topography, extension, penetration, and the wall, and then gives sort of a sum score, can be used to guide patient selection and say this is a patient who's amenable to hysteroscopic resection of leiomyomas. And in other centers where people are more used to doing this, type 2 fibroids can also be resected hysteroscopically using a staged approach. And usually these patients are pre-treated with a gonadotrophin releasing hormone analogs such as leuprolide before the surgery. Complications of hysteroscopic fibroid resection, fluid overload, uterine perforation, hemorrhage, and infection. However, it is notable that relief of menstrual symptoms actually occurs in 69 to 85% of women after up to 15 years of follow-up, and therefore this is a very effective modality which all of us should be trained and be confident in doing. Abdominal myomectomy for patients who want preservation of fertility. It can result in reduction of bleeding in up to 80% of the patients. But again, these figures have been noted mainly in retrospective studies without adequate randomized controlled clinical trials. A recurrence can be very high with a 5-year cumulative recurrence of up to 62% in some case series, and which is quite significant. Several interventions can be used to reduce blood loss at myomectomy, and this includes the use of vasopressin, misoprostol, tranexamic acid, gelatin thrombin matrix, chemical dissection with Mesner and pericervical tourniquets to reduce blood loss. Usually people tend to choose what they are more comfortable with as modalities to reduce menstrual blood, to reduce blood loss at myomectomy. And in some selected cases, uterine artery embolization can actually be used to prior to abdominal myomectomy, and it can result also in significant reduction in blood loss at myomectomy. Gonadotrophin releasing hormone agonists reduce blood loss when used for treatment of large myomatous uteri and can result in avoidance of a potentially midline incision, converting it to a lower transverse incision. In terms of laparoscopic myomectomy, studies have noted that outcomes are comparable, they're similar to those of open procedures. However, laparoscopic procedures result in shorter hospital stays, less febrile morbidity, less blood loss, and reduced adhesion formation and pain. However, rupture in subsequent pregnancies seems to be much higher following laparoscopic enucleation of myomas. And this has been postulated to be possibly due to single layer closures and hemomyometrial injury from greater electrosurgery use during laparoscopic myomectomy. The patient criteria over which patients are suitable candidates vary by surgeon expertise and include myoma size. So some would say if fibroids are not more than 6 centimeters.
If I can interrupt you and just tell you that our time is running out, if you could round up.
All right, so 6 to 10 centimeters, that's been the cutoff point for some surgeons, and if there are more than 3 tumors, some surgeons would also not go for laparoscopic resection. And if there are locations that potentially require multiple incisions, then laparoscopy would be avoided. In general, large intramural and multiple myomas require a greater laparoscopic skill. And then hysterectomy is the definitive treatment for this via either vaginal, abdominal, or laparoscopic routes. And pre-treatment with gonadotrophin-releasing hormone analogs can lead to reduction in uterine size, reduced blood loss and avoidance of a midline incision. And I think laparoscopic techniques will become more popular in the future as surgeons realize that even bigger uteri can also undergo laparoscopic hysterectomy. There have been fears of seeding of myoma fragments within the peritoneal cavity in patients with possible leiomyosarcomas, and also risk of direct injury to bowel or blood vessels during morcellation. And yes, so this is just another picture of one of the patients we operated at Pari, where we entered the abdomen and noted a very vascular.
About being this little password quickly.
All right. That's all right. And so that brings me to the end of my presentation. Thank you.
Thank you so much for your presentation, Dr. Mrevanema. It's a good reminder for all of us on the medical management of myomas that is available to us as clinicians. I'll ask everyone to hold on to their questions for now, and or just add them to the chat box where we will get answers at the end of the session. Whilst Dr. Mrevanema exits his screen, I will introduce Dr. Godfrey Chatora, who is a consultant radiologist who graduated from the University of Zimbabwe with honors. And following completion of his basic training, rotation in Norfolk in the United Kingdom, he then proceeded to general radiology training in Nottingham, and during which time he was awarded a fellowship of the Royal College of Radiologists. Then he later undertook a subspecialty fellowship training in vascular and interventional radiology, both in the UK, as well as he took a period of out-of-program training at the renowned Sheffield Academic Vascular Unit. And Dr. Chatora is currently the managing radiologist of the MIC Radiology Group. Dr. Chatora, welcome to our session. If you can please go ahead with your presentation.
Thank you very much for the invitation. I'm extremely honored, extremely humbled to be invited to give a presentation today. Thank you very much all. If you can please confirm whether the slides are showing.
They're showing. We can see your initial slide, Dr. Chatora.
Thank you very much. So what I've been asked to do today, I feel, is to open a discussion on uterine artery embolization. The way that I'm hoping to do this is to begin by outlining the principles and applications of uterine artery embolization techniques, not only in gynecology, but also touching on obstetrics. Also to discuss the absolute necessity for effective multidisciplinary collaboration in patient selection and in planning for us to get optimum outcomes. And I'll complete my talk by just looking at locally available options for uterine artery embolization and what our current outcomes have been like. So basically, I look at this in three main broad groups. We're looking at uterine fibroid embolization for heavy menstrual bleeding and bulk-related symptoms primarily. Non-fibroid uterine artery embolization for conditions such as uterine artery pseudoaneurysms or arteriovenous malformations post-trauma or post-curettage. And I will also touch on an issue that I believe we will need to focus on moving forward, which is postpartum uterine artery embolization. So why uterine fibroids? Why is it a point of discussion? I was glad Dr. Mrevanema highlighted the frequency with which patients with symptomatic fibroids present to outpatient clinics in our setting. It's by far the commonest benign tumor of females, histologically present in up to 70% of women, and 50% of whom will be symptomatic. So you're looking at up to 1/3 of adult women will have symptomatic fibroid disease. We all know this can cause significant morbidity and a significant health burden. The key thing for me here is this is during active adulthood, during our most active and most productive years.
Obviously, in our local setting, these are 3.25 times statistically more likely to happen in Black females. So again, this really brings the condition to the fore for me. Dr. Maria Rema also touched on the classification of the fibroids, where we classify them in terms of their location, with obviously with class 1 to 7 and the hybrid leiomyomas, which can impact on both the endometrium and the serosa. So potential therapies, obviously, doing nothing, reassurance, is a potential therapy in itself. We've had introduction to surgical treatments, myomectomy and hysterectomy, but what I am focusing on today is uterine artery embolization as one of the minimally invasive techniques. There has also been a look at uterine artery ligation and an upcoming technique on high intensity focused ultrasound, as well as obviously the medical therapy, which has been discussed earlier. So uterine artery embolization, this was developed in the early 1990s by a French group, and it was specifically designed as a pre-embolization procedure. Ultimately, however, it became recognized as being beneficial on its own accord. So rapidly adopted worldwide, and to date, we've got close to 500,000 cases that have been performed internationally. One of the things that I discuss with my radiology colleagues when we look at the analogy of a hunting wolf pack is you have those that go ahead of the pack, those that go with the pack, and those, as in our setting, that are a fair distance behind the pack. I believe that there's the strengths and weaknesses of each position do tend to balance out. In our setting, the fact that we are a fair distance behind the pack, I believe means we can benefit from the wealth of data that is out there on how we can optimize our patient selection for treatment options such as this. So I'm going to look at two main randomized controlled trials. The first one is the EMI trial, which was initially a 5-year outcome randomized controlled trial, where patients were randomized to either undergo uterine artery embolization or surgery with hysterectomy as treatment for menorrhagia caused by fibroids. The patients were randomized in a 1-to-1 ratio, and the endpoints at 5 years, they looked at the need for reintervention, the improvement in menorrhagia, and a healthcare-related quality of life measure questionnaire. In short, at the end of the 5 years, their conclusion was that uterine artery embolization did hold its own as a well-established alternative to hysterectomy, about which patients should be counseled. They went on to follow up these patients for an additional 5 years. So this is the sort of wealth of data that I'm talking about. We have an additional 5 years extension of the EMI trial, where at the end of the 10 years, we now have 177 patients from a prospective randomized controlled trial with 10-year follow-up and health-related quality of life questionnaires. And at 10 years, there was no statistical difference in the quality of life between the two groups. 78% of the uterine artery embolization patients and 87% of the hysterectomy patients were either quite or very satisfied with their treatment outcome. An important figure I would like us to keep in mind is here. 31% of uterine artery embolization patients would, however, go on to require hysterectomy by 10 years. So 31% of uterine artery embolization patients did require re-interventions. The second trial that I want us to look at is the REST trial. So this was a Scottish-based trial undertaken in 27 UK hospitals between 2000 and 2005. Another randomized controlled trial, prospective, where they had 157 patients randomized in a 2-to-1 ratio between uterine artery embolization and hysterectomy. Again, very similar results. At 5 years, no significant difference in the quality of life using the various tools that they use, and I'll show you the tool that we have adopted locally. Symptom scores improved, 4.5 for uterine artery embolization out of a maximum of 5, and 4.8 for hysterectomy, again out of a maximum of 5. Re-interventions for the uterine artery embolization group, very similar to the EMI trial, 32%. So their conclusion here was that one of the conclusions, the initial cost benefit from uterine artery embolization was then eroded to equipoise by 5 years. So putting cost benefit aside, what conclusions did the REST trial draw? Again, A, it's a satisfactory alternative to surgery for women with symptomatic fibroids. B, its less invasive nature does need to be balanced against the need for re-intervention in about 30% of patients. And ultimately, the choice should lie with the informed patient. An analysis of these two randomized controlled trials, just looking at a few key parameters. Hospital stay in the uterine fibroid embolization group, as opposed to the two surgical groups, is about a third of the duration. The return to routine lifestyle, again, is about a third of that required for surgery. Return to work is about 50% to a third of the time required for surgery. You do get to retain the uterus. In terms of fibroid symptoms resolution, obviously hysterectomy is the only treatment method which has 100% efficacy. Quality of life and major complication rates were deemed to be equal across all three groups across the two randomized controlled trials. So where does that leave us in terms of the current guidelines? I've looked at three key ones in chronological order. The Cochrane review in 2012, UAE versus surgery, similar patient satisfaction with shorter hospital stay and quicker return to activities. The Royal College of Obstetrics and Gynecology recommended it formally as a treatment in 2013, and it then featured in the NICE guidelines in 2018 as part of NG 88 as being recommended as a treatment option for patients with heavy menstrual bleeding and fibroids greater than 3 centimeter size. That being said, just touching briefly on the technique of the uterine fibroid embolization, very straightforward, whether it's by femoral or what is now growing in popularity, radial access. One accesses the internal iliac, subsequently the anterior division and the uterine artery, and under imaging injects particles or plastic beads to block the arterioles supplying the fibroids. A very simple technique. And obviously, like I said, this is either by femoral or by the radial route, which is growing in popularity, particularly in North America. So what are the contraindications to fibroid embolization? Obviously, we have absolute contraindications, understandably, pregnancy, the presence of malignancy or acute pelvic infection. Relative contraindications, this is where the concept of informed consent comes in again. Patients wishing to conceive within the next 2 years. This is a very contentious one because although this factors in the guidelines, more and more groups across the world are reporting the incidence of females who are unable to conceive with symptomatic fibroids, who after uterine artery embolization do go on to conceive and carry pregnancy to term. So this is one where careful consent is required. Intracavitary fibroids, I'm going to highlight some examples of that. Narrow stalk subserosal fibroids, fibroids greater than 15 centimeters diameter, and previous radiation and the presence of connective tissue disease. So just to touch on the intracavitary fibroids, treating an intracavitary fibroid, less than 2 centimeter size, one would expect even if it does slough off into the endometrial cavity, that would typically pass without complication. When a fibroid, however, is isolated and less than 3 centimeter size, here now comes the question of whether this patient is better served with hysteroscopic resection as opposed to embolization. Fibroids greater than 4 centimeter size, however, are considered a relative contraindication due to the infection risk that then comes when a fibroid of this size sloughs off into the endometrial cavity and does not pass spontaneously. So obviously informed consent about the possibility of requiring additional interventions. In as far as the pre-UFE imaging evaluation, the gold standard is contrast-enhanced MRI and MR angiography, and I'll illustrate why. But alternatives that have been used and used very reliably are your non-contrast MRI as well as contrast-enhanced CT. So when we're looking at the reporting template, and this is one that I discussed with my radiology colleagues, the main things that we want to report on the MRI or MRA examination, obviously we want to describe the uterus, its size, its volume. As far as the fibroids go, a key aspect for me is their enhancement. Remember, the cornerstone of this treatment is cutting the blood supply to these fibroids. So if these fibroids are not vascular, they don't enhance, they're autoinfarcted, then this is not a suitable treatment technique. Information about the uterine arteries, their number, their site, their origin, their size, and the presence of any collateral supply is also very useful. So here, T1, fat suppressed image, post-contrast, sagittal, highlighting a bulky uterus, 2 enhancing fibroids. So obviously this is a patient you expect will get benefit from uterine artery embolization. When we look at the MR angiography on this volume rendered image, you see that in this patient there is a normal variant where you've got a hypoplastic left internal iliac system, and subsequently the uterus is predominantly supplied by a large caliber right of a uterine artery. So in this instance, you go into the procedure knowing exactly what you're targeting, making it much more elegant and swifter. So this just shows the comparison from the magnetic resonance angiographic image to the catheter angiographic image in that same patient. Again, just highlighting how accurately you can delineate the iliac arterial anatomy on your MR angiography. This shows a type 1 uterine artery, which is arising as the first branch of the inferior gluteal artery. And at catheter angiography, you can see how accurately you've managed to get your pre-procedure roadmap prior to taking on this case. Which patients are not good candidates for uterine fibroid embolization? It may not help patients who have got bulk symptoms. You may have unrealistic expectations, and I'll take us through the consent procedure for these patients. Patients who have got pain which is questionable in relation to the fibroids, patients with chronic pain and small fibroids, and obviously it definitely will not help patients with autoinfarcted fibroids. So pre-procedure, what is required here? Specialist gynecology workup and evaluation is definitely required. As Dr. Murianima highlighted, there are medical therapies that can be tried, all sorts of things that can be done before we come to the discussion around uterine fibroid embolization. And then there should be an interventional radiology clinic consultation. This is where we sit down with the patient in clinic, go through their imaging, go through their history, and give them a frank and open insight into the procedure. As was said before, from those previous randomized controlled trials, the choice should ultimately lie with the informed patient. There are 8 main parameters that I believe should be discussed at this point of consultation. The 95% success rate for menorrhagia, 50% success rate for bulk symptoms, a 70% success rate for treating symptoms from adenomyosis, and then the issue of potential premature menopause. For patients less than 45 years of age, that's a 1 to 2% rate, and patients of greater than 45 years of age, it's a 2 to 5% rate. A 5% risk of persistent vaginal discharge requiring additional intervention, 2% infection risk, of which only 1% is infection risk that may require hysterectomy. So what are we aiming to do as we follow these patients up, ideally at initially 3 months post-procedure? So we've got sagittal T2 MR images, where looking at the uterus, we're aiming to have achieved volume reduction, reduction in vascularity of the fibroids, and then obviously because we're treating patients and not treating pictures, we're looking to have improved quality of life. And I'll show you the quality of life assessment tools that we are using locally. So what sort of tools do we have available? One of the things that has really made this procedure much more elegant is the presence of what you call micro-coaxial catheters. And these are basically catheters that are the same caliber as a guide wire and can navigate even more tortuous and narrow caliber vessels, allowing you to perform treatments where previously it was very difficult. The materials that are used for embolization Absorbable agents typically tend to be preserved for postpartum hemorrhage. So we would ideally use the non-absorbable agents, particulate, either PVA or embospheres. The injectable agents, sclerosing agents, and things like coils have tended to fall away in preference for uterine fibroid embolization. So vascular coils, which are the spiral devices that you pass through this injection device, which are covered in these fibrinous coats that are highly prothrombotic, causing vascular occlusion. Particles, which are irregular angular particles that can be injected for this procedure. We locally have opted to go for the spheres, and we use Embozine by Boston Scientific. So these are exact size particles, which makes the embolization endpoint much more predictable. So for example, for us, our embolic agent protocol is quite predictable. We know we're probably going to use 2 of the 500 to 700 micron and 2 of the 700 to 900 micron particles to embolize to stasis. So managing the patient post-procedure, the main things that we do need to manage are pain and post-embolization syndrome. One of the things which is of great benefit for these patients is to get a clear understanding at the outset, exactly what to expect, the timing of their regular oral analgesia, things that will reduce their requirement for narcotic analgesia, guidance on timeframes of these post-procedure symptoms, managing their expectations, and giving them a clear mechanism or clear pathway or means for contacting the interventional radiology clinical team so they can get the support they need post-procedure when they need it. Post-embolization syndrome, how to describe it? It's like flu-like symptoms, fever, nausea, pain, lasts between 1 and 10 days, can start within minutes or within days, and pretty much every single patient gets it. For pain control, and pain control is one of the main issues in the first 12 hours post-procedure, we use a combination of drugs for conscious sedation together with narcotic analgesia. A PCA pump has come across as being one of the gold standards, of which, although we do not have this available locally as yet, we are working on getting that in. Intra-articular lignocaine has also been very beneficial in reducing the requirement for narcotic analgesia. And for patients who've got sensitivities to narcotic analgesia, superior hypogastric nerve blocks. One of the other things that I have been discussing with my radiology colleagues is, as we do more of these cases, we are going to see uterine gas. And gas in any solid organ is normal post-embolization. This is nitrogen. It can last up to 2 weeks. There's no normal amount, but it does decrease with time, and you will see it on ultrasound or CT. So basically, we're describing the patient who's had embolization, is symptomatic, and goes on to have imaging. We will see quite alarming looking pictures like this. Fibroids containing gas demonstrating air fluid levels. Ladies and gentlemen, this is not an indication for a hysterectomy. These are normal post-embolization appearances, and patients simply require the supportive care in that an immediate post-procedural period. One that I have come back to, which is again, this contentious point about embolization. Article from December 2013, uterine artery embolization is fertility enhancing. That I think is probably a step too far. But what I do agree with from this article is, again, groups around the world are reporting that by performing these procedures in younger women, women are finding that we are finding that more and more of these patients are going on to conceive and carry pregnancy to term, patients who have previously not been able to conceive. Unfortunately, this is not an area where randomized controlled trials are conceivable. So looking at our local cases, one of the things that I've been discussing with colleagues is we have adopted our own local form of uterine fibroid symptom and health-related quality of life questionnaire. And these have been developed worldwide to evaluate the symptoms of fibroids and their impact on health-related quality of life. They've been used in a number of studies. For example, those randomized controlled trials I highlighted earlier, and they have been reliable, they show validity, so we have adopted a tool. And just showing a couple of pages from it, this is quite a long questionnaire that these patients have to fill in, and this is at the beginning of treatment, at 3 months, at 6 months, 9 months, and we're aiming to follow these patients up to 3 years. And you can see how I know this may not be very easy to read, but it touches on pretty much every single aspect of quality of life that can possibly be related to uterine fibroids. So of the 6 cases that we have done since we launched the service last year, 2 of our patients have now reached the first checkpoint, which is the 3-month period. So I'm just highlighting what we've observed from our first 2 quality of life questionnaires. So from patient 1 and patient 2, out of a total possible score of 185, which is the absolute worst in terms of quality of life, we started off at 130 and 162 respectively, and our current scores are now down to about 50% of the initial score. When we look at the average answer per question, we started off at about 4, and the answers have now dropped to an average of approximately 2. And if we just step back to that questionnaire, an answer of 5 is an issue that's affecting your quality of life all the time. An answer of 1, it's affecting you none of the time, and 2, it's affecting you a little of the time. So obviously, so far, that first 3-month check, we have got encouraging results. And the aim is for these patients, we continue to feed these questionnaire results back to the referring clinicians. So I'm going to look at some cases that we've done locally, just to highlight how we've gotten on. So case number 1, obviously we can assess, see from here, we've gotten access via the right common femoral artery. We've crossed over the aortic bifurcation into the left internal iliac artery, where we've got good visibility of the left uterine artery, accessed that and treated it to stasis. So even though there's no more contrast coming out of the catheter tip, there is still contrast sitting in the uterine artery. So that has been embolized to stasis. Sorry. Catheter is then withdrawn into the contralateral iliac artery, access the internal iliac, so we can see contrast outlining clearly the contralateral right uterine artery, and that again is treated to stasis. Case number 2, again, this is one of our local cases. This is from earlier this year, accessing the left internal iliac artery, good visibility of the uterine artery, and again, treatment to stasis. You've got stasis of contrast flow in the uterine artery, catheter withdrawn to the contralateral internal iliac, microcatheter access into the uterine artery, and further treatment to stasis with only subtle trickle residual flow. So what are the benefits of having a viable uterine fibroid embolization service for me? I think there are 3 main things, or I believe there are 3 main things. It provides alternative options to you, our gynecology colleagues. It gives the patients informed choice for their therapy. And touching on to postpartum hemorrhage, it does open the door for us to have additional tools to manage postpartum hemorrhage. Why is it even important to be talking about postpartum hemorrhage? Still the leading cause for maternal mortality worldwide. The highest incidence is right on our back doors in Africa and developing countries. And even in the developed world, a 2008 NHS confidential inquiry into 12 maternal deaths in a London hospital, as one of their conclusions, highlighted that the lack of embolization services was deemed to be a critical factor in the management or the failure and management of these patients. And as far as the history of embolization for postpartum hemorrhage, this is not something new that we're making up today. First described in the late 1970s, the first 2 papers that I've been able to identify are from 1979. So obviously these techniques have become much more refined over the last 41 years. And as far as the indications, obviously I'm just going to touch on these very briefly. Atonic uterus with or without cesarean section, uterine tear, cervical vaginal injuries, bleeding post-hysterectomy, and placental implantation issues. So what are we trying to do? We're targeting the anterior division of the internal iliac. We're using temporary embolic agents, nothing fancy, simple gel form, or even at its worst, autologous blood. And when you do use particles, you want your larger particles greater than 700 microns to prevent potential infarction. The technique is exactly the same as what we showed for the fibroid therapies, except your uterine arteries can be smaller. So, post-embolization, what are the issues? The question that was asked initially was, will this affect menses, fertility, future pregnancy? Different groups have looked at this and all appear to return to normal postpartum hemorrhage embolization. The major complication of post-embolization for postpartum hemorrhage is uterine infarction. And this is where particle size becomes absolutely crucial, making sure you use the larger particles so you do not get as profound ischemia post-treatment. Local arterial trauma, minimal risk, renal toxicity, particularly a combination of intravenous contrast in patients who are hypovolemic, and ovarian failure. So it is now internationally accepted as a first-line treatment for emergency postpartum hemorrhage, and it's made its way into the UK practice guideline documents under the Royal College of Obstetrics and Gynecology, Royal College of Radiology, and the British Society of Interventional Radiology. So embolization in postpartum hemorrhage. Obviously, we've not done any cases locally, but I've been privileged to allowed to share a few cases done by a colleague who's based in Australasia. And this is a patient bleeding post-normal delivery. A catheter has been passed over the aortic bifurcation into the left uterine artery. And as contrast is injected, you can see the arterial blush and contrast briskly extravasating into the endometrial cavity. So this was treated with gel form embolization, and the completion embolization angiogram shows no further extravasation. The second case, which he was kind enough to share, is one of hemorrhage post-cesarean section. So what you can see on this image is, if you with an eagle eye, Raytech swab in the pelvis. So obviously this is a combined procedure. It's all hands on deck here. Catheter in the common iliac artery, outlining the internal iliac. We've got the anterior division, the uterine artery, and brisk extravasation. So that is accessed with a microcatheter and embolization coil deployed, and that has been treated to stasis. So hopefully I've been able to do justice to the aims that we outlined at the beginning of this talk, which was to outline the principles and applications of uterine artery embolization techniques in obstetrics and gynecology, to highlight and discuss the necessity of effective multidisciplinary collaboration in patient selecting to get optimum outcomes, and to illustrate what we now have as locally available options for uterine fibroid embolization, the current outcomes, and hopefully to open the discussion to future utilization of these techniques. Thank you very much.
Thank you so much, Dr. Chatora, for that brilliant, such a detailed presentation. And I guess we all have to really fall in line with precision, minimally invasive procedures, which are the trend globally, and we cannot make excuses as being in developed countries. Thank you so much. There are people who have put in questions. So whilst I wait for hands to be raised, I'll read the question. And the first question that I got was from Dr. Chidoma Dziwa. And sorry, Dr. Mrewanema, I will come back to you shortly. Why can't we use the uterine artery embolization? Why can't we repeat it in the 31 to 32% of patients who get recurrence after the 5 years?
Thank you very much. That's a very, very good question. So it's not a question of not being able to repeat it, because remember, you have not blocked the artery, you have not ligated it, you have not used coil embolization. You can easily come back and repeat it, and you often do need to, based on the quality of life questionnaires. But this is probably in patients who have had other conditions develop, perhaps that 1% of patients where they get infection that does require hysterectomy, or other issues arise in their gynecological obstetric care. but there's absolutely no reason why you cannot repeat it because the main arteries themselves remain patent.
Oh, thank you. So we can say if a patient recurs after 10 or so years, the treatment option can still be embolization.
Absolutely. Absolutely.
Thank you for that. Dr. Madziwa and Dr. Biko, I hope you've been answered. Dr. Madzire, please go ahead.
Thank you very much, Chair. Thank you very much, Dr. Chatura, for the insightful talk. Thank you very much to Grant as well for the talk. So just a question for you, Dr. Chatura. This is Dr. Madzire speaking.
Yes.
In your experience where you've worked, how are these interventions being rolled out in the public sector? Because our biggest problem is usually our students only learn this in the book and they know everything, but they will never see it in real life. So is it practical to end up having this process happening in the public sector that it becomes a reality, not something we just only hear about? Thank you.
Thank you very much for that question. I think that that's a very, very good question. And it starts to angle towards a discussion that I hope will start today and continue well into the future, which is once we have the will to start these treatments, we simply start wherever we start and it will grow. That's inevitable. And as far as doing this in the public sector, we know internationally that this treatment option is cheaper than hysterectomy. We already know we can offer hysterectomy in the public sector. So what's holding us back? There's a need for hardware. As a practice, colleagues who have been discussing this with over the last few years will know it's taken us about 5 years to get the hardware in, but it's not impossible. This virtual table that we're sitting around here has got some of the most eminent names in Zimbabwean medicine who, by simply raising their finger, can summon these resources. If you can get the imaging equipment in the public sector, then the catheters, the particles, these are of a very, very small cost. But the main limiting factor is the hardware, your imaging equipment. And I'm sure that that's not something that's insurmountable.
Whilst we're on that question, Dr. Chatora, Dr. Gwanzura has asked about the cost of this embolization locally.
Okay, so I'm not privy to the local costs of hysterectomy, but what I'll do is I'll use the UK-based figures because I believe there's a lot of corroboration between the two. According to the NHS, it costs the NHS about £3,500 for a patient to undergo a hysterectomy. It costs the NHS just over £2,000 for a patient to undergo uterine artery embolization. So that by proportion is the sort of difference in cost that you are looking at.
Thank you very much. Dr. Mhlanga, please go ahead.
Yeah, thank you, Shemba, for the good talk. My question is on the practicality of this. If you did the uterine artery embolization for fibroids, for example, number one, is there a difference in the gel forms in their time to action? Number two, what is this actual time to expect that if the bleeding doesn't reduce by this time, it has failed?
Thank you. So, Doc, if I can just clarify, are you asking about treatment for fibroids, symptomatic fibroids, or are we now talking about postpartum hemorrhage here?
Well, you could apply it to both, but I was really looking at if you're doing it as a treatment for heavy menstrual bleeding, for example. Yes. When are you expecting that this embolization should work? Is it the next period? Is it,
Okay, thank you very much. I would say between 1 and 3 months, we should have a good indicator of the efficacy of our treatment. Like you've seen from our presentation, we are surveying these patients at 3 months. And if at that 3-month period, we are not seeing a satisfactory improvement in the quality of life, we do need to then go back to that roundtable discussion and say, look, do we need to do something else? Do we need to repeat the treatment, or do we have to accept this as treatment failure? But I would say 3 months is probably a safe point at which you can start making those assessments.
Thank you. I presume if you're doing it on the table, would you still go through the femoral artery, or you would inject it directly if they need a rose? We sometimes do these huge threatening placenta previas and stuff. Does it work, this gel?
Right. So This again brings in another, sorry, and I start to get a little bit excitable and start to talk a bit fast here, so I'll try and slow down. For those patients where we know we've got pre-existing placental issues, the move now has been to do preemptive catheterization of the uterine arteries. So think about it. You know this patient has got, that threatening placenta we've spoken about. We've decided to undertake an elective cesarean section. On the morning of the procedure, what is to stop us from electively putting balloon catheters or any other type of catheter into the uterine arteries, parking them there, and then taking the patient to theater? Should things become interesting during the cesarean section, the balloons can be inflated, or embolic material can be injected through those catheters. They are in place. If they're not required, they can be taken out at the end of the procedure.
Thanks, that's very helpful. I can see this being really practical in people, for example, the Jehovah's Witnesses, because we could clearly do.
Absolutely. So if you've got a patient who's got balloons in each uterine artery, the radiologist doesn't even need to be there. It's simply a balloon with a syringe attached on the end. You know that if you inflate that balloon to 5 cc's, you have completely occluded that artery. You can inflate them and deflate them at will as you're controlling the bleeding. It really does give you an extra dimension of control.
Thank you so much. In the same vein, thank you, Dr. Mhlanga. In the same vein, to follow up Dr. Mhlanga's question, there is another question where they're asking, in the settings where we use it in PPH for control of PPH, do they already have radiological equipment in their delivery suites and theaters? Is this because you know that PPH can be sudden and it can be extreme? So are these radiological units inbuilt into the theaters?
Right. So there are facilities where they've got hybrid theaters, but the facilities where I've worked previously, it's simply a question of using a mobile C-arm that's equipped with digital subtraction angiography. And the example that I can give you is this type of machinery will cost you about 25% of the cost of a CT scanner. Parenyatwa Hospital has a CT scanner. So this is not an outlandish capital investment, but that can be wheeled into the theater just as you do with the current image intensifiers and give you the angiographic capability. Machines like that are used to do endovascular aneurysm repair, and they're more than adequate for this sort of treatment option.
Thank you so much. Dr. Nyakura, please go ahead with your question.
Thank you, Dr. Zige. I'm Dr. Nyakura Michael from Victoria Falls, Obs and Gyne. Thank you so much, Dr. Chatura, for the quite informative presentation. I have concerns on the issue to do with the uterine artery embolization postpartum. Okay. Patients with postpartum hemorrhage, they can quickly deteriorate and you can lose a patient within a few minutes. If it's really the case with the uterine artery that you have highlighted, you can embolize. May you please give us more detail on how this is done? I'm really concerned about the time it would take for someone, for an interventional radiologist to come in and embolize the arteries in a patient who's having severe postpartum hemorrhage. If you can clarify how much it will take and the other logistics are involved in embolization.
Thank you very much, Remy. So, look, I really love that question that you have brought up, because it really highlights that what we need is to really be sitting around the table and having constructive discussions on how we can bring these techniques in. Let me give you an example. We had a patient transferred this last week from Bulawayo to Harare, a patient with chronic pancreatitis, recurrent bleeding requiring transfusion from a gastroduodenal artery aneurysm. He is on a top-of-the-range US-based Nostro medical aid scheme, which had authorized payment for a Whipple's procedure, tens of thousands of dollars. We were asked to embolize this gastroduodenal artery because there were questions about his surgical suitability. The procedure, the embolization procedure, took us 30 minutes from start to finish. Getting pre-authorization from his nostril medical aid took almost 2 days, while he was sitting in a hospital bed waiting for us to do the procedure. So these are some of the things that we need to start brainstorming and thinking about. It's not a silver bullet, it's not for every patient, but surely if we can institute this and save 1 or 2 patients, that's a big difference for me. So yes, I'm not saying we should delay urgent intervention while trying to call in an interventionist, no, but there are clearly patients, a subset of patients who can benefit from this. And it's about us deciding whether there is a will and finding out how we can start to institute this.
All right, thank you so much for the response, Dr. Chatora. Very exciting times that we are having here. It was a pipe dream to think about radiological intervention in gynecology, let alone in obstetrics. Thank you for bringing this up into our country as well.
Thank you very much, Doc.
My next question, sorry, Dr. Zige. My next question goes to Dr. Morewa Nema. Thank you so much, Dr. Grant, for the nice presentation, very informative as well. I'm not sure whether I didn't hear you correctly or it was a slip of the tongue. You said we should not use progestogens or norethistone, for example, in the management of fibroids. Please clarify for me the and why the contraindication?
Hi, Dr. Nyakura. So I didn't say that they are contraindicated. I said the evidence is not really convincing in terms of their effectiveness.
Dr. Grant, if you could speak into your microphone.
All right. I hope you can hear me now.
Yes,
we can. Yes, we can hear you now.
All right, so I was saying I did not say that they are a contraindication. They are contraindicated as such. I said the evidence that is available is not convincing that they are beneficial for the reduction or for significant reduction of heavy menstrual bleeding associated with fibroids. That's what's available in the literature.
All right, Dr. Grant. I'm saying this in my few years of practice, I've realized actually this is a drug that has really been beneficial for most of the people with heavy menstrual bleeding. What I agree with is probably not very effective in reducing the size of the fibroids. But in terms of reducing bleeding, buying time to prepare your patient for theater, I think this is one of the drugs that has been really effective in the treatment of patients with fibroid uterus. Thank you for your talk.
Okay, thanks.
Thank you, Dr. Grant, for your answers. And for fertility, has there been a follow-up on the ovarian reserve after embolization?
Sorry, I didn't quite get that question.
Okay, let me come again. The question is, with consideration to fertility, has there been follow-up on ovarian reserve after patients have gone through embolization?
Not that I've personally come across, no. It's obviously something that I'd need to look at specifically. The only aspect that I can highlight there, obviously, which are these case series showing what is being interpreted as improved fertility in patients who have had limited fertility secondary to symptomatic fibroids. But in as far as the actual ovarian reserve, I would need to look that up and give feedback.
Okay, thank you. Then Dr. Suddens wrote, may you please explain MRI-guided ultrasound treatment of fibroids? I don't know if you can do that briefly here, Dr. Chatora.
It's something that's really taking off, I would say particularly in China. But it's basically the use of high energy ultrasound for fibroid treatment as being something that's even less invasive than potentially uterine artery embolization. it's exciting, but it's still a way away. We still need to get a little bit more information about the durability of this technique. But again, if you just think about it, the ability to treat fibroids without actually even putting a needle to the skin, it is exciting. But it's very early days for that technique.
Thank you, Dr. Sadons. I hope you've been answered. Dr. Magure, please go ahead with your question.
Okay, thank you very much, Dr. Chatura, for such an exciting presentation. We're excited that we have more options for our women. I wanted to ask about one of the criteria. We said it's an option available for fibroids more than 3 centimeters. Do you have a criteria for do you have an upper limit of the number of fibroids and the size of the fibroids that can be, where women can be offered this option? Thank you.
Thank you very much, Dr. Magure. So, as with some of these things, these figures tend to be drawn up almost in an arbitrary fashion. The 3 centimeter figure came up because those randomized controlled trials that we looked at, EMI, REST, picked a figure of 2 centimeters. So then the guidelines have adopted the 3 centimeter mark. In terms of the number of fibroids, no, there is no limit on the number of fibroids. There is, however, the upper limit on the size of the biggest fibroid, where 15 centimeters has been taken as being a level above which embolization is unlikely to give you durable benefits in terms of your quality of life, pressure symptoms, and so forth. So number of fibroids, not an issue, but the size of the largest fibroid is the one issue that we do need to bear in mind. And greater than 15 centimeters, yes, that's one where the current consensus is that's beyond the capabilities of embolization.
Thank you. Dr. Mhlanga, your hand is still up. Did you have another question? And whilst I wait for your response, Dr. Chatura, the pre-treatment of fibroids distorts anatomy surgically. It makes the uterus softer when we pre-treat it with gonadotropin-releasing hormone agonists. Does this distort the anatomy when you want to do interventional radiology, or it is of no consequence and we can happily give women pre-treatment with these gonadotropins agonists?
Yes, so fortunately, because the iliac arterial structures are quite well tethered along the pelvic sidewall, it doesn't make a big difference from an interventional point of view. So it's not even something that I would, routinely quiz the patient about and so forth. So no, okay. That doesn't have a bearing.
Okay. I'm going to entertain questions even from our first session. I believe we didn't get enough time to. So if anyone has questions for the first session that we have, please go ahead and ask these questions. Whilst I await more questions, Dr. Chatura, how do we you said there's a risk of vaginal discharge. How long should we wait until this vaginal discharge subsides before we introduce any treatment? And when should we worry that this has been prolonged vaginal discharge, and what should we do if this is a complication?
All right. So obviously, in as far as your routine investigations for a lady with a vaginal discharge goes, those obviously all apply, the microbiology assessment and so forth. I do believe that this is something that you expect to have settled within 2 to 3 weeks. Anything beyond that, then yes, we do need to be coming around the table to decide if anything additional is required. But the percentage risk of that is, again, as highlighted, very low.
Hello, Dr. Ziki.
Yes, please go ahead, Dr. Kasongo.
Yes, thank you so much, Izzy Kasongo. I need to ask Dr. Chatura, why not speed up to train also others about this helpful techniques, so we can end up to have one in Bulawayo, one in Big Force, one in Mutare for this helpful process. Just speed up to train others.
Sure. Thank you very much. I think that that is a very, very fair question. And one of the things that I highlighted earlier is the main constraint for us to begin with was the actual hardware, getting the good quality digital fluoroscopic equipment in that will give you the quality of images that you need to be able to access those small arteries. We've got that now. We've got a service running. In terms of training, the Department of Radiology locally has started a radiology training program, which we'll be glad to participate in. And hopefully this is something that can be incorporated, that is intervention in general, into local training. And yes, we do aspire to have, decentralization of this service, because I believe it can really add value.
Whilst I wait for more comments. Yes,
yeah,
please go ahead.
Dr. Chatora is Dr. Georgievich speaking. I just wanted to comment on that issue with medical aid. I recently sent a patient to you and I was very positively surprised. Medical aid, CMAS, is covering 2/3 of the costs, full costs of your embolization for the multifibroid uterus. That woman has 20 fibroids. So I'm very optimistic that other medical aids will join. That was the only comment I had.
Thank you very much, Dr. George.
There's another question on the chat box. What is the risk of embolizing other pelvic organs? This is from Daniel's iPhone.
Thank you. Well, the thing about the pelvis, whether it's the female pelvis in uterine artery embolization or the male pelvis in prostate artery embolization, is it's divided into literally blind ending pathways. So once you are in the uterine artery, you can't really send your particles anywhere else, unless if you over-embolize and your particles start refluxing back beyond your catheter. But because you're doing it under fluoroscopy, you're watching your particles as they flow. The only way that could happen is literally if you close your eyes as you're embolizing. So it is very safe from the point of view of non-target embolization.
And this is another question on the chat box where the question is not very clear. It says may have missed the pregnancy complications in women who fall pregnant post embolization. What should we be on the lookout for in these patients? And in addition to this question, Dr. Chatora, I have read that these women are prone to preterm pregnancies and they're prone to increased miscarriage risk. But I sort of got an answer where you said there are studies which are actually showing the converse to be true. So you may go ahead and answer that question.
Thank you very much. So it's a dynamic scenario where for a long period of time, embolization was used for the older patients. And as the patients who are being given the treatment are getting younger and younger, we are starting to see a difference in this trend. But yes, as it stands at the moment, patients who do fall pregnant after uterine artery embolization should have a close eye kept on them. The things that we're looking out for are things like intrauterine growth restriction. We're looking for placental attachment complications, and obviously issues to do with preterm labor. It's not a big percentage. You're not looking at a percentage that's sort of 30, 40, 50% no, but they are at higher risk of these issues. But again, remember, we're dealing with a cohort of patients who have previously been significantly subfertile. So this is, yes, these are aspects that we do need to look out for. So yes, if and when they do conceive, these are pregnancies that do need to be monitored very closely.
So it is no longer an absolute contraindication that this is treatment for a woman who intends to fall pregnant. Because I'm sure there are some guidelines where I've read that you should not advise this for women who plan to fall pregnant.
Absolutely, absolutely. So, and again, unfortunately, as I highlighted during the talk, this is one of those areas where it clearly will not be possible to have randomized controlled trials. What we do have available are various case series. I've come across case series from South Africa and so forth, and this is what we stand guided by. But at the moment, yes, the way that we are approaching it locally is not an absolute contraindication. Patients are being counseled that if subfertility is an issue, they are reported cases of patients then falling pregnant, but if they do, the pregnancies do need to be closely monitored.
May I remind participants that you can please go ahead and ask questions even from the first session. And I see one more question. Is there concern with Asherman syndrome after embolization?
For me, it's not one that I've come across. Again, this is something that it's an interesting question that I will definitely look into. But as of now, as of how we are operating, no, it's not something that I've come across.
All right, I think that's it with regards to the questions that I had. Thank you so much for that stimulating and very insightful presentation to Dr. Grant Mrevanema and Dr. Chatora. And if there are no further questions, I can declare this session closed.
Thank you.
Over to you, Dr.
Thank you so
Wirenga.
much, Dr. Zigi. Maybe to just comment, Dr. Chatora, before you go, Dr. Wirenga, probably what do you think if we say for what's fibroids we see them, women, sometimes in young women who desire to have children or who are planning or who are actually struggling to have children, these fibroids, that may probably come to you for uterine artery embolization. So I wanted to suggest that probably, I think selection of these kind of patients for uterine embolization should be done very carefully, with abundance of information to the patient with regards to the issues to do with their future fertility, if they are to get uterine embolization as an alternative to surgery. If somehow we feel that the myomas are the ones that are making pregnancy difficult. So I don't know what you think, that probably this type of patients might need to be counseled in a special way with lots of abundance so that they make informed choices to say they don't want to go for this procedure or not, knowing that there is a small but possible risk that this may affect their fertility.
Absolutely. I completely agree. And I hope that this is something that did come across clear during my presentation, which is not just according to the guidelines as they stand from NICE, the Royal Colleges, and so forth, but also from what we see from the randomized control trials. These procedures do need to be consented to by patients who have got adequate information. And because you're ranging from getting to a point where you've probably got improved fertility, but on the other hand, you've got a 1% to 2% risk of going into premature menopause. So this is a situation that has to be approached with great clarity and with good informed consent.
Thank you so much. If there are no other questions or comments on this presentation, once again, thank you so much, Dr. Chatora. Thank you, Dr. Grant, for this wonderful session.
Thank you. Thank you very much for the invitation.
I don't know if the first session presenters are still around. Doctors Moyo, I think Doctors Moyo and Dr. Madzire and Matega. Are you in the meeting? I just wanted to pose a question.
We didn't run away, Dr. Wirenga.
Great.
So we are here with you the whole day.
Right. So what is the perception of local women concerning both of your alternatives? Do you know the perception of the local women or local couples? What is the actual perception, both for the egg donation and the adoption? What is the actual perception out there? How do people see this?
Yes, you can go ahead, Dr. Mazir.
Can I go? I don't think, is Jerry still around?
Dr. Moyo, you can go ahead. I thought it was Jerry. You can go ahead.
Oh, all right. To answer your question, when we do the counseling, I remember doing a counseling on one of the women that unfortunately the ovarian reserve was very, very low, and we're faced with a situation that we're not going to be able to achieve. And I explained to her that we now have to opt for donor eggs. And she was, surprisingly, she was quite happy. You know what? It actually means I'm carrying my husband's child. I'd rather do that than have him go and have the child somewhere else. They're so happy about that. Women quickly adjust to their situation, and they are happy to be assisted, and they love these kids. I don't do many sperm donations. I don't know how men receive children that were born from sperm donations, but from egg donations, I know a lot of couples that are very happy, and I've got a number of couples that have actually come back for a second child, again from a donor egg. So they're happy. They're very, very happy.
I will also come in there. I will probably focus on the issue of adoption. Not that I oversee a lot of these. I've just had one or two people making inquiries on adoption. I will take you back to 2016 of November when we had our scientific meeting, and Professor Mjanja did give a talk on adoption, the forgotten alternative to fertility issues. He did give his perception, I think in his 10 years of personal experience, in his 10 years experience from 2006 to 2016. And he noted that from 2006 up to 2016, 59 couples in his practice or individuals were cancelled and had been referred to the district welfare offices for issues to do with adoption. And in that 10 years, only 5 couples or individuals managed to complete the process and took up the adoptions, and which was a conversion rate of around what? Around 8%. It's probably very difficult to make a direct conclusion whether it directly affects how people perceive adoption as such. We might probably have to get probably more information, because I think it's the social welfare department that sees most of these adoptions issues as opposed to the gynecologist in medical practice. I think it would be very interesting possibly to try and actually engage the department and actually see what has been happening behind the scenes. We only probably interface with these patients when they come to make inquiries, and after time we then send them to the social welfare where they get this assistance with the adoption.
If I may add, it looks like the adoption process itself in Zimbabwe is very, very complicated. We also use it in IVF for the surrogate mothers to convert the name of the mother into the parents, the biological parents. You have to use some sort of adoption law. The lawyers complain that adoption processes in Zimbabwe is so difficult. I think maybe since COVID is probably gone, we have to start engaging the relevant authorities for amendments of certain sectors of that act, so that people can be assisted without too much hassles.
Yeah, Jeff, if I may also come in, I've had a patient who's also a close friend of mine who went through this adoption processes. It's actually not very user-friendly. She was now explaining to me the actual process that you go through. You have to register clearly with the social welfare department. But what they do, this is her reporting this to me. I can't hold it true, but I have no reason to believe that she's lying. When you go there and you register
Yes, we do here.
Sorry.
Admin, please.
Yeah.
Let me try and mute these people.
What do you want to
I think Dr. I think there's a baby playing with Dr. Vyosha's laptop.
That sounds better now. So what she was telling me was you go there and you put an appointment. The people in the social welfare department will come to your house. They want to see your pay slips. You go through police checks, fingerprinting, and the like. But what she didn't really like was when they are coming to your house, they don't put an appointment. So you should just expect them. And they say this is done to make sure that they see your home as is at any given time. So you can imagine if they see you with your bottle of whiskey or something on a Saturday, they might decide that you are not the most appropriate person to adopt somebody. So she told me that she felt that the process was almost making her the victim rather than someone who wants to assist herself and assist another soul. So I think when we have an opportunity to engage them, maybe we could find out the actual adoptees and what they went through, and maybe lobby them to try and change a few systems to make it a bit more user-friendly. Thanks.
Dr. Renga, probably I suggest maybe you can take advantage of the extra time we managed to garner and probably move on to the next session.
Good afternoon, everybody. The next session is not quite yet in place. If you can just give us a few minutes to sort ourselves out, we'll be back with you quite soon.
Can I suggest that those who are not speaking and just attending, you can turn off the videos to take away the distractions? If you can, thank you.
Probably while we are waiting for our next presenter, maybe we can take just a 10 minutes break, maybe a water break. Then by 10 past, around 10 past, 12 past, we can come back and hopefully we'll be starting at 12:15.
Very good afternoon to you all. It's now 10 past 12. We will start the third session of our presentation today. The third section is going to be on gynecology oncology, and I will be leading this section. My name is Dr. Makoni Mbezai. So apologies, we have a slight change to our program. If you notice, our program is saying we're supposed to be discussing the use of advanced imaging in ovarian cancer. We have shifted that presentation. There has been a family emergency which Dr. Chakanani had to attend to. So unfortunately, you'll not be able to be with us today. So we are going to move on to the next presentation on the timetable, which is the use of advanced imaging in endometrial cancer. This talk is going to be given to us by Dr. Maita Zhenu Chatora, who is a consultant radiologist at Medical Imaging Center, as well as World Women Clinic. She obtained her medical degree from the University of Zimbabwe and then continued her postgraduate training in the United Kingdom. Following completion of her radiological training at the Nottingham University Hospital's NH Trust, she was admitted as a fellow of the Royal College of Radiologists in 2010. She then went on to complete a 2-year breast imaging fellowship at the Nottingham Breast Institute. She has a long-standing subspecialty interest in all aspects of women imaging, cross-sectional and oncological imaging. So I will leave this time over to Dr. Maita Zhenu.
Good morning. Thank you very much for the introduction. And thank you again to the organizers for inviting me to speak. Can you please allow me to share my screen? Dr. Makoni, I'm unable to share my screen.
The host, can you please allow her to share the screen? I have no host rights at the moment.
Okay, I think I'm there. Can you see that?
Yes, we can see your screen.
Okay. Right, so the objectives of my talk are to discuss the role of imaging in endometrial cancer with regards to diagnosis, staging, and follow-up. So endometrial cancer is the commonest gynecological malignancy in developed countries, with much lower incidence in developing countries like ours. 95% of patients are greater than 40 years of age, with a peak incidence in the 6th and 7th decade of life. Only 20 to 25% are diagnosed before menopause, and studies are showing a rising incidence with increasing life expectancy. And because the majority present with PV bleeding early, it is not a common cause of cancer death. So in our local setting, you can see that endometrial cancer is relatively rare compared to other gynecological malignancies, notably cervical cancer, accounting for only about 2% of cancer cases in women. And this is the latest report from our National Cancer Registry. So in 2017, we had 86 new cases of endometrial cancer, and 26 women died from endometrial cancer in 2017. So as I stated, abnormal uterine bleeding is the most common clinical presentation. The majority, because of their age, present with postmenopausal bleeding. And the first line imaging modality is ultrasound. So what we're looking for is a thickened endometrium in the context of abnormal bleeding. And when Doppler is applied, the tissue may demonstrate increased vascularity. But endometrial thickening can also be due to benign pathology, such as endometrial hyperplasia or polyps. But ultrasound features suggestive of endometrial cancer rather than benign pathology include irregularity and heterogeneity of the endometrium, the presence of a polypoid mass lesion, and frank myometrial invasion with disruption of the endometrial myometrial junction, And you can see those features in the image on the left. But however, regardless of the sonographic findings in the context of postmenopausal bleeding, if endometrial thickening is greater than 5 millimeters, this requires endometrial sampling. So the histology, 90% will have endometrioid adenocarcinoma, divided into 3 grades, remaining 10% having atypical histologies. And the histology can also be divided into type 1 and type 2, which is important because type 2 patients have a worse prognosis and they're more likely to have disease that has spread at presentation or recur after treatment. FIGO staging, the latest update was in 2009, and it is a surgical pathological system whereby the patient undergoes the listed surgical procedures that then feed into pathology and into the FIGO staging, and currently imaging is not incorporated into FIGO staging at all. So why do we scan all of these patients? Well, what we want to do is to ideally predict which patients are going to have nodal metastases to be able to influence the surgical management of patients. And I know Dr. Gouget is going to give more information about this in a later talk. So the depth of the myometrial invasion is the strongest predictor of nodal metastases. So if you have greater than 50% myometrial thickness, this translates to a 6 to 7 times increased risk of pelvic and para-aortic metastases, and these patients should be considered for more aggressive surgery. Cervical stromal invasion is another predictor, as well as your high-risk type 2 histologies listed there. So the histological information we can get obviously from the endometrial biopsy, but it's important to note that this can be inaccurate in 20% due to sampling error, and often tumors can be upstaged at the final histology. And information about the depth of the myometrial invasion and cervical stromal invasion can actually be assessed preoperatively on imaging, and this is where radiologists come in. So in terms of the best imaging modality to use, MRI with its high intrinsic soft tissue contrast and ability to depict uterine zonal anatomy is the imaging modality of choice. So it has been proven to be the most accurate in terms of determining your depth of myometrial invasion and cervical stromal invasion. So on the right, you can see a sagittal reconstruction of the pelvis on CT, contrast enhanced, and you can see that CT offers very poor soft tissue contrast for reliable local tumor staging when it comes to looking at depth of myometrial invasion and cervical stromal invasion. But it does play an important role in assessing for extrauterine spread of disease, looking for distant mets, and assessing the abdominal and pelvic lymph nodes. So these are the latest European Society of Medical Oncology guidelines with regards to the role of MRI following endometrial sampling. So for your type 1 histologies, your grade 1 or grade 2 endometrioid adenocarcinomas, they recommend the role of MRI is basically to select patients with stage 1A disease who are at low risk for lymph node mets and would not benefit from lymphadenectomy. So for your type 2 histologies, so your grade 3 endometrioid adenocarcinomas or non-endometrioid carcinomas, the main role of MRI is to assess for the presence of extrauterine spread and determine the extent of extrauterine spread so as to facilitate the treatment planning. And for these patients, they also recommend whole body imaging with FDG PET, obviously where available. It's not available in Zim at the moment, and also CT to check for distant mets. These are published guidelines from the European Society of Urogenital Radiology with recommended MRI protocol. And basically they recommend TT-weighted imaging in 2 planes, so sagittal and axial oblique. So the axial oblique is a very important sequence because it is basically perpendicular to the long axis of the endometrium. So it allows you to properly assess the radial extent of the tumor. They also recommend diffusion weighted imaging, and I'll go into more detail about this later, with a minimum of 2 B values, so 0 and the second one higher between 800 and 1000. They also recommend dynamic contrast enhanced imaging or a single phase at 2.5 minutes, because at that point you get maximum contrast between the tumor and adjacent myometrium. So if it's a supervised study and the radiologist is able to review the images, you can actually omit the contrast enhanced sequences if the tumor is noted to be small and confined to the inner myometrium. They recommend lymph node assessment in all patients as well. So from an axial T2 from the renal hilar down to the pubic symphysis. And they also recommend DWI if it's a high-risk patient with type 2 histologies, because DWI is very sensitive for picking up lymph nodes. But if the patient is going to have a CT scan anyway, there's necessarily no need to necessarily do the lymph node assessment on MRI. So just a very quick revision of the normal zonal anatomy before I move on to show you some MRI images. So the endometrial complex is high T2 signal, so high signal on T2. The outer myometrium is slightly hyperintense compared to the junctional zone or the inner myometrium, which is hyperintense. And the difference between the inner and outer myometrium is simply just the density with which the muscle cells are packed rather than any difference in composition. So then you have your cervix with the internal and external os. The internal os is not a defined anatomical position, but it is where you see relative wasting of the uterus. And cervical stroma is low signal intensity, and it is the inner part of the stroma which lies adjacent to the endocervical canal and is in continuation with the junctional zone. So then you also have your rectus sigmoid, vagina, and bladder. So in postmenopausal patients, the uterus becomes very small and featureless with indistinct zonal anatomy because you've lost that hormonal drive that maintains these features. So this is just to show you the conventional MRI appearance of endometrial cancer on MRI on T2 weighted image. So it is of intermediate signal intensity. So in the first two images, you can see the intermediate signal T2 tumor on the background of high signal endometrium. The smaller tumor in the middle image, again with background high signal T2 endometrium. And in the last image, you can't see any normal endometrium at all. So it's all just intermediate signal T2 tumor. So diffusion weighted imaging, it's a special form of MRI, functional imaging technique that is based upon measuring the diffusion or the random Brownian movement of water molecules within tissue. So on DWI, very cellular tissue, such as endometrial cancer, shows restriction of movement of the water molecules. So what you see, so this is your sagittal T2 with the intermediate signal tumor in the endometrial cavity. And on the high B values, you can see high signal intensity. And on the ADC map, so ADC stands for apparent diffusion coefficient, you can see restricted diffusion. So that is the low signal intensity that you see within the endometrial cavity. So the importance of the sequence is that the depth of the myometrial invasion is occasionally unclear on the T2 and contrast enhanced imaging, and DWI can help us to clearly demonstrate the local tumor extent because you get a very high signal intensity on your B values. And also DWI, as I mentioned, is very sensitive at picking up lymph nodes as well. Dynamic contrast enhanced sequences are important as well. So endometrial tumor is hypo-enhancing compared to the avidly enhancing myometrium, as you can see on the right. And the maximum contrast occurs at 2 minutes and 30 seconds after contrast administration. So studies have shown that contrast, the presence of contrast, increases radiologists' confidence in the staging, but not necessarily the overall interpretation of the stage. So this is a bit of a controversial issue. Some protocols omit contrast enhancement altogether, but it is of benefit when you're trying to exclude cervical stromal invasion, because if you can see an intact enhancing cervical stroma, then essentially you can exclude stromal invasion. So to show you some images of contrast enhancement of endometrial cancer. So as I said earlier, it is hypo-enhancing relative to the myometrium. So the top images are your sagittal T2 images, and the bottom ones are the contrast enhanced images. So you can see that following contrast administration, the endometrial cancer is hypo-enhancing relative to the avidly enhancing myometrium. So this is an example of tumor within the endometrial cavity with intermediate signals. So this is your sagittal and axial oblique. And this is a very beautifully done axial oblique image. So it is done perpendicular to the long axis of the endometrial canal. So it allows you to really clearly see the radial extent of the tumor. And in this patient, you can see that the endometrial-myometrial junction is preserved, and there is therefore no myometrial extension. The cervix, the vagina appear normal. You can see nice enhancing intact cervical stroma. So this is a FIGO stage 1A tumor, and this patient is at low risk for nodal metastases. So this is another patient. So you've got your sagittal and axial oblique T2 images. You've got your contrast enhanced images. You've got your DWI and ADC, and you can see restricted diffusion consistent with hypercellular endometrial malignancy. And this is a much more extensive tumor, which is filling and expanding the endometrial cavity, and it is definitely going into the myometrium, especially anteriorly there. But here, though, the question comes, how far is it going into the myometrium? It's probably going more than 50%, but is it going all the way? Are we now reaching serosal breach? So this is where contrast enhancement really makes a difference. And on the contrast enhanced sequences, especially the axial oblique sequence, you can see that there is actually a rim of avidly enhancing myometrium all the way around. And although tumor is extending more than 50% anteriorly, it is not going through. So this is FIGO stage 1B disease. And also tumor does not extend into the cervical stroma. So there are some pitfalls in assessing the depth of myometrial invasion on MRI, and I've listed some of the conditions here. The most common, adenomyosis, fibroids, polypoid lesions. So with adenomyosis, you get widening of the endometrial-myometrial junction, so which can make assessing the depth difficult. Again, with fibroids, it alters the thickness of the myometrium. So again, it makes it difficult to determine whether it's less than 50% or greater than 50%. And in conditions where you have so postmenopausal patients with very thin myometrium, again, this makes it difficult to determine. If you have disease going into the cornua or into a cesarean section scar, you have thinner myometrium at these sites, and again, this makes it difficult to determine. And studies have shown that 73% of incorrectly staged cancers had coexisting benign myometrial pathology, so it's important to bear this in mind. So this is a case of cervical stromal invasion. So you can see tumor, intermediate signal on T2, on the sagittal and axial images, which is filling and expanding the endometrial cavity and is extending down into the cervical stroma, with loss of the low signal intensity cervical stromal ring. And this is consistent with stage 2 disease. So pitfalls to cervical stromal involvement. So if you don't have true oblique imaging through the cervix, for example, in the last case, it's not, especially at this level, it's not entirely perpendicular to the cervix. It can be difficult to determine whether there is indeed cervical stromal involvement or not. So technique is important. Also, where we call the internal os may be different to where pathologists call it. And in some cases, stromal invasion may occur directly from the myometrium without involvement of the endocervical canal. In a small subset of patients, it is unclear whether a patient has endometrial or cervical cancer, because the histological differentiation can be challenging, and imaging plays a part in this as well. So we can assess the radiology growth pattern to differentiate between the two, and this can then be used to direct management. And this is important, as you know, because the treatment regimes differ completely. So features favoring endometrial cancer are the epicenter of the mass. So if it is centered over the body of the uterus, and also if you have tumor within the endometrial cavity. Whereas features that favor cervical cancer, necrosis, especially with most cancers are squamous cell. If you have early bladder invasion, and if you have fistula formation, that would make you decide whether this is, that this is cervical cancer rather than endometrial cancer. So FIGA stage 3C is nodal metastases. And as I mentioned earlier, this significantly alters the prognosis. So we use the measurements, so size, as well as morphology to assess for abdominal and pelvic lymph nodes. So with regards to the size, we use the short axis diameter. So for pelvic nodes, this is a maximum of 8 millimeters and up to 10 millimeters for abdominal lymph nodes. And we also use morphology because sometimes you can have small lymph nodes that don't meet the size criteria, but that can look suspicious because they have a rounded appearance. They've lost the fatty hilum, irregular contour, necrosis. They can be clustered, and they can also have similar signal intensity to the primary mass, and this can also be suspicious. So as I mentioned earlier, diffusion-weighted imaging can help to identify small nodes, but studies are showing that it is limited in predicting which ones are actually involved by tumor. So on the images on the right, you can see some small iliac lymph nodes. And on the bottom image, which is the diffusion-weighted image, you can see how easily you can see these on the with high B values. It's important to have knowledge of the lymph node drainage on imaging because endometrial lymphatic drainage is complex. So lymph node metastases primarily spread along pelvic pathways, but it does depend on the site of the primary tumor. So if the tumor is found in the middle and lower aspects of the uterus, it drains through the parametria through to the obturator lymph nodes. If tumor is within the upper corpus and fundus, it drains via the hypogastric route through to the interiliac lymph nodes, common iliac lymph nodes, and then posteriorly to the paraortic lymph nodes. But fundal tumors may follow the paraortic pathway through the gonadal vessels and drain directly to the paraortic lymph nodes, bypassing the pelvic lymph nodes. So it's important to check this area for patients who have fundal tumors. So this is an example of pelvic and paraortic lymphadenopathy consistent with a stage 3C disease. And you can see a large tumor in the pelvis associated with right iliac lymph nodes with necrotic centers, and also left paraortic nodal mets at the level of the renal hilum. So finally, a case of an example of stage 4 disease. So this enhanced CT demonstrates a large heterogeneously enhancing mass within the pelvis. You can see that there's extensive bilateral iliac lymphadenopathy, particularly on the right, that is now causing moderate hydronephrosis with clubbing of the helices. And you also have an omental deposit. So we've seen the role that imaging plays by providing a preoperative roadmap that helps us to determine which patients need more extensive surgery, but it also provides important considerations for surgery, such as uterine size to assess suitability for laparoscopic surgery. Also, if there's pelvic adhesions or endometriosis, abdominal wall hernias, again, important if you're considering laparoscopic surgery, and also to assess if there are any normal variants, again, which can affect the type of surgery that's planned. So imaging also plays a role in surveillance and follow-up of endometrial cancer patients. So following treatment, local regional recurrence is low. It occurs at a rate of only 4 to 8%. 25% of recurrences occur within 6 months, and 98% occur within 3 years. So the routine use of imaging is therefore not recommended, given the low rate of local regional recurrence. However, it should be considered in patients who are at high risk. So these are patients who are older than 60 years, patients with aggressive histological subtype and grade, especially if they had close resection margins. And sometimes recurrence can occur prior to adjuvant radiotherapy. Patients who had lymphovascular space invasion, and patients with a high FIGO stage. So MRI can determine the extent of local recurrence and the appropriateness for resection and radiotherapy. And a PET-CT is quite good at determining if recurrence is localized or disseminated. So this is an example of an intrapelvic lymph node recurrence 12 months after surgery for endometrial cancer. So on the axial T2 weighted image, you can see it measured 9 millimeters external iliac lymph node, which is just above the upper limit of normal. And again, you can see this is the axial DWI, just showing how sensitive it is for picking up lymph nodes. And it shows a focal hyperintense spot. And then on your axial contrast enhanced, all you're seeing is just a bit of rim enhancement, but they followed this up and the lymph node increased in size, confirming lymph node recurrence. So to summarize, the imaging in the management of endometrial cancer has become routine, and the main role is in the pre-op identification of women with high-risk cancer in need of more extensive surgery. First-line imaging modalities ultrasound, but MRI is the gold standard for pre-op local staging when you come to assessing the myometrial invasion, cervical invasion, and cervical stromal invasion, as well as surveillance for local disease recurrence. Functional MRI with DWI and contrast enhancement can also improve accuracy of local staging and detection of nodal metastases. CT and FDG PET are best suited to assess the extent of extrauterine disease and distant mets. Thank you very much.
Thank you very much, Dr. Chatora. We were insinuated and enhanced the issues, and yeah, we were learning. Thank you for that. We'll hold on to our questions and allow Dr. Guja to give us the talk that he has prepared for us. So Dr. Guja is one of us. He is a gynecologist, and he's a subspecialist in the gyne-oncology. He is one of the 2 gyne-oncologists and lead surgeons at Parenya Group of Hospitals, and is involved in the running of the gynecology oncology services, which includes cervical cancer screening, chairing of the gyne-oncology tumor board, and is also involved in a research on cervical cancer prevention. He endeavors to improve clinical standards in the institutions to meet international standards, and his goal, his main areas of interest are gynecological cancer screening, minimal access surgery in gynecology oncology, and also to maintain significant involvement in research, particularly training in the low-income countries, advances the development of continued higher standards in care of gynecological oncology cases worldwide. So today he's going to give us a talk on the use of advanced imaging in tailoring lymph node dissection in endometrial cancer. So over to you, Dr. Guja.
Okay, thank you very much, Dr. Makoni, for that very kind introduction. And I would like to thank Dr. Maita Chatora for such an eloquent talk. I think she has made my job much easier. So this is basically the outline of my talk. And just a moment, I think I've okay, I think that this is basically the outline of my talk. I'll just share a slide on postmenopausal bleeding. I'll talk a bit about epidemiology. I'll talk a bit about the histological variants and outcomes. I think Maita has already hinted about this. I'll talk about surgery for endometrial cancer, and I will talk about use of imaging and triaging patients for lymph node dissection, and I'll end up giving you a glimpse into the future. So basically, when a woman lands into the gynecology clinic with postmenopausal bleeding, when I always ask the students, what percentage of women do you think would end up with endometrial cancer? I get figures like 80%, 90%. But when a woman has got postmenopausal bleeding, it's only 10 to 15% of those patients who end up with endometrial cancer. However, endometrial cancer is the most serious diagnosis, so it needs to be excluded. It needs to be excluded first in managing these patients. But looking at it from another angle, it means a lot of these patients who come in, they've got benign conditions and they don't need a hysterectomy, and they can be managed with hysteroscopy and medical treatment, for example, if they've got hyperplasia without atypia. I think Dr. Mvere has already talked a bit about the epidemiology. So I think in the Western world, cervical cancer, endometrial cancer is the commonest malignancy. But if you look at data worldwide, it's the second most common gynecological malignancy after cervical cancer. But it's completely opposite if you go to the Western world, because cervical cancer is not very common in that part of the world. So it becomes the most common gynecological cancer. Then if you look at the mortality, so you actually find that it's actually the 8th most common cause of mortality in females. I just went through our Zimbabwe Cancer Registry for 2017. So if you look at Black women, actually it's the 10th most common cancer in Zimbabwe. So it's not as common as in the Western, as common as in the Western world. But if you look again at our Caucasian population, it's actually the 9th most common cancer in women. But I would want to hasten and say that our statistics most of these patients actually end up going to South Africa for their treatment, and they might not be captured in our statistics. So there's just a bit of that problem when you look at these statistics of Caucasians in Zimbabwe. So a patient with endometrial cancer who lands in your office is likely to be around the age of 63. That's median age of presentation. They're likely to be obese, diabetic, and hypertensive. And I think 80 to 90% of those patients are going to have what we call type 1 endometrial cancer. I'm going to give a talk on molecular staging, because I think that's the in thing. People are moving away from the clinical pathological staging to use of molecular staging. But if you look at the clinical pathological staging, 80 to 90% of patients are type 1 and 10 to 20% of patients are type 2. And when you look about molecular staging, you look at these different mutations, and then you end up kind of like coming with staging of those patients using those molecular typing. And that's what's happening in the rest of the world, and that's probably the future, but we are still a long way from that. I think all endometrial cancers are not the same. So if you look, the majority of patients who present with 75 to 80% of patients who have endometrioid carcinoma, which is basically a histological variant with best prognosis. So other patients would come with, the second maybe common would be uterine serous, very poor prognosis, clear cell carcinoma, very poor prognosis, and carcinosarcoma, a very poor prognosis. So carcinosarcomas used to be considered as sarcomas, but that has been changed, and they're now kind of like classified as carcinomas. So I think the message that I want to bring home is, if you've got a patient with endometrial cancer in front of you, it doesn't mean that all of them, they've got a very, very good prognosis. So you should be able to differentiate those with endometrioid with a good prognosis and those with other histological variants where the prognosis is not as good. I think this slide kind of like brings it home. So if you look at patients with endometrioid, the vast majority of those patients, 73%, who present with in stage 1, and 11% who present in stage 2. So that's 84% of those patients who present with stage 1 or stage 2. But look at those ones with poor prognosis. Only 62% of those patients that will present in early stage. If you look at the 5-year survival, 85 to 90% in patients with endometrioid, it's so dismal in patients with other histological variants. So I want to hammer this point home that when you've got a patient in front of you, it's very, very important to know the histological variant that you are dealing with, because it determines how we're going to manage the patient, it's going to determine how we're going to cancel the patient, it's going to determine how we're going to determine the prognosis for the patient. So before you tackle a patient and take a patient for surgery with endometrial cancer, these are kind of like the intraoperative surgical principles. I've put queries because when I talk about the glimpse into the future, you see that this probably might not still be relevant. But when I was training, we use frozen section. So availability of frozen section to determine the extent of the staging procedure. In other words, when you take out the uterus, you want to know how much of the myometrium is involved. You want to know whether the cervix is involved, and you want to confirm the histological grade. So like what Dr. Mvere was showing us, actually this information, you can get it on an MRI. You can get the depth of invasion. You can get the whether the cervix is involved or not. So this is kind of like falling out of favor. I'll come to that point on my later stage. And before you take a patient to theater, you should be able to do complete surgical staging. Basically, surgical staging is when we talk about lymph node dissection. So you should be able to do both pelvic and paraortic lymph node dissection. I think Dr. Mvere has shown us very, very clear pictures on MRI of paraortic. So if you can't take a patient to the theater when you cannot do the paraortic lymph node dissection, you then palpate and find that they've got paraortic lymph nodes, and suddenly you are stuck. Either you have to kind of call for help, or you're going to leave theater with the patient with still disease in the paraortic area. So you should be actually trained in doing surgery for these patients. I think Dr. Mvere has already kind of like highlighted this, so I'm going to skip it. But safe to say that this is surgical pathological staging. So you actually get the final stage after you've done the operation. But pre-operative imaging, actually, there's a lot of work that has been done to try and see how accurate is pre-operative staging. And I think we've seen very, very clear images from Dr. Mvere's presentation, which brings another point home that when you've got a patient in front of you with endometrial cancer, the imaging of choice for the pelvis is going to be an MRI scan. So there are a lot of patients that are referred to our unit, endometrial cancer, and they've had CT scan of the pelvis. So probably that probably needs to be looked at. If you've got a patient with endometrial cancer, MRI is a far much better choice in terms of local staging. So why do we kind of like go to such lengths to say and do MRIs, to do frozen section in theater? It's because we want to kind of like see patients who have got lymph node involvement. I'm going to talk about, so if you've got a patient with a grade 1 tumor involving the inner half of the myometrium and with no extrauterine disease, you find that the risk of lymph nodes involvement is less than 1%. So that means in this group of patients, you really want to avoid doing lymph node dissection because it's associated with morbidity, it's associated with a longer surgery, and it's not associated with any oncological benefit. So that means it's very, very important to try and pick up this group of women to avoid doing lymph node dissection in these patients. But look at this, once you start having grade 2, grade 3, even if it's involving the inner half, even without extrauterine disease, almost 10% of these patients have got pelvic lymph node dissection, and 4% of these patients have got aortic. If you look at grade 3, now involving the outer half of the myometrium, with or without extrauterine disease, 20 to 60% of these patients have got pelvic lymph node dissection, about 10 to 30% have got aortic. So we should be, in a way, try to differentiate these two groups of patients and try to avoid lymph node dissection in this group But this group warrants lymph node dissection to be able to complete staging. The elephant in the room is, does lymph node dissection improve oncological outcomes? So I want to hasten and say that these studies were done in women with low risk. That means these were grade 1, grade 2, early stage figure 1 on imaging. Does lymph node dissection improve survival? So I'll start with this study published. So prior to 2008, there was no data to kind of like guide to say, should we be doing lymph node dissection or not? So this Italian study by Panici was done in 2008. The question that they wanted to answer is, does the addition of pelvic systematic lymph node dissection to standard surgery improve overall survival and disease-free survival? So they randomized 514 women into 2 arms, one with 264 and other with 250. One group had pelvic systematic lymph node dissection, and the other one didn't have any lymph node dissection done. So they were able to, so definitely what they were able to show that if you do lymph nodes, I think it's no brainer, you're going to improve staging. You're going to pick up more women with microscopic lymph nodes, and you're going to be able to stage the patients in a better way. The median lymph node harvest was about 30. But what they basically showed, for sake of time, I'm just going to summarize this study. They clearly showed that early and late complications were more in the lymph node dissection arm. So if you look at lymphoedema, which is one of the most feared long-term complications after lymph node dissection, it was way more in patients with lymph node dissection. But if you look at overall survival, there was absolutely no difference. So whether you had done the lymph node dissection or not, it looked like there was no difference in overall or even disease-free survival. I want to keep on reminding the audience that these were kind of like stage 1 patients pre-operatively. So this part doesn't apply to kind of like high risk patients. A similar trial called the ASTED trial, a study on the treatment of endometrial cancer, answered almost the same question as well. Does pelvic lymph node dissection improve survival of women with endometrial cancer? 1,408 women randomized into 2 arms, one with 700, similar number of women. One group had standard surgery and the other had standard surgery, as well as lymph node dissection. These studies faced, both this Italian and this ASTED trial faced huge criticism because, like I think what Dr. Mbele has shown, that if you've got a tumor arising from the fundus, it might involve para-aortic lymph nodes without necessarily involving the pelvic lymph nodes. But in both of these studies, there was no systematic para-aortic lymph node dissection done. And if you look at the median lymph nodes that were removed in this study, there were 12. And these studies faced a lot of criticism because of that. But it consistently showed that morbidity was higher in the lymph node dissection arm, but there was absolutely no difference in overall survival. The same findings as the Italian trial. So if you look at these 2 trials together, they show that when you do lymph node dissection, you improve surgical staging, but there's no improvement in progression-free survival or overall survival. But however, I want to hasten and say other non-randomized controlled trials showed the opposite. Progression-free survival and overall survival was better but with lymph node dissection. But if you look at the level of evidence, it's always higher with a randomized controlled trial. So the conclusion from these 2 trials that low-risk patients do not benefit from lymph node dissection, but however, intermediate risk patients you might consider lymph node dissection, and in high risk, you have to perform a lymph node dissection. So the question now is, how do you decide who's low risk? How do you decide who's intermediate risk? How do you decide this is high risk? I won't go into this. Dr. Mbele has done that already. So I think the best imaging of choice is in pelvic MRI. So MRI can look at the depth of invasion, can look at cervical involvement, and of course, you want to interpret it together with your preoperative histology. That's why it's very, very vital that you shouldn't take a patient with a presumptive diagnosis of endometrial cancer without histology, because it's important in triaging the patients whether they are low risk or they are high risk. I won't Dr. Mvere has shown us very, very clear images. I'll skip. So once the surgery has been done, then these patients are kind of like, you have to kind of like look at the histology and put them into these risk groups. So the low risk group, risk of recurrence is less than 5%. So these patients don't benefit from lymph node dissection. They don't benefit from any adjuvant treatment. I'll save this talk for another day, but you can try them. We can then come up with an intermediate risk, high intermediate. So this is very, very important because it determines what type of adjuvant treatment these patients get. So when we are sitting in the tumor board with the histology results after surgery for endometrial cancer, this is what pretty much what you are doing, determining the risk of recurrence and determining what will be the best adjuvant treatment for these patients. So studies have been done to look at the preoperative assessment in endometrial cancer. And if you use the preoperative histology and you use the pelvic MRI to try these patients into low risk and non-low risk groups, how accurate is that? And can we use that in clinical practice? So in other words, can we triage using MRI and preoperative histology to decide whom we do lymph node dissection or not? So I'm going to talk about this study where they looked at 292 women, where they used preoperative histology, they used pelvic MRI, as well as serum CA125, which you don't commonly use in everyday clinical practice. And they used the ESGO, ESMO, ESP risk groups to try and determine who was low risk and who was non-low risk. Just to summarize the study, they found out the sensitivity and specificity of discriminating low and non-low risk were quite high, 96.6% for the sensitivity, but the specificity wasn't very good. It was 73.6%. But however, 9 patients were falsely classified as low risk using this strategy, and one of those patients was classified as low risk, actually had nodal metastasis. In other words, this patient was actually stage 3, was supposed to be high risk, but had been falsely classified as low risk. So I think, like what Dr. Mvere said, there are definitely pitfalls associated with this strategy. So their conclusion was that a selective lymph node dissection strategy for endometrial cancer is possible and would probably be cost effective while not jeopardizing patient survival or patient's quality of life. Then another study done, this was a French study done in 2016, trying to answer exactly the same question. Can we use preoperative histology and MRI to try and triage patients before operation to decide who benefits and who doesn't benefit from lymph node dissection? But in France, they kind of like, at that time, they were classifying patients into low risk, intermediate risk, and high risk, depending on the MRI and the histology findings. To try and summarize the study, they looked at 91 patients, and this was kind of like the specific sensitivity of 70%, specificity of 82%, positive predictive value of 87%, negative predictive value of 61% in detecting intermediate and high risk endometrial cancer. But what this study brought to the fore was actually using this strategy, there was an underestimation in 32% of the patients of their risk category. However, in 7% of the patients, there was also an overestimation. So there are definitely pitfalls associated with this. This is what they were able to show. They showed that MRI underestimated endometrial cancer stage in 20% of cases, which Dr. Mvere has already told us. And this is also very, very important, that endometrial sampling underestimated the histological type in 4% of cases and the grade in 99% of cases. So there were erroneous preoperative risk assessment leads to suboptimal initial surgical management of patients with endometrial cancer. This was their conclusion, to say this has got pitfalls and it might lead you to do the inappropriate surgery. Then you realize at the end, actually, that your patient was a higher stage, needed lymph node dissection, and that has got clinical as well as legal implications. So I think the question in front of us is there a way? I think another way of doing this, I think Dr. Mvere has clearly shown that MRI is useful in triaging these patients to determine we are low risk for lymph node dissection, whom we might not need, so low risk for recurrence of cancer and where lymph node dissection might not be warranted, and those who are high risk where lymph node dissection improves staging. But however, the take-home message is this is associated with pitfalls. So if you've got a patient sitting in front of you, you might say they are low risk, and then you do the operation, find out they are high risk. So in the gynecology world, people don't agree. So you get some units where they do lymph node dissection on every patient, and then you get some units where they still use this type of triaging to determine who gets lymph node dissection or not. But is there another way? I think I'm kind of like going above time. So the glimpse to the future is definitely there is another way. So the other way is doing sentinel lymph node biopsy. So what I'm going to do here, I'm not going to go a lot into kind of like talking about the techniques of sentinel lymph node biopsy. But basically the principle behind sentinel lymph node biopsy is we know that every group of cancers, if you look at their lymphatic drainage, there are specific groups of lymph node lymphatics or lymph node groups where that cancer initially drains into. So in other words, if you inject a dye onto the uterus, and then you assess the first group of lymph nodes that drain the uterus, and they don't have cancer, then probably it means that the rest of the lymph nodes in the basin will probably not have any malignancy. And in those patients, you can spare them lymph node dissection and the morbidity associated with it. But what it then means is even those patients that previously we classified as low risk using MRI, if they've got lymph node involvement, you can then pick it up. So sentinel lymph node biopsy then allows the use, so kind of allows lymph node dissection to be done in all patients with lymph node with endometrial cancer rather than triaging them using MRI before an operation. So these are kind of like the guidelines from ESGO, ESMO, and ESP. So they say sentinel lymph node biopsy can be considered for staging purposes in patients with low risk, intermediate risk disease. It can be omitted in cases without myometrial invasion. So that means MRI is too beneficial. If you don't see any myometrial invasion on your MRI, then in those patients you can skip. But it means that the majority of patients, even with low risk on preoperative imaging, can have a sentinel lymph node biopsy. But however, they no longer recommend systematic lymph node dissection in those patients that are low risk on MRI. So which means that if you come to our local setting, we are still over-treating these patients because we don't have access to sentinel lymph node biopsy, which is kind of like very, very, very frustrating for me. I've called this glimpse into the future, but it's not the future because it's already happening. But because of the obvious reasons, we're not able to do this. So we end up over-treating a lot of our patients with low-risk disease by doing systematic lymph node dissection. Okay, the other recommendation is that surgical lymph node staging should be performed in patients with high intermediate risk and those with high risk disease. So sentinel lymph node biopsy, even in those patients, is acceptable alternative to systematic lymph node dissection. So I did a presentation sometime back in the department in 2019. I think then there wasn't actually enough evidence to support the use of sentinel lymph node in patients with high risk endometrial cancer, but that has changed. So sentinel lymph node biopsy is now acceptable even in patients with high risk disease. But however, so there are a lot of dyes that can be used for when you do the sentinel lymph node biopsy. But indocyanine green with cervical injection is the preferred detection technique. I won't go into the detail about that. At the beginning, people didn't know exactly where to inject. If it's endometrial cancer, do you inject at the cervix? Do you inject at the fundus at hysteroscopy? Do you inject at the fundus with laparoscopy? But I think studies have clearly shown that I think in terms of detection of a sentinel lymph node at the cervical injection site is way more superior, and this is what is recommended. And the dye of choice is your indocyanine green, and you inject on the cervix. So if you don't have it, you can still use the old tracer. They're less optimal, but you can still use them. However, if you don't pick up any sentinel lymph nodes, then site-specific systematic lymph node dissection should still be performed in women with high intermediate or high risk patients. And I won't kind of like labor this point. The way that you assess the sentinel lymph node is a bit different from the normal way that you kind of like the pathologists process the rest, the lymph nodes, like in everyday practice. There's a procedure called ultra staging, where they cut very, very, very thin slices and employ the use of immunohistochemistry to be able to pick up very, very early lymph node involvement. And when a systematic lymph node dissection is performed, pelvic and parietic infrarenal lymph node dissection is suggested. It brings me back to the point where I said, before you take a patient with endometrial cancer to theater, you should be comfortable in doing parietic, because in high-risk patients, we should do parietic lymph node dissection. And that was the huge criticism of those two other trials, the Italian trial and the Aztec trial, because they didn't perform any parietic lymph node dissection. I won't bother you a lot with this, but you should be able to say at these macrometastases, at these micrometastases, there was a debate in the past whether micrometastasis improves an impact on negative impact on survival, but I think that matter has been put to rest. Micrometastasis can affect prognosis adversely, and treatment should be the same as those with macrometastasis. But however, there's another concept where you see where on immunohistochemistry, you pick up isolated tumor cells, whether that improves prognosis or not, or adversely affects prognosis or not. The verdict is still out, but it has to be reported by the pathologist. So if pelvic lymph node involvement is found intraoperatively, so further systematic pelvic lymph node dissection should be omitted. We should only proceed to debulk enlarged lymph nodes, both pelvic and parietic, to complete your staging. I think that was the gist of my talk. I think I'm going to give a talk on some other day as well. There's enough data now showing that even patients with low risk or high risk disease, I think you can use minimal access surgery as the standard of care. So I'm just going to finish by showing, to kind of like on a lighter note, showing the difference between laparotomy and minimal invasive surgery. So these are patients who were treated with endometrial cancer the old way, where they are left with very, very huge scars, funny scars, very, very funny scars, funny scars. And this is in comparison in patients who were managed with laparoscopy. Tiny incisions, very tiny. So if you've done a laparotomy, when the lady goes to the beach, she's going to be the odd one out. These are how it's going to look. In comparison to those who are smiling, we have been managed in the minimal invasive surgery. So they will remember you on their wedding when you've done it in the minimal invasive way. And there's actually some data that is accumulating as well about robotic surgery. So this is what we still do. You go to the patient by the bedside. I'm sorry, it's a male. I couldn't get one with a female. We tell the patient that, hi, I'm performing your surgery tomorrow. It's difficult to say whether this applies today, because in these other units, this is how the operation is now done. Is it the surgeon doing it, or is it the machine that's doing the operation? So in conclusion, I would say prognosis of endometrial cancer varies with histological or molecular subtype. So I think this is probably the take-home message. It's not every endometrial cancer that has got a good prognosis, and you need to do appropriate workup, appropriate triaging, and you need to do appropriate planning for their surgery. And I can't emphasize this more, imaging plays a very, very important role in preoperative staging and planning of surgery. And I said I'm going to come to this point. I think because of poor reproducibility, most guidelines now say that frozen section is now obsolete. I was doing it when I was doing my subspecialty training, but 2 years down the line, this is completely thrown out of the window, which means that imaging is now playing a much more central role in triaging these patients rather than using frozen section in theater to do that. And the gist of my talk is to say sentinel lymph node biopsy balances the benefits of full staging and morbidity associated with systematic lymph node dissection. So it allows you to be able to do surgical staging for all the patients, and you minimize morbidity, especially lymphoedema in those patients where you don't have to do systematic lymph node dissection. I think this is my last point. I think we've said this over and over again, that MDT meetings play a very, very vital role in individualizing treatment. So you remember but if you go through what I've just said today, so it's not there's no kind of like one size fits all when you come to treatment of women with cancer. Every patient is different. The histological type is going to be different. MRI findings are going to be different. So I think we are moving towards, we're in the era where treatment for women with cancer is individualized. And one of the benefits of MDT meetings, it helps with individualized care and helps us to live in this new world of precision medicine. Thank you very much for taking the time to listen to my talk. We wanted to add a third talk, but I think we're going to skip that. And this will be the last talk for this segment. I will hand over to our very able chair, Dr. Makon.
Thank you very much, Dr. Guja, for that very thorough presentation, where you are walking us through endometrial cancer, preoperative, and the role of lymph node dissection in management of endometrial cancer. So I'll open up the floor to questions, both Dr. Guja's talk and Dr. Chatora's talk. If there are any questions, you are free to raise your hand. Areas that would need clarification from what Dr. Vere Chatora and what Dr. Guja spoke about. I'll give this time first to Dr. Ziki. You can ask your question.
Thank you for your presentation. Dr. Guja, you will excuse me if my question is a bit ignorant, but given the complex lymphatic drainage of the uterus, which one would you consider sentinel? Is the one that's picking up the dye first, or you're going to, I'm not really following which one we're going to label as the sentinel lymph node.
Okay, thanks very much, Dr. Ziki, for that very, very brilliant question. So I think that's why you find that with vulval cancer, sentinel lymph node biopsy has been kind of like the standard of care for many years. And I think the cervical cancer kind of like followed. But there's been a very, very huge debate about endometrial cancer. That's why it's just coming to the fore at this moment. So at the beginning, people didn't agree on where to inject. Do you inject on the fundus? Do you inject on the cervix? Looking at the complex lymph node, kind of like lymphatic drainage of the uterus. So a lot of studies were done prior to these guidelines coming into use to try and determine whether sentinel lymph node biopsy was appropriate for patients with endometrial cancer. So in other words, these patients would have a sentinel lymph node, they would have sentinel lymph node biopsy done initially. You pick up the sentinel lymph node and then you proceed and do systematic pelvic lymph node dissection. And then compare the mapping that was found before and compared to these results of the systematic pelvic lymph node dissection. So I think to zero in on your question, a sentinel lymph node biopsy, a sentinel lymph node does not necessarily have to be one. So if you are pick, there can actually be multiple sentinel lymph nodes. So you can pick up an obturator and you can pick up a parietic. You can pick up an obturator or you can pick up a left external iliac. So I didn't bring up the diagram, but there are lots of, from those studies that were done, where the areas where you find the sentinel lymph node. So I think the take-home message that it does not necessarily have to be one, and there can be multiple. And in areas where you don't pick up sentinel lymph nodes, for example, in the left hemipelvis or right hemipelvis, if you don't pick up a sentinel lymph node, that means you have to do systematic lymph node dissection. Thank you very much for that very, very brilliant question. I didn't have time. Maybe one of you guys should take that up and present about the studies that were done to validate sentinel lymph node biopsy in women with endometrial cancer.
Okay, I think Dr. Ziki, you've been answered sufficiently. Any other questions? Anyone else who's got areas that they need clarification on? There's nothing that has been commented. All right. Dr. Chitora, you can go ahead and say what you need to say.
So this is just a question for Dr. Guja. So have any sentinel lymph node biopsy procedures been done at all yet in Zimbabwe?
Unfortunately, not yet. For definitely various reasons. So the first reason being that for you to be able to kind of like do this, you need to have a fully functional nuclear kind of like medicine department, because if you don't have it in functional nuclear medicine, then it's very, very, very difficult. And then the second thing is, you know, that if you then do the indocyanine green injection, which is kind of like the standard of care, so then you need kind of like this laparoscopic endoscopic local cameras that can be able to pick up this fluorescent dye, and basically we don't have that. So I mean, before you ask me your question, what I wanted to say was, this is kind of like the frustration that kind of like we face in gyno-oncology, that the world is moving at a very, very fast pace, and we know what's supposed to be done. I've got sentinel lymph nodes in Cape Town. We're doing them for vulva, so it's something that can easily be done if you've got the right equipment. But at this moment, we don't have a functional CT scan at Pari. We don't have a functional MRI scan at Pari. So what we're mostly talking about here can be done for some private patients, but not the bulk of women that were meant to treat at Pari. And we don't have availability of the nuclear medicine and all those other things to support the use of sentinel lymph nodes in endometrial cancer.
Thank you.
Okay, thank you, Dr. Kusha, for that answer. In the chat box, we have a question from Daniel's iPhone. What's the accuracy of preoperative histology from Propel, i.e. the grade and type, chances of grade and type changing with final histology post-operative?
Okay, I think I had a slide on that. So basically, if you, the first question is a people comparable to a DNC? I remember I gave a talk about dead and cremated some time back, but I think there's enough data showing that a PPL is not inferior to a DNC. But however, so regardless of how you do the endometrial sampling, it's going to underestimate the histological variant in about 4% of women, of cases. And it's actually going to underestimate the grade in 9% of cases. So in other words, in 4% of women, it's going to say grade 1, and you do an MRI, it's less than 50%, and then you say, okay, this is a low risk, no lymph node dissection. But then when you do the final staging, it comes out as grade 3. So when you come to the tumor board, these are kind of like things that are happening all the time, where there's a change between the preoperative and the postoperative staging. And I mixed up histological type. I wanted to say in 4% of the cases, it tells you that it's in endometrioid. You then do the operation using that. So it's endometrioid less than 50%. You do the operation saying it's low risk, you skip lymph node dissection, and the final histology comes back and says it's a uterine serous carcinoma, poor prognosis, lymph node dissection was supposed to be done to finalize the staging. And you've kind of like done suboptimal operation for the patient. In about 10% of these patients, it's going to tell you it's a grade 1, grade 2, or it's going to, and you don't do lymph node dissection, the histology comes back, or it's find that it's a grade 3, or it tells you that it's a grade 3, you then do the operation, and the final histology is grade 1 or grade 2. So this is precisely the reason why there is more and more use of the sentinel lymph node biopsy, because it allows you to be able to assess the lymph nodes in all the patients. So much so that if there's a problem, if there's been underestimation of the histological subtype or an underestimation of the histological grade, it doesn't matter, because we have fully staged the patient using the sentinel lymph node biopsy. So I think there are definitely problems of underestimation when you do the when you use preoperative histology.
Okay, thank you very much. I believe you've been answered. Prof. Chipato, I can see you're raising your hand. Please go ahead.
Thank you, Dr. Guja, for a very nice talk. So when you do the sentinel lymph node excision, does that mean you then do frozen section of that lymph node, of those lymph nodes?
So initially you do frozen section, because if there's obvious involvement, then you pick it up. So you need that to be supported by frozen section. But then when you've done the frozen section, then the lymph node is then taken for what we call ultra staging. So ultra staging, they are now kind of like using very, very thin slices. So there's a specific protocol that pathologists are supposed to follow. So unfortunately, you can't do ultra staging on the same day. So these results have to come on a later date, where you then employ ultra staging as well as immunohistochemists, then to be able to pick up isolated tumor cells or make micrometastases that might be missed if you do the normal histological assessment. So yes, to answer your question, Prof, you need frozen section in theater, and if lymph nodes are definitely involved at frozen section, you just kind of like remove the enlarged lymph nodes for staging and spare the patient morbidity associated with a systematic lymph node dissection.
Okay, thank you very much. I do not see any other raised hands, and the chat box does not have any other questions. So if we are all happy and we've been answered, and we appreciate that preoperative assessment is important in determining or assessing the risk of the patient, involvement of histology and the pelvic MRI, then I believe we'll be able to do justice to our women, appreciating that there are shortfalls to this, but it improves our ability to see which women would need lymph node dissections and which ones do not. Thank you very much, Dr. Mvere Chatora, for your wonderful presentation and taking the time to be with us this afternoon. Thank you also to Dr. Guja for the detailed presentation that he gave us. Our time is now 13:25. We will meet at 2 p.m. We can have a lunch break, and then we'll meet after lunch for the next segment. Thank you very much.
Thank you.
Okay, thank you very much, Dr. Makoti, for hosting the session. So as she said, let's try to be on time so that we start right pronto at 2 in the afternoon. So yes, let's see you around 2 for the last session, exciting session for the fetal medicine department. Thank you.
So ngiright njani? Ngiright njani? Njani umsebenzi?
They don't do that.
Afternoon, ladies and gentlemen.
Afternoon, everyone, and welcome back for our last session for the day. And the thematic session is being presented by the Fetal Medicine Unit. I'll quickly ask Dr. Due, who is chairing, to take over the proceedings. Thank you.
Thank you, Dr. Bismarck. I hope I'm audible enough. Can you hear me?
Yes, we can hear you loud and clear.
Thank you. So good afternoon, ladies and gentlemen. Welcome to the fourth and last session of our first quarter scientific meeting. I'll be chairing this session from the Fetal Medicine Unit. I'm Dr. Dube, I'm in Bulawayo. Thank you to everyone who's been with us since 8:30 in the morning, and welcome to those who may be joining us for the very first time. As you may be aware, the Fetal Medicine Unit has been in existence for a couple of years now. A lot of lessons have been learned and a lot of experiences have been gained. So today's presentations will give us some of those experiences, from outcomes of fetuses with absent or reversed end-diastolic flow to outcomes in fetuses and twins with selective fetal growth restrictions, to cervical stitch failure and the various management options. We'll get all the presentations at once, one after the other, and then have some time for discussion thereafter. So it is my pleasure, again at this time, to call upon our first presenter, Mr. Ezanga, to give us his talk. Over to you, sir.
Thank you very much. Let me try to share my screen. Can I be allowed to share the screen by the host?
Yes, I can see your screen, but you may need maybe to put it on PowerPoint.
Oh, okay.
Yes.
Can you see the slides now?
Yes, we can see the first slide.
Excellent. All right, thank you very much for the privilege of giving this talk. I would like to share the experiences which we have had since the inception of the fetal medicine in Zimbabwe just over 2 years ago. Okay, so it has been a privilege and an eye-opener to be part of the fetal medicine team. For the 2 years since the return of Dr. Verenga from the UK, and he has been selfless to share with us the great wealth of knowledge and exposure, so that we are now scanning almost at an acceptable level with the world, because we have adopted the Fetal Medicine Foundation guidelines and protocols, and adapted some of them to suit our local needs. So I hope after this talk, we will be at a better level, both as the sonographers, the fetal medicine team, the managing obstetricians, as well as any other interested stakeholders. So this issue of fetal growth restriction has some key issues which emanate from the diagnosis, especially in the high-risk women. We know we've got a very high burden we've got a very high burden of preeclampsia in sub-Saharan Africa. And usually these women have got a strong association and likelihood of developing fetal growth restriction, which itself has got some not so good perinatal and maternal outcomes. So in that background, it is imperative that we have some surveillance tools in place which will assist in monitoring these women who are at high risk. And these surveillance tools include Doppler studies, biometry, which is done every 2 weeks to assess growth. And if we are talking about the vascular studies, that's the Doppler. We are mainly looking at the umbilical artery Doppler, ductus venosus Doppler, middle-cerebral artery Doppler, as well as the uterine Doppler assessment of the mother. So it also includes biophysical profile as well as cardiotocography, which we currently don't have in our units. So what are the surveillance goals? One, to assess the risk and extent of hypoxia or acidosis, which is a common outcome in these growth-restricted fetuses. Want to assess the risk of stillbirth. Want to assess the rate of clinical deterioration, as well as planning when soonest or latest the next visit or next appointment should be done. And most importantly, to decide on the timing of delivery. We don't want to deliver the fetus too early. We also don't want to deliver them too late. So the main outcome becomes the timing of the delivery. So here are the surveillance tools which are available. We've got biometry and centiles, and we usually use the 10% mark. Anything less than 10% of the fetal weight, if the estimated fetal weight is below the 10th centile, then we are saying we've got fetal growth restriction. It's more for gestational age, but since we're a high-risk unit, we tend to be biased towards being on the cautious side. So just our protocols say if the estimated fetal weight is below the 10th centile, irrespective of the Dopplers, it becomes fetal growth restriction. When the Dopplers kick in, then we can have fetal growth restriction with abnormal Dopplers, or we can have fetal growth restriction with normal Dopplers. So we assess the umbilical artery, the middle cerebral artery. We also assess amniotic fluid, as well as the ductus venosus. Then if there are abnormalities, which is our main focus for the talk today, we have a scenario whereby you can have absent and diastolic flow, like the case on this image here, whereby there is no flow on the diastole, or it can be reversed in the umbilical artery. Then here you can see this is the ductus venosus. Here there is a significant decrease in the A wave, which is associated with the high PI, or demonstrating resistance at the level of the heart. Then here you can see that there are some aspects which are showing some reversal on the A wave here, which is not a good sign. Then here, that's the biometry. showing us the estimated fetal weight here and the individual as well as the vascular. And you can see here it's demonstrating that they are below the 10th centile, which is in keeping with fetal growth restriction. So the way the management is done is no longer just stepping in the dark, but it's guided by extensive research, which has mainly been done by the Fetal Medicine Foundation, as well as other gurus in the world of fetal medicine. So when we have got early onset fetal growth restriction, which we categorize as the one which is below 32 weeks gestation, we can have a scenario whereby you can have fetal growth restriction, implying that the estimated fetal weight will be below the 10th centile, but the Dopplers, all the Dopplers will be normal. In that instance, we do surveillance every 2 weeks. Scenario number 2 is when we've got fetal growth restriction, but you've got either or both a high PI in the umbilical artery above the 95th centile, or a low PI, which we term redistribution or brain sparing less than the 5th centile. If we've got this scenario, we don't scan them every 2 weeks, but we increase the frequency and scan them every week for Doppler, then every 2 weeks for growth and Dopplers. Then scenario number 3, which I highlighted in red, is our main focus, as I'll be presenting the statistics in a bit. So in this scenario now, we've got fetal growth restriction with abnormal Dopplers. And this time we've got either absent or reversed end-diastolic flow in the umbilical. But when it is below 32 weeks, we will not use the absence or reversal of flow in the umbilical as a determinant for delivery. But we will make sure that the surveillance is no longer weekly or fortnightly, but it becomes 3 days. Why? Because below 32 weeks, our main focus, or the one which determines the decision to deliver, is the ductus venosus. And as long as the ductus venosus still has some flow in the airway, we will try to continue pushing the baby inside so that they gain more weight, and it will actually improve their outcome. And also locally, our neonatology units specified that the fetuses should have at least reached 1 kg or 1,000 grams in order for them to be successfully given an opportunity to be ventilated. Why? Because we've got I think everyone knows that we've got a crisis in the country in terms of the equipment. We've got very few ventilators, and usually if we've got possibly a 700-gram baby and a 1.5 kg baby who both need ventilation, they will give priority to the 1.5 because they've got a better chance of making it. Okay, so how do we reach the decision to deliver before 32 weeks? As I said, once we have absent or reversal of flow in the ductus venosus, then we will recommend agent delivery within 24 hours, definitely after administration of antenatal steroids and magnesium sulfate. This is informed by the TRAFO study, a very massive study which was done to prove that the ductus venosus, as long as it still has positive flow in the airway, we can still have the baby inside, but keep monitoring it every 3 days or even more frequently. Okay, here it's an image of the deterioration of the umbilical artery. You can see that it's reduced in diastolic, it's continuing to reduce, it's now absent, and it's now reversing. Here is the ductus venosus, reduced airway, reversal, and even deteriorating further. So once we've got this stage or the absence, then we recommend delivery within 24 hours. After 32 weeks, because they would have gained at least sufficient weight, then once we have got reversal, once we have got a reversal or absent end diastolic flow in the umbilical, we will deliver. I think you can appreciate the difference before 32 weeks and after 32 weeks. And it has to do with the weight dynamics. So once we have got reversal or absence of end diastolic flow in the umbilical, we will recommend delivery. And if the fetal growth restriction is there, just the biometry, which is abnormal, and the Dopplers are normal, we aim for delivery at 38 to 39 weeks. So why is fetal surveillance important? Research has shown that small for gestational age fetuses who undergo surveillance and timely delivery have a 4- to 5-fold reduction in mortality and or severe morbidity before birth. Okay. So now I'll give a summary. This is still work in progress. I'll just give you the preliminary data, which is not so good. I think it will be a wake-up call for us, I think, to all work together towards trying to avoid what can be avoided. So in this data, we had 48 pregnant women or fetuses that we scanned in our fetal medicine units. And all these had 35 of them had absent end diastolic flow and 13 of them had reversal flow in the end diastole. And amongst these 48, we managed to get some outcomes of 17, which I'll be talking about. The others are work in progress. I think in the upcoming meetings, we'll also present once we get more information. So now talking about the 17 babies which we managed to get the outcomes, who had absent or reversal or flow in the umbilical artery. 8 of them are alive, but unfortunately, 9 of them are demised in one way or the other. 1 was a fresh stillbirth, 5 were macerated stillbirths, and 3 were early neonatal demises. So just to get a little bit more information from the outcomes which we collected, as well as the data of the scans which we did, as well as the clinical history which we collected. So all these women, we actually gave the green light or the alert for decision to deliver after the reversal of flow in the umbilical artery or absence of flow on the diastole, as well as, so when it's, as you can see, the majority of them are below 32 weeks. So this was in combination with also an absence of a wave in the ductus venosus. So when they first showed up at the fetal medicine unit, these were their gestational ages, 37, 33, 27, 27, 28. And by the time they delivered, we were actually carrying out some surveillance, and you can see that we managed even to get 5 more weeks in some of them, some 3, some 1, depending on how the Dopplers were behaving. And most of their birth weights were above 1,200 grams, and all their APGAR scores were both above 7, except 1, this one which had 5 and 6. And all of them were admitted in the NICU with varying durations from 4 days to a month And 3 of them actually required ventilation after undergoing respiratory distress. So these ones are still alive. However, the sad part has to do with this group. So on this group, we didn't have much contact with them at the fetal medicine units because they came and I think their Dopplers were not in good shape. The 1,000 gram mark, which I mentioned earlier on. Unfortunately, most of them couldn't be attended to in the theaters, and they ended up delivering spontaneously by the normal vaginal delivery, and they delivered macerated stillborn babies. One of the babies had an emergency cesarean section, was put in NICU, had good weight, but unfortunately they also had early neonatal demise. And these other 3, this one, I think the weight issue, which I mentioned earlier on, they were not prioritized to be admitted in the neonatal units. You can see the other one at 800, 700, and 701, and the Dopplers had reached a point of no return. And these 2 actually were given birth whilst alive, but they were not admitted. And the outcome which we got is they ended up demising the neonates. So what are some of the lessons to be learned from these scenarios? Close monitoring of early onset fetal growth restriction babies is very possible in the advent of ultrasound and Doppler ultrasound and proper training in actually taking the Dopplers as well as interpreting the results. So fetal Dopplers actually play a pivotal role in this process of surveillance. However, I think the main thing here has to do with this 3rd bullet. When the ultrasound results from the biometry and the Doppler are pointing towards a need for delivery to be effected within a short period of time. So if we've got such a scenario, it is imperative for proper coordination between the managing obstetric firms at our hospital, at our maternity hospitals, as well as the neonatology team, so that we don't have the scenario of those first 4, 5 fetuses, which are neonates, which ended up being delivered as MSBs. Why? Because either possibly there was no proper coordination, or possibly there wasn't real agency which was given to the state in which they were in. And it is imperative for all hands to be on the deck, because in Zimbabwe, we've got high perinatal mortality and maternal rates, as in the reports by the Ministry of Health. So for us to lower those maternal and perinatal mortality rates, we need proper coordination of the various stakeholders. And it's imperative for sonographers and those who would have done scans, or the GPs, everyone involved, to timeously refer these high risk and these critical cases to the next level. The fetal medicine units at Salem Gab and at Parenyatwa are very much open to assist, but it has to be timeous, because if they come too late, no miracles can be done. But if they come in good time, it can help in making sure that they have got good outcomes. So whenever we come across these patients, so this is a plea to both the obstetricians and also those who are performing the scans to assist in making sure that timeous intervention is performed. So these are my acknowledgements of the fetal medicine teams at Salem Mugabe and at Mbuyane Handa. Thank you. That concludes my talk.
Thank you very much, Mr. Zanga, for such an insightful presentation where you took us through the goals of surveillance, the surveillance tools, and other key issues in fetal growth restricted babies, and also for the local outcomes and the data that we're able to show us. And I want to thank you specifically for the call, and to everyone who's listening or who's in this meeting, for the call to have all our hands on deck so that we're able to reduce the high perinatal and maternal mortality rates in Zimbabwe. So thank you very much for our pediatricians who are on this meeting. We'll have an extensive discussion soon after all these presentations. Thank you very much. So again, it is now my pleasure to call upon our second presenter, Dr. Ndagurwa, to present on the outcomes of fetuses in twins with selective fetal growth restriction, the FMU experience. It's over to you for your talk. If the admin could allow them to share their screen so that they can present. Thank you.
Oh, okay. Afternoon, everyone. I'm Dr. Ndagurwa from the Fetal Medicine Unit Department. I'm going to talk about outcomes of twins with selective fetal growth restriction. So, selective fetal growth restriction can affect monochorionic twins, as
Sorry,
we can.
Dr. Ndagurwa, my apologies to interrupt you, but we cannot see your slide for the presentation. We are only seeing I think is it your desktop? If you could put it on slideshow, your presentation, that would be helpful. Thank you.
Okay.
Dr. Nagura, sometimes you might just need to unshare and reshare. It does happen sometimes.
That's okay.
Much better. Thank you. We can now see it. You can put it on slideshow.
Okay, that's fine.
Thank you.
So my talk is on outcomes of twins with selective fetal growth restriction. And I had mentioned earlier on that selective fetal growth restriction can affect monochorionic twins, like what is shown in this image, where we have a single placenta, two fetuses, and one of them is looking smaller than the other one. So this is in a monochorionic pregnancy. And in this image, we can see that we have two different babies, and each with its own placenta, but we can see that the one on the right is smaller than the one on the left, and this is selective fetal growth restriction affecting a dichorionic pregnancy. It can also affect triplets, and in this image we can see that we have a dichorionic triamniotic triplet pregnancy, with one of the triplets having its own placenta, and two of the triplets, let's say this is triplet 1 and triplet 2, they are sharing the same placenta, and so they are having a monochorionic relationship. And we can say we can see that triplet 2 is smaller than triplet 1, which shows that selective fetal growth restriction can also affect triplets. So for monochorionic twins, selective fetal growth restriction can affect up to 15% of those pregnancies. And what will be happening in monochorionic twins is that we have a single placenta, like what is shown in this image. And on this image, we can see that we have two different codes inserting on different places on the placenta. So we'll say this is the code for twin 1, and this is the code for twin 2, and they are having a monochorionic relationship. So in this image, we can see that the code for twin 2 is well established with good and healthy blood vessels, and the territory for this code is getting up to about 75% of the total surface area of the placenta. Whereas for twin 1, we can see that the blood vessels are smaller and the vasculature is not as established as it is for twin 2. So this twin is the territory of twin 1 is occupying less than 25% of the placenta. And what it means is twin 1 is getting less oxygen and nutrient supply, and that will result in selective fetal growth restriction. So on ultrasound scan, we diagnose selective fetal growth restriction for monochorionic twins when one of the fetuses or one of the twins is small and the estimated fetal weight is less than falls below the 5th centile, and the other twin may be having normal growth, and the discordance between the twins, the discordance of the estimated fetal weight should be greater or equal to 25%. So we have two fetuses. One of them has a weight whose centile falls below the 5th percentile, and the other one is growing normally, but the discordance between the two is greater or equal to 25%. and the amniotic fluid in the smaller fetus is reduced, and in the bigger fetus, it should be normal. So for dichorionic twins, we diagnose selective fetal growth restriction when the estimated fetal weight of one of the twins is falling on a centile that is less than the 10th centile. This is according to ESOG. And according to the Delphi procedure, we can diagnose selective fetal growth restriction in dichorionic twins if two of the following are present. That is, if we are having one of the twins with an estimated fetal weight centile that falls below the 3rd centile or the 10th centile, or when we have an estimated fetal weight discordance of greater or equal to 25%, or a high umbilical artery pulsatility index of greater than the 95th centile in the smaller twins. So selective fetal growth restriction in dichorionic twins, the disease process is sort of different from what happens in monochorionic twins. For dichorionic twins, it's more of placental insufficiency in one of the placentae, and it has been noted that there's a higher incidence of preeclampsia in dichorionic twins versus monochorionic twins with the similar diagnosis of selective fetal growth restriction. For the classification of selective fetal growth restriction, it is according to the Doppler findings of the end diastolic flow in the umbilical artery of the smaller fetus. So we say it's type 1 when the end diastolic flow is positive, type 2 when the end diastolic flow is absent or reversed, and it's type 3 when it's cyclical, that is when we have positive, sometimes we have positive flow, sometimes it's absent, and on some of the parts of the same waveform, there's reversal of flow. So we can have selective fetal growth restriction with superimposed twin-to-twin transfusion syndrome, and this occurs in monochorionic twins. So this is noted when there's a discrepancy of greater or equal to 25% in the estimated fetal weights, and there is polyhydramnios in the sake of the bigger twin. Remember, I said for selective fetal growth restriction, we have reduced liquor volume in the smaller twin and normal liquor volume in the bigger twin. But when it becomes superimposed with twin-to-twin transfusion syndrome, the discrepancy is still there, but in the bigger twin, there will be polyhydramnios. So in our unit, we have a protocol that we use, and we have always suggested that it's better for twins to be managed within the fetal medicine unit, where there is a protocol that is followed by all the sonographers and consultants in that unit, and it will always improve the outcomes of twins and other pregnancies with a high risk of poor fetal outcomes. So for the twins, on presentation, we do a detailed ultrasound scan examination. On that examination, we'll be checking for fetal abnormalities. We label the twins, we check the fetal growth, the Doppler studies, and we also screen for preeclampsia. So if it's a monochorionic with no complications, we see them every 2 weeks, checking the growth, amniotic fluid, and the Doppler studies as well. If it's a dichorionic, we see them every 4 weeks, doing the same things. And on diagnosis of selective fetal growth restriction, if the Doppler studies are normal, we see that patient every 2 weeks, where we'll be monitoring growth, checking the Doppler studies, and measuring the amniotic fluid using the single depaced pool. For the Doppler studies, we check the umbilical artery, the mid-cerebral artery, and the ductus venosus. So if we then note abnormal Doppler studies, we then see that patient every week checking the Doppler studies, and then after every 2 weeks, we check the estimated fetal weight as well, so that we know if the babies are growing or not. And then on every visit that we measure the fetal weights, we do calculate the inter-twin estimated fetal weight discordance. So far we have scanned in excess of 300 twins, that is the dichorionic and monochorionic, and about 10 triplets. Of the 300, about 68% of the twins are dichorionic and 31% are monochorionic. 11% of the twins who are dichorionic were noted to have selective fetal growth restriction. And this sort of value is in keeping with international figures that quote about a figure of about 10.5% as prevalence of selective fetal growth restriction in dichorionic diamniotic pregnancies. For monochorionic diamniotic, the prevalence in our cohort is about 14%, which is also in keeping with a figure of about 13%, which is quoted in literature. So for the dichorionic twins with selective fetal growth restriction, in the patients that we saw, the diagnosis was made at an average gestational age of 30 to 33 weeks in dichorionic and 26 to 27 weeks in monochorionic twins. We noted a significant disease progression in these twins of about 48% in dichorionic and 60% in monochorionic twins. And for dichorionic, the disease progression occurred over about 5 to 6 weeks and 4 to 5 weeks in monochorionic twins. We noted that the average gestational age at delivery of dichorionic twins with selective fetal growth restriction was about 35 to 36 weeks, and that for monochorionic twins was about 32 to 33 weeks. So we noted that monochorionic twins with selective fetal growth restriction have an increased risk of severe prematurity, having low APGAR scores at delivery, and also having very low birth weight. Whereas for dichorionic twins, of course, the risk of prematurity, low APGAR, and low birth weight is higher than in dichorionic without selective fetal growth restriction. We noted that the risk is actually lower as compared in monochorionic twins. So dichorionic twins with selective fetal growth restriction, they tend to be delivered at a later gestational age compared to monochorionic, and prematurity, low birth weight, and low APGAR score rates are sort of lower than in the monochorionic twins. Almost all the twins that were diagnosed with selective fetal growth restriction end up in the neonatal unit, and we noted that the risk is actually higher for monochorionic twins because they are smaller and they tend to have more severe disease. After admission to NICU, we noted that monochorionic twins have a higher risk of having severe morbidity, and we ended up losing about 40% during the early neonatal period. We also noted that the hospital stay, the NICU admission for monochorionic twins was longer by about 2 days than for that of dichorionic twins. And monochorionic twins have a higher perinatal mortality. Dichorionic twins with selective fetal growth restriction have a higher perinatal mortality than dichorionic twins without selective fetal growth restriction. Thank you.
Thank you very much, Dr. Ndagura, for an excellent presentation where you took us through selective fetal growth restriction in twins and the way you managed to walk us through selective fetal growth restriction in monochorionic twins, also in dichorionic diamniotic twins. And you're also able to give us classification, the protocols that are in use in the fetal medicine unit, and also your experiences. So I'm sure a lot of questions are going to arise from these experiences, and we'll entertain those during our discussion section. So allow me to call upon our third and last presenter, Dr. Verenga, who's going to talk to us about cervical stitch failure and these management options. I hand over this time to you, Dr. Verenga. Thank you.
Good afternoon. Sorry, forgive my hoarse voice. I'm having a flu. So the reason why I've decided to talk about this topic is because of my experience, or the experience that I and the team are having in the fetal medicine units, and I thought it's a topic which I want to share with you, so that maybe we can all walk in the same path, because currently we may not be walking in the same path in some areas, which I want to highlight. Cervical stitch failure, I was never taught that a stitch will fail and will need some, you need to do something about this stitch. Normally, we would just insert a stitch and walk away, and we told the woman to come to and see us in the ANC and palpate the tummy and be super happy that the woman is still having a baby inside. This is the kind of practice before I did fetal medicine that I was doing, and this is what I was taught. But today I want to show you another angle of the stitch. My talk is mainly on the stitch. I'm not going comprehensive preterm based screening or other forms of treatment, but you are more than welcome to ask those questions at the end if you have any questions related to preterm birth. Why preterm birth? We know that is the leading reason why babies in our country die. However, the unfortunate part, I know some colleagues contributed to the guideline, which you are seeing the picture there. Unfortunately, this guideline, the only statement it mentions about preterm-based screening is to do with giving antibiotics to women with probably symptoms of urinary tract infection or lower genital tract infection. That's probably the only, or let me say, the only sort of preventive intervention that is mentioned in that book. Then the Bible of our students or our trainees who pass through the unit, this one, doesn't mention anything about preterm-based screening. What it does is that it only mentions the management, the reactive obstetrics of the old is all what it does. That blue book there, which is more of the Bible of all this of our doctors in this country. It mentions nothing about prevention, about screening, of the biggest problem of why babies don't go home in our country. So, however, internationally, there are guidances, which I believe we are using at specialist level in our own private practice. And also these guidelines, they are not written anywhere in the walls of our labor wards, but somehow women are just being given stitches without any proper written guidance to say, if you give the woman the stitch, then what? What do you do? It's not clear. So these guidelines, the three of them, well, they are all talking about the same subject. I just want to show you how much they may not agree with certain statements. Let's look at the history indicated, the prophylactic cyclage. The ACOG says you just have to wait for 1 second trimester loss, and that's it. Go and put a stitch. Of course, there has to be some history of painless cervical dilation in the absence of labor or rupture or prior cyclage due to painless cervical dilation in the second trimester. Then you go and put a stitch. The RCOG doesn't encourage you to go and put a stitch into one. Neither the Society of Obstetrics and Gynecology of Canada, I think I might have made a mistake there. Then these two, they say you have to wait for 3 of them. Then after that, then you can consider putting a stitch. They all agree that put it around 12 to 14 weeks. Then they all agree again that if you are seeing a woman with a singleton pregnancy and they have a history of spontaneous preterm delivery, and somehow the person who you asked to do the scan, they did a cervical length assessment and it's less than 25 millimeters, it's less than 24 weeks, they say go ahead and put a stitch. I know that nationally, women are not being done routine ultrasound assessment of their cervix. So that most people who order in a normal scan, they do not even order cervical length assessment. If they do order, it's done from the tummy, that is transabdominal instead of transvaginal. So probably this kind of indication applies to very few people in our country because cervical length assessment is not being done to the majority of women. They also have what they call physical examination indicated, which we call the rescue cyclage in most of the cases. They say if the cervix is 4 centimeters or prolapse, this prolapse of the membrane beyond the os, external os, a senior obstetrician should make the decision of whether to put or not. That's what the Canadians say. The ACOG and the RCOG and NICE, they are fight on it. They don't tell you what to do. Then what the ACOG and RCOG, they will go on to say if technically feasible and singleton, rule out uterine activity and intra-amniotic infection first, then you can go ahead and attempt to put a rescue cycle. So these are the guidelines, more or less speaking of the same patient who will be in front of you. Then the abdominal cyclage, which we don't do, which probably at the end of this meeting, I want to encourage us to think about it. Consider with cervical insufficiency in the previous failed cyclage, they all agree that it should do it. Then consider a previous trachelectomy only the ACOG and the Canadians do agree with that. The RCOG doesn't mention anything to do with that. In terms of removal, I will show you some of our cases because this is where the context is. To say, in terms of removal, what do these guidelines say? They say if there's established preterm labor, to minimize trauma of the cervix, the RCOG says remove it. Then the Canadians and the Americans only say remove if there is painful contraction or progression of vaginal bleeding. If preterm labor, then the Americans say remove it. Then the Canadians say if the woman is unresponsive to chocolysis or a strong suspicion of sepsis, then remove the sacrilege. I didn't go exhaustive in comparing the guidelines. I've cherry-picked what I want to dissect in my presentation today. Some may not be aware that a short cervix has already been, one of my image disappeared there. Right. Short cervix has already been studied. It's now years and years that people have studied. And one thing that has come out of studies is that women with a short cervix, especially those with a cervix of less than 15 millimeters, they will benefit from inserting a stitch. If the cervix is less than 50 millimeters, this was studied in women with prior history of preterm birth. But the same information can also be translated to women who are not yet to have a short cervix on routine anomaly scan. So there is benefit that if you pick up a woman with a short cervix and you are able to apply a stitch, you will improve those who are born before 35 weeks. So the birth rate at 39 weeks was improved in this study. So there is a benefit in checking the cervix and doing something about it. One of the two papers do not tell us that the three guidelines, they may not tell us what we should do to these women once we have inserted the stitch. There are some studies, they may be small studies, but these studies, what they've shown is that the distance between the funneling for those with the funnel cervix to the stitch is very important. So that if you follow up that distance between the funnel to the stitch, if there's a shortening or a disappearance of that distance, that will predict preterm birth, that the woman is likely to fail the stitch and is likely to deliver prematurely. Again, this has been assessed again in another small study where they looked and measured this, we call it the pre-stitch length, some call it the pre-sacrilege length, to say the length between the sacrilege and the internal os, which I will show you on my image just now, is a very important predictor of knowing whether the woman is likely to have preterm birth or to have a failed stitch or not. As a result, because of this information that we know, we have seen that it is imperative that women who have a stitch should have some surveillance of this stitch to see whether this stitch is losing its effect or not. The question is, this is the women that we have scanned from second trimester. We have scanned 4,490 women from second trimester onwards. I didn't put data for first trimesters and early pregnancy. And out of these, we have seen that short cervix was as common as around 15%, and it was getting up about 361 women. Most of them were coming for the anomaly scan, and others were for all these other indications, including multiple pregnancy. From what we heard Dr. Ndagura presenting, we do cervical length assessment for all multiple pregnancy in their longitudinal follow-up. Then out of the short cervix, 73% of them was in singletons, and the cervical length that we done, 73 were in singleton, and those short cervix were about 12%, almost 13% of women at short cervix. So when we looked according to trimester, we noted that only 32% of them were second trimester. So in other words, 11 out of the 34 cases. Because of the few number of our short cervixes, we couldn't come up with meaningful trend on that data. So what I've done is I've cherry-picked certain cases that I think will speak a message which I want to highlight in this presentation. This is an example of one of our women who came to us because she had a history, indicated cerclage. She was 21 years old, para-O. She had 2 previous second trimester miscarriages, and the history indicated cerclage was done. It was almost towards 16 weeks. So all women who come to us in first trimester to have the fetal assessment before this, the cerclage, we told them to come and see us after the cerclage because we believe we should put them on surveillance because of those 2 studies I showed you, that there is a value in monitoring what you call the pre-stitch length. And for this woman, when she came to see us, we noted that she defaulted her other reviews. She didn't come. She only presented the anomaly scan at 21 weeks. So when we did the cervix, you can see the stitches here, that there is 1 stitch, there's 1 stitch, and these are membranes now bulging. So this is a classical stitch failure. She had a stitch inserted, but this stitch has failed to hold things in. You can see that the membranes have gone beyond the stitch. And in terms of how then should we access the cervix, or how are we doing it? Because people may wonder, how are these guys assessing the cervix? The guidance of doing it were actually written by Kagan some years back in 2015, when he recommended that the woman should be in lithotomy. We don't put them exactly in lithotomy, but we modify the lithotomy. Then we ask them to empty the bladder. Then we get the longitudinal view of the cervix. Then we identify the cervical canal and surrounding mucosa. Then we magnify the image to 75% of the screen, and we avoid pressure on the anterior cervical wall. Then we place the calipers on the internal and the external os. This is how the image normally looks like. So we just make sure that there's not too much pressure from the probe there. Then we put the caliper at the internal os and the external os. Then we measure, as it is illustrated on this one of our images there. Then in terms of the placement, this is another issue which probably is not very clear from the publication. Begela and also Miroshinesco, they made some recommendations some years back where they were arguing that the stitch, when you apply it, you should apply it as very close to this uterocervical fold as much as possible, viscocervical fold. You know where the peritoneum folds on the cervix, where the endocervix continues. So this is their suggestion that it should be put somewhere there. If you are applying a Schroedinger, probably you may put it a little bit higher because you would dissect all this layer to put it a little bit higher. But most of the McDonald, which is being done, where you don't have to dissect anything, there are recommendations that we put it somewhere here so that it looks something like this. However, evidence is not proven that the post-stitch is any value. The post-stitch is this length here. The pre-stitch is this length. That is from the internal os to the stitch. And the post-stitch length is this length from the stitch to the external os. As you can see from one of our image, you can see that's the internal os, and we are measuring, we are drawing a line between the 2 stitches visible there, 1 stitch there, 1 stitch there. So we draw the line, then we measure the distance from the internal os to the line that connects the 2 stitches. Then, of course, this is the post-stitch length. So studies have shown that the important part, the studies have already highlighted, is this pre-stitch length or the pre-cerclage length is the one that predicts whether we are going to fail in our attempt to prevent preterm birth or we are going to succeed. So this is what we monitor when women come to us for preterm surveillance, say what is happening to the pre-stitch length. So in terms of insertion, we have seen various kinds of insertions. Look at this one. So the stitch is almost at the distal end of the cervix. Somehow we have this subjective feeling that this stitch is not properly inserted. Of course, the literature doesn't have the evidence to argue on the post-stitch length, but the data looked in most of the literature is just for few patients, so that we cannot conclusively say this length indeed doesn't matter. So we sometimes feel there are certain patients where which we have asked to say, please go and get it reapplied so that it's at least at the right place, like we see it in this patient here, that is inserted almost halfway, as recommended by these guys, that here I'm going to insert it, try to insert it as close as possible to the internal os. This is another case again, a history indicated sacrilege. So 33 years old, para 1, 5 second trimester miscarriages, then 1 first trimester miscarriages, a history indicated sacrilege put around 16 weeks. This one succeeded. It's a success case, this one. You can see the pre-stitch length. This one was also done very well. Look where it is in relation to the internal os. Of course, the pre-stitch length looks small there, but the cervix was holding, and the last follow-up was at 34 weeks when you let it go, and then the pre-stitch length was 4 millimeters, and the total was 20, and we're happy that she has arrived at 34 weeks. This is another case, 33 years old, para 0, 2 first trimester losses. Yet team decided to put a sacrilege, probably for this indication. It's not the usual indication, but they put a stitch, and she came to us at 17 weeks. When we saw at 17 weeks, we noted that there is already funneling at 17 weeks. And look at where the stitch is. The cervix is just ending at a very small post-stitch length. And we are beginning to question, to say, yes, the literature doesn't have evidence to say this post-stitch length matters. But some of these women we see with a failed stitch, if you look at the post-stitch length, you see that it has been inserted too peripheral, too distal, almost close to the external os. And already there is evidence that there is failing here. And what we did for this lady, we ordered a reapplication. We actually wrote there to say, look, we think it is too distal. Why don't you go and try to apply it a little bit higher, and then we can assess and see what happens to the overall cervix. Well, a cervical stitch is known to improve cervical length. This is a case with classical stitch failure, which I'm presenting now. She's 23 years old, para 0, 2 second trimester miscarriages, 1 first trimester miscarriages, 1 preterm birth with accompanied with early neonatal death. She had a history indicated sacrilege at 15 weeks after we had seen her for the first trimester. Then at 16 weeks, she came to us, and we noted that there was a little bit of a funneling after the stitch had been inserted, and she only had 5 millimeters of measurable pre-stitch length. And what we did is we gave a progesterone 200 micrograms, and then we prescribed the antibiotics. We asked her to come back and see us 1 week later. And when we saw her 1 week later, we actually celebrated because she had gained a lot in terms of the pre-stitch length, which was now 18 millimeters. This is now 17 weeks. And when she came, it's 19 weeks, we noted that there was now a reduction, a slight reduction in the pre-stitch length, which was now 8 millimeters. Then we asked her to come in, because this is somebody who has been pregnant 4 times, no baby. And when she came at 21 weeks, this is what we saw. We noted that now the funneling has gone beyond the stitch, so that the stitch is no longer holding, and the stitch is failing for this lady. A very difficult case to counsel and to manage. The options in this case were saying, should we talk to the team that put the stitch, say, is there benefit in us reapplying another stitch? She's already on progesterone, she's on a stitch already, but this stitch is fading, and this woman is devastated. Then another case again, 21 years old, 2 second trimester miscarriages, history indicated circulation at 15 weeks. Then she defaulted follow-up, she came at 20 weeks, and this is what we see at 20 weeks. These are the stitch. You can see the open cervix now, and there is no more cervix to talk of. These are membranes bulging with the stitch inside, and she's only 20 weeks. We do have some successful stories where we have rescued the situation through the stitch. So a 36 weeks, 36 years year old lady, para O, she came for a routine anomaly scan referred by a doctor, and we know that there was funneling with a short cervix of 9 millimeters. Progesterone doesn't work well in women with a cervix of less than 10 millimeters. Some may wonder and say, why are you not just giving the progesterone? If the cervix is less than 10 millimeters, progesterone doesn't work. The woman needs a stitch. So the doctor put a stitch around 21 weeks, and also we put on progesterone on top of the stitch. Then we did 2 weekly surveillance. After the stitch, she gained some cervical length. As you can see, she had a pre-stitch length of 21 millimeters. And this is the last review with her. When you saw her last time, she was now 25 weeks. She had this, what you described as a stable cervix, although she had lost some, but this woman went on to deliver at 10. So this was a successful story of rescuing a woman who was at risk. Then para O just referred for a routine anomaly scan, 23 weeks. And when you did the internal scan, because we offer all women routine transvaginal scan, those who come for anomaly, and we noted that she was already bulging into the vagina. We ordered a stitch here, and the stitch unfortunately failed the rescue stitch, and she went on to miscarry at 23 weeks. The other success case we had, the 27-year-old lady, para 0, and she had 4 first trimester losses. Then a routine anomaly scan showed that there was funneling. The doctor did not put a history indicated here. It was an ultrasound scan indicated as a stitch, because when she came, the cervix length was only 17 millimeters. And we agreed with the doctor that I think it's better we put a stitch and put a progesterone as well. So we did that. And we reviewed it 1 week after the stitch, and we can see that she has gained some pre-stitch length of about 17 millimeters, 15 millimeters here. And we continue to follow up every 2 weeks. This lady, in terms of my image, we continued to follow up, and she delivered at 10 after putting a stitch. So the story here is, women who have a stitch, it's not given that the stitch that we have put is going to hold and the women are going to succeed. There are some women where the stitch is failing, and the guidelines that most probably will use are a little bit silent on saying what should you do when you put a stitch. So what we recommend is that if you put a stitch on a baby, whether history indicated, ultrasound scan indicated, or physical examination indicated stitch, refer them for preterm surveillance, where we check for pre-stitch length. So after the circulation, they will need surveillance. What we are doing with our protocol at the moment is that we are offering them 2 weekly surveillance for women who have a stitch until they are around 32, 34 weeks, then you can let them go. At 28 weeks, we are giving all of them antenatal steroids the moment they reach 28 weeks, just in case the stitch failed and they end up delivering preterm without antenatal steroids. The role of progesterone has been shown to work very well in women with short cervix during a mid-trimester scan, a routine anomaly scan. But what we have been doing with women, we have been seeing evidence of shortening of the pre-stitch length. We've been prescribing progesterone. Then we tighten the follow-up. Normally, we ask them to come every week, and we check before we made a decision of the stitch failure. There is a concept of stitch reapplication in the literature. The only reason, the indication for stitch reapplication are two. Number one, if a stitch is come out, reapply another one, or if you feel that the stitch was not applied correctly. I think I showed you some of the cases where we feel that the stitch was too distal, so that a reapplication of the stitch may give a benefit, because you have seen for yourself that the women I have presented here are women who have tried several times and suddenly they have the stitch, but the stitch is put a little bit too distal than we feel it should be. Then the third option is to say, we have a very strong gyne endoscopy team. The best way to put an abdominal stitch is to do endoscopically. I think the gyne endoscopy team, you might need to start looking at offering abdominal stitch for the kind of women I've presented here. Women who have been tried and who have failed, where the stitch is failing. These women are many. I've just given a slip of the iceberg, but these women are many. They are out there, and most of you relate to the stories that I've told you of these women here. So this is what we are recommending, to say, look, the literature is not very clear on how to manage the women with failed stitch, but this is what we are suggesting, and this is how we are going to be counseling the women who come to us with failed stitch, or those we see that there is evidence that the stitch is failing. Thank you so much. I think this is the end of my presentation. I want to thank the wonderful team I work with. Most of the data we present is data generated by this wonderful team during the consult of patients. They work so hard, and they are all amazing people. The midwives, the doctors, the sonographers, amazing people we work with. Thank you so much for doing this. Thank you.
Thank you very much, Dr. Berenga, for such a very insightful presentation on why some of our cervical circular stitches, they fail, and what are some of the management options. And you also suggested to us some care pathways to consider progesterone, stitch application, and also the issues surrounding abdominal stitch for subsequent pregnancy. Normally, we failed a vaginal sacrilege in the past. So thank you very much again for presenting the data from our local cohort of patients that we are following up. And I think, to me, really, this is a call to all of us on this platform that it may be time that we start to evaluate our practice and to self-evaluate possibly the position at which we are inserting most of our stitches, the timing of the stitch, so that we may be able to reduce some of these failures. And I think it is up to all of us to be able to follow the evidence, and also to be able to be guided by research. And I'm happy that most of these images and pictures are actually coming from our own patients that we have in our own setting, and it's not something that we are getting from the books or something that we are getting from the internet. And so once we do that, we are able to probably relate more to these images than we would do if they were from anywhere else. So thank you very much again to our three presenters who have managed to present in our session, and I'll open this floor now for the discussions following these presentations. And then maybe let me start with the chat box. There are a few questions, there are a few comments that I've seen that our colleagues have put there, and we'll try and go through most of them if time permits. So there is on the chat there, I can see that there's Bob Charlomrove who wanted to know whether any of the babies in our outcomes and these experiences that people have shared or our presenters have shared, received any surfactant. So if the presenters are able to answer the question, kindly unmute yourselves and answer the question from BT Murove wants to know if any of the babies received surfactant. Thank you. Is Mr. Zanga still with us? Is Dr. Dagura still in the meeting? If you are, please kindly assist with the answer.
Okay. Yes, you can go ahead, Dr. Vireng.
No. I just wanted to say probably I wasn't seeing Mr. Zanga there, so I wanted to ask him if he's still in the meeting. Go ahead.
So for our government patients, surfactant is almost always out of stock, except for the few patients who are able to buy some. So the supplies of surfactant are very erratic, and it's actually difficult for us to get the information from the nursery so that we know which patient received surfactant, which one did not receive surfactant.
Thank you very much, Dr. Ndagura, for the answer. I hope Dr. BT Murove has been answered. We also have a comment from Hilda Angela Mjuru, who says, thank you for an excellent presentation. NNU and NICU is different. Babies less than 1,000 grams are admitted into NNU, but not in NICU for assisted ventilation. I think this comment follows up on what Mr. Zanga had said. Thank you for clarifying this, Dr. Mjuru. Then we have another comment, it's a question rather from FM Chiora, Dr. FM Chiora, who says, why are these babies less than 1,000 grams not admitted to NICU? Could this be related to poor outcomes? I'm not sure if there's one of our presenters would like to answer the question, or one of our neonatologists who may be present who can be able to help Dr. Chiora on his question. Why are these babies with less than 1,000 grams not admitted to NICU? Could this be related to poor outcomes?
Hi, it's Dr. Alex Stevenson. I'm one of the neonatologists at Mbuya Nahanda. There are many ways to answering that question. I think the simplest is that NICU is closed. Doesn't matter how much you weigh, we don't have a NICU. But that hopefully is a temporary thing. When NICU is open, like any resource limited intervention, it has to be prioritized to those people who would benefit most from it. And answering the question of who would benefit most from NICU intervention is a profound and important question, and I don't know the answer to that. And I'm not aware of a blanket rule that says 1,000 grams can't go to NICU. Clearly, a baby who's 400 grams in Harare is very unlikely to benefit from going to NICU. And so you can see the logic behind the statement, but where that line falls, exactly where it falls, I don't know. And it's also has many other parameters that need to be considered.
Thank you very much for that answer. I hope for Mr. Chiora, you've been answered. There's a comment from Dr. M.G. Madzire to everyone who says theater space is a bottleneck in managing babies with abnormal Dopplers. So advocacy for epilepsy hospitals to congest our emergency list should be stepped up. I'm not sure if Dr. Madzire is still on the meeting to clarify further his comment.
Thank you very much, Dr. No, what I'm just bringing is information on, especially in Harare. These babies, when the cesarean section is ordered, we try to push them down to a level, but there are already other dire emergencies which are waiting for cesarean sections. So they end up waiting for longer than necessary and eventually, or sometimes lose the baby. So we've been trying. There was a time we thought MAP would be working, and we have other routine scissors being done there so that we have less congestion in the central hospitals. I don't know whether that's a similar experience in Bulawayo. Thanks.
Thank you very much for your comment. Yes, I think the theater space is usually very difficult to find in the setting of our limited resources and constrained staffing levels. So yes, indeed, we even in Bulawayo are facing those. I think those some challenges that Harare has. So there's some comments on the chat. I think that Dr. Verenga has already commented on, and Dr. Gwen Chimini says surfactant has been available at Salim Mugabe Hospital at NNU. However, we only have 2 CPAP machines, and I think she's still answering the question on surfactant. There's a question from Precious Mtlanga to Dr. Verenga, who said, if a patient presents at an ultrasound scan department, what is the role of ultrasound scan in stitch failure before referral to the FMU? What is the role of ultrasound scan in stitch failure before referral to the FMU? I'm not sure if Dr. Verenga, you are getting the question and if you are ready to answer. Dr. Verenga is still with us, or even Dr. Ndagura, are you able to answer the question?
I'm around. So, sorry, I was muted. So
okay.
The role is to do surveillance. Like I said, that our protocol, which we recommend that if you put a stitch, because the moment you put a stitch on someone, they're saying this is somebody who has suffered enough. And we are trying to help this person to make it, to at least have take a baby home. So we are saying if we do put a stitch, obviously this is a high risk pregnancy and the stakes are high and against the patient. So we recommend that a 2-week surveillance be done until at least we reach a viability, then the woman can be given antenatal steroids so that no matter what happens, you've at least covered the baby, you've gone beyond 28 weeks. So we recommend 2-weekly surveillance. And what should be measured is not the total cervical length, because it's not the total cervical length that predicts the preterm death. In women, we had a stitch, but it is the pre-stitch length, or what others call the pre-cerclage length, that is important. So the pre-stitch length should be measured and should be monitored. If there is a rapid decrease or rapid shortening of the pre-stitch length, then that woman should be referred. It is normal to see some progressive shortening of the pre-stitch length with advancing gestation. That is normal even for a cervix. A cervix will progressively shorten with gestation. But the rapid change, especially if you begin to lose the pre-stitch length at all, then these women should be referred to the fetal medicine unit so that we can discuss with them the management options that we have just mentioned here.
Thank you very much, Dr. Verenga, for that answer. I will now go to the participants list. I see there are a couple of hands that are raised. And for now, I'll acknowledge Dr. Bothel Tikuja. You have your hand raised. Kindly unmute yourself and contribute to ask a question to our members.
Okay. All right, thank you very much. I think my first one is a comment, then I'll follow up with some questions. So I think the reason why the Royal College and the Canadians recommend 3 or more previous second trimester is based on one of the largest trials that was done, the RCOG trial, where they looked at the question of whether there's actually a benefit putting a cerclage. I think the results showed that the benefit of putting a cerclage was minimal, and the patients who actually benefited from a cerclage in a subgroup analysis were patients who had 3 or more recurrent miscarriages. So I think that I'm not so sure. Maybe you can comment where the ARCO data comes from to say it after one, you can put a stitch. Then I want to just to play a devil's advocate a little bit, Dr. Verenga. I think the assumption here is that every woman who's having a miscarriage is having cervical insufficiency. So you remember, in most units, if somebody is having recurrent miscarriage, they're supposed to be worked up and really find the cause for the recurrent miscarriage. Because some of these patients probably have antiphospholipid syndrome, but you're just kind of like catching them at the end when the cervix is dilating. So I want kind of like to hear your comment on that, about going to do kind of like an invasive abdominal sacrilege on a presumption that somebody has got cervical insufficiency without proper up to exclude other causes of recurrent miscarriages. Because I'm seeing some patients, I'm not so sure as well what's the guidance in the unit as to regards to the definition. Because we are finding some patients first trimester miscarriages having a sacrilege, that there's no indication for that. And the reason why it's going to fail is probably because it has nothing to do with cervical insufficiency. So I'd like to hear a comment about how you sort that out, and you think the management of these patients in the absence of a recurrent pregnancy loss clinic, where you wake up these patients to find the cause before you put in a stitch. My third question, my other question is there evidence to show a benefit in putting a stitch in a woman who's pregnant for the first time with a short cervix? As far as I still remember, maybe I don't remember coming across that data that if you come across a patient with a short cervix with no spontaneous history of with no history of a previous spontaneous miscarriage, that a cervical sacrilege is indicated. Then my last comment, I don't know whether Mr. Zanga is still available. It's kind of like an ethical question. I saw that there were some patients who had a spontaneous, it says spontaneous NVD. Were those patients, most of them were around 28 weeks. Were they in spontaneous labor or they were induced? And then I saw some patients who had elective Caesar weighing 700 grams when we don't have a NICU that's functioning. So basically my question is kind of like an ethical question. How do you decide on the mode of delivery if you've got a 700-gram baby, very poor prognosis, and no NICU available, and how do you decide between doing a Caesar or just inducing since the outcome is very poor? And my other question to Mr. Sanga is, well, if there are lots of referrals for these patients, would you think that there will be an improvement in the outcome, considering that we don't have kind of like, there's no NICU that's available, these babies can't be have the optimum care? Would you think that would translate to referrals would translate to an improvement in the outcome? Thank you.
Much, Dr. Gunja, for the questions. I'm sure if the presenters are still around, they should be able to assist you. Maybe let's start with Dr. Verenga. There are a couple of questions, comments that you need to address. Thank you.
Thank you so much, Dr. Dule, and thank you so much, Dr. Gunja. I'm glad you asked all these important questions. First of all, Dr. Gunja, when I started, I told you that with the fetal medicine unit, we are discovering some very glaring gaps in the way we are managing patients. This is why I started by putting this slide, and I mentioned this book, and I also mentioned that there is no protocol at PARI, at SALI. I'm not sure about Mpilo and UBH that tells people what to do with these cases. So that the way they have been managed, I think it's individual clinician decision, number one. So there's no unit protocol. Because the patient that we see, because we have not established a preterm a recurrent pregnancy loss clinic, because I think other people should do that. But how we come to see the patient, because they are referred to us for ultrasound scan assessment after, whether in preparation for sacrilege or for, then we ask them that they come for monitoring. Because they have already told you that, yes, this guideline don't recommend it, but there are two studies which are small. There are more studies on this subject that have shown that there is benefit if you monitor these women with sacrilege. So we do not have a protocol. We need a protocol. An institution needs a protocol on what to do with preterm birth. Then on the benefits of why do we have to put on a para-O, the data for putting a sacrilege comes from the data that looked at the utility of offering routine preterm surveillance, preterm routine cervical length assessment at the normal scan, where they show that there is benefit. You are going to pick up women with a short cervix, you are going to put on progesterone. But among the women who put on progesterone, those with cervical lengths of less than 10 millimeters, progesterone doesn't work. And there is some benefit in putting a stitch for this kind of women.
How many of them were para-Os from that study?
I'm not recalling from my head, but probably this is information I can supply later. But that's the thinking, to say if the cell is less than 10 millimeters, progesterone is not going to work for these ladies. And what they need is a stitch. Whether they are para-O, para-1, para-2, it's not going to work. Progesterone has been shown to fail. Then the second question which you asked, I think it is to do with the protocols, right? Say, we are trying to build the protocol based on our experience we are having at the moment. I've seen that women who are referred to us for cervical sacrilege, the usual wake up where you are going to do infection screening is not happening for most of the patients. I think one of the limiting factors is that if you take a high vaginal swab, even if you send urine MCS at our central hospital, the results are not coming back. So I'm just supposing that probably this is the reason why the teams that refer patients to us are no longer doing the usual wake up. They send women to us, we look through their notes. In most cases, they are sent to us already the sacrilege, but there is no protocol. But we need a protocol that does infection screen that also wakes them up. But most of the patients that are sent to us, they will have been waked up by their teams, the obstetric teams. They will have looked at them and probably rule out the most likely cause of why the women would be put a sacrilege. I think I was mentioning that this was indicated, this was ultrasound scan indicated. So there is need of a protocol. This is one of the reasons why we are presenting this data, because we think it's a weakness in the system, not only the institutions, but also at the national level. We are not saying anything about preterm birth. So we need the protocol, we agree. I think as far as the question related to me, I think that's what I can say. You may comment if you think I've not answered this satisfactorily.
Thank you very much, Dr. Verenga and Dr. Kuja for that discussion. Unfortunately, in the interest of our time, I'm being reminded by DSG, but our time is running out. But let me acknowledge Dr. Felix Mhlanga. I think he's been having his hand up for quite a while. I think there's a very burning question or comment that he wants to make. And those with burning questions, I will encourage you really to direct them to the FMU after the meeting or in subsequent meetings, so that we may be able to stick to time. So Dr. Mhlanga, please, I'm giving you this time to be our last person to ask or to comment on this in this session. Thank you.
Oh, thank you. I'll be brief, and thanks to the FMU team. I think this is really wonderful when you use local data. My question is related to the pre-stitch or pre-cervical length. I just want clarification from Dr. Verenga whether he is saying if you put the stitch, the pre-stitch length over time will increase as the cervix develops and enlarges cranially. This is what I seem to have heard from him. And is that a reflection of why sometimes you then get refunneling and the stitch appears to have gone away too distally? The second issue related to that is, what does he envisage in the protocol to say you put the cerclage at 16 weeks, for example, and you're following them up at every 2 weeks like he's suggesting. So if we see funneling at 18 weeks or 20, what are we supposed to do? As a comment, I think people will be happy to put intra-abdominal stitch, but I get worried about how it will be removed in the case of an emergency. Otherwise, the idea sounds quite reasonable, and I don't know whether he thinks it can fit into their protocol that they would suggest to us. Thank you.
Thank you, Dr. Mdlana. Studies of stitch have shown that when you put a stitch, you gain some cervical length after putting the stitch. This is one of the reasons why we are asking them to come there. This is an example of a woman who gained some length after the stitch has been put. We can see that here it's very short. Then the stitch was put nicely there, and we also see here the stitch that the woman gained some length. But what will happen during the follow-up? Was during the follow-up, as the pregnancy progresses, what we have, the trend that we have seen with the pre-stitch is that it progressively shortens in the same way that the cervix in those who don't have a short cervix progressively shortens with gestational age. But it doesn't lengthen per se, but it shortens with time. But immediately after the stitch, there should be evidence of having gained a length of the cervix, as we can see on the image. As is also reported on studies of stitch, to say you gain some length on putting, but the most important parameter to monitor is the pre-stitch length, is the one that predicts preterm birth rather than the post-stitch or the overall length.
Thank you very much.
I think you have answered the first part of my question. The next question was you were suggesting that we should follow them up serially. What is the plan to following them up serially? If we see this refunneling, what is the plan?
There are two scenarios here. There's a woman who is progressively funneling. Like I suggested, that there are papers that suggest that probably giving them progesterone as a contingent does help to give them progesterone 200 micrograms on top of the stitch. I think one of the guidelines I quoted there also recommends that you may consider giving progesterone as well on top of the stitch. So that's one reason to say we can prescribe progesterone. Two, it's also an opportunity to screen them for causes of why it may be failing, like infection. We can screen for infection and just make sure there's no underlying infection. There's infection, we need to treat these women. For patients who are now 28 weeks and above, or even around 26 weeks sometimes, depending on the fetal weight, it's an opportunity to start giving them antenatal steroids, because the outcome of a baby who is given antenatal steroids is much better than the one who is not given antenatal steroids. So we can give them the antenatal steroids and then warn them that, look, your stitch is about to fail. So if you do experience pain, don't go anywhere, just be around so that if it fails, you can get the right kind of care. And there are those, that other group, which let me show this image again, which I said, my feeling is, of course, the few studies in the literature, they do not show that there is any role in measuring the post-stitch length, but there are certain stitches which are inserted the way this one is. Where it is too distal, I think these are the women who should be counseled towards a re-application of the stitch in the right place, and then we assess and see what happens, than to just wash them with a stitch that is almost at the external course. So I would say those are the reasons for following up these women, why we are saying we should follow them up and see what happens. And also counsel them concerning the stitch failure, because they need to know that this is what is happening.
Thank you.
Thank you very much, Dr. Mhlanga for the question, and also to our presenters, and also for this session. I think we can all see that the presentations are raising quite a lot of interesting talks, interesting discussions, and therefore we've come to the end of this session. But this does not by any means mean an end to the discussions. We have various other platforms where we can be able to assist each other to carry these discussions even further, and help us to learn from each other, and to improve the outcome of most of our women. And therefore I'll end this session here, and hand over to the SG for any closing remarks and any other housekeeping issues. SG, I hand over to you. Thank you very much to the Fetal Medicine Unit and all the participants.
Thank you very much, Dr. Adue, for holding forth this exciting FMU theme and session. I would like to take this opportunity to just thank everyone for taking part in our first quarter scientific meeting. I would like to acknowledge all the presenters and the tedious work they did in trying to come up with these exciting presentations. I would like to thank our scientific committee as well for working tirelessly and making sure the first quarterly meeting pulls through. I would like really to acknowledge the scientific committee meeting for, I would say, the first time in so many years on our virtual platforms, so to speak, improving and gelling up of all the obstetricians in terms of presentations and coordinations across the country. I think we've managed to sow seeds of significant unity, particularly between, I've heard remember in our first presentation, it was the Harare guys and the Blawayo guys, so to speak. And I'm so happy that we are now really working together in trying to improve our profession. And finally, I would like to thank Vincent for doing a stellar of a job in coordinating and administering all the activities around the preparation for the coming up of this scientific committee meeting. And for all those who still have got burning questions and comments, I will refer you to the various presenters. You can inbox them or directly discuss with them so that some of the issues can also be addressed. I would like to thank you once again for making this program a success, and thank you so much. I declare the meeting to an end. Thank you very much, everyone.